Rajshri Sol Good morning. Thank you.
Good morning, everybody.
Good morning, sir. Good morning, sir. Is it audible, sir?
9 o'clock sharp start చేస్తుండ్రా
Sir, అవును sir.
Good morning, Dr. Joshi.
Good morning, sir.
Morning. How are you?
Fine, thank you, sir.
Am I audible?
Yes, sir.
Right.
So all your students are doing really a great job, sir.
No. You did the job. I learned from my alumni a lot how to behave, how to go about, and all the friendship and affectionate you also adds to our strength. That's right.
Yes.
मैडम कैसे हैं?
बिल्कुल ठीक है साहब. हम हमेशा
हाँ?
याद करते हैं. आप हमारे शादी के रिसेप्शन में यू आर द फर्स्ट गेस्ट. अच्छा है साहब, ये ग्लोबल मीट का आइडिया बहुत अच्छा हुआ.
बहुत अच्छा है, बहुत अच्छा है. बहुत एकेडमिक एंड सोशल.
Both, yes.
एकेडमिक भी अच्छा है.
एकेडमिक अच्छा है, एक्चुअल टॉपिक्स अच्छे हैं. एंड ये अगर कंटिन्यू हुआ तो रेगुलरली एकेडमिक एक्टिविटी के साथ एटलीस्ट वंस इन अ मंथ इफ वी आर एबल टू हैव exchange of thoughts, probably that will be great.
And
Namaskaram, sir. Dr. Raghuram Reddy garu.
Namaste.
Namaste.
How are you, Narasimha Reddy?
I'm doing well, sir. Thank you very much.
A frequent guest of Hyderabad.
Yes.
Hello.
Hello, Narasimha Reddy. How are you?
Good. How are you doing?
Mrs. ఎట్లున్నారు? Family ఎట్లుంది?
Family anta baagunnaru, sir.
How is your child? What is the age of your child now, son?
Yeah, he's 22. He just turned 22.
22. Oh.
20.
What is he doing?
Yeah, he just completed his engineering, sir.
Oh,
Yeah,
engineering.
yeah.
What subject in engineering?
Yeah, chemical engineering. Sir.
Chemical engineering. Why both of you are doctors? He didn't like to become a doctor.
That's exactly why he didn't want to become a doctor. From the very beginning, that is one thing he said, I am not going to become a doctor.
That seems to be the universal phenomenon, actually. Very few doctors' children I have seen, at least, that they don't want to become. Even my children, they said, we don't want to. And they're really doing better than what we could have done economically.
Yeah, but in America, if you look at it, there are 1 in 6 current medical students are Indian. So essentially, that there is a significant proportion of Indians in this field.
Yes, and they are learning quite well and doing really well there, actually.
Yes, yeah.
Yeah.
Pretty.
So, how is the life in USA, Narasimha?
Life, I think, is kind of disrupted at this point in time, as it is everywhere else. But I think one thing is that we are adapting. I mean, one thing about United States is that it adapts fairly quickly.
Yeah.
So right now, I am as busy, or if not a little bit more busy than what I was before the pandemic. And I'm seeing the same number of patients or more number of patients, but I'm doing it mostly from home using the psychiatry, and I go to office 1 day a week. So
have you seen the rise in the neurotics and OCDs after the pandemic?
yeah, I mean the place where we work, there is a significant increase in the depression, anxiety, and all these things. And I deal with mostly people with more serious mental illness type of it, and even there we have our waiting list has increased.
అది ఒకటి మా దగ్గర లేదు అక్కడ వెయిటింగ్ లిస్ట్ అనేది మా దగ్గర లేదు we have got to see everybody who comes. So our OP can be 15-20 patients.
Correct. Yeah, yeah. But there is a downside to that, and
but after pandemic, neurotics చాలా ఎక్కువైపోయినారు, and then OCD people going into more washing and cleaning compulsions. We have 17 participants now.
What is it we have?
17 participants ఉన్నారు ఇప్పుడు ఆన్లైన్ మీద. కేశవరావు is there. Good morning, కేశవరావు. శ్రీధర్ రాజు.
Keshav, they are physically there or on Zoom?
కాదు, వర్చువల్ లాంటి మన ఇంట్లో ఉన్నారు. ఫిజికలీ శివ అక్కడ ఉన్నట్లు ఉన్నారు. శివ, కిషన్, ఉమా, ప్రమోద్ I think are visible there.
A very good morning to one and all.
Morning.
Conference. So I welcome you all for the first IMH Hyderabad Alumni Global Meet. Everyone, we'll start with the inauguration function. My request,
वो ये दे दे
Alumni
मेरे को
Association,
हेडफोन कल दिया सो
ఏదైనా
Dr. Pri Raghuram Reddy sir, who is online.
Yes. అది నేను కలపటం లేదు.
Welcome you, sir. Guest of
Hello.
honor, Dr. Shankar sir, to please come on to the dais.
అది పెట్టి కనపడం అప్పుడు కూడా కనపడవా?
My request, Dr. P. Kishan sir, guest of honor, to please come on to the dais. My request, Vice President Dr. B. Preeti Swarup sir, please come on to the dais. I request Treasurer Dr. M. Girish Kumar to please come on to the dais. Sir, now I hand over the proceedings to Dr. V. Pramod Kumar sir, the presiding officer. Thank you, sir.
A warm good morning to all of you. And it's my privilege to welcome you to this session for the inaugural ceremony of IMH Alumni Global Meet. And I take this opportunity to welcome first Dr. P. Raghuram Reddy sir, our guru of all of us, almost all of the alumni of the IMH. And in view of the pandemic and because of some restrictions from his family members, our sir is not able to make it. And we welcome you, sir. And it would have been a great pleasure if you are amongst us offline. Anyhow, sir, thank you and welcome you, sir. And Dr. Raghuram, and now I welcome Dr. P. Kishan, who is a guest of honor, and he is instrumental in making this meet possible and trying to make it a memorable one. Usually people will do this paid work, but I feel that he has made all the work he has done, the interaction with the speakers, interaction with the most of the global delegates, and in coordination with the office bearers of IMH Alumni Association, he did a great job. I welcome you, Dr. Kishan, and it is a pleasure to have you here. And my colleague, Dr. Uma Shankar, is a guest of honor for this session. And he is also the organizing secretary for the IPSACon 2020. And as you know, Dr. Kishan is the organizing chairperson for the conference. I welcome you, Dr. Uma Shankar, for this session, and I thank you for coming over to the session offline. Then I also welcome all the delegates who are online from far off places and from India, and all the people who are online right now, and to all the people who are yet to be online for this session, I welcome you all. Then I welcome all the people who are instrumental in making these arrangements, and my special thanks goes to my team members, all the office bearers of the IMH Alumni Association. And so we'll begin the program with the formal lighting of the session, indicating the inauguration of the meeting. So I request all of you to join me in lighting the lamp. Please. Now we will have the prayer song. Who will play? Dr. Mansa will be will render the prayer song.
महागणपतिं मनसा स्मरामि महागणपतिं वसिष्ठरामदेवादिवन्दितमहागणपतिं मनसा स्मरामि महादेवसुतं गुरुगुहनुतां मारकोटिप्रकाशं शान्तं महाकाव्यनाटकादिप्रियं मूषिकवाहनं मोदकप्रियं महाकाव्यनाटकादिप्रियं मूषिकवाहनं मोदकप्रियं महागणपतिम्.
The inaugural meeting చూడండి, inauguration చూడండి, స్టార్ట్ అయిపోయింది.
Shiv Kumar will give his brief address.
Thank you, sir. under the guidance of our IMH Alumni President, Dr. V. Pramod Kumar sir, and all seniors of IMH Alumni, we were able to do certain activities, sir. Like we are able to start our alumni office, IMH Hyderabad. We are able to register 190 alumni members in our group now, and we are co-hosting IPSICon 2020. We conducted various CMEs at IMH, and today we are going to launch our website also in the afternoon session. And with the support of all alumni members now globally, we want to take IMH Alumni Association to certain high standards. Thank you so much, sir.
Thank you, Dr. Shiv Kumar. Now I request Dr. B. Preeti Swarup, Vice President of the Alumni Association, to give his remarks.
Respected Raghuram Reddy sir, Chief Guest for today's IMH Hyderabad Alumni Global Meet, Dr. Kishan sir, Guest of Honor, Dr. Umashankar sir, Guest of Honor, seniors, colleagues, and juniors. A hearty welcome for the IMH Alumni Global Meet, the first meet which is being organized under the able guidance of Dr. Kishan sir and Pramod sir. We are planning to have many more meetings, and I thank my colleagues who are abroad and who are actively participating in this meet. We are planning to have similar kinds of meets in the future with the help of seniors, colleagues, and juniors. I welcome you all. Thank you.
Thank you, Dr. Preeti. Now, I request Dr. P. Kishan, who is the organizing chairperson of IPSOCON 2020. I request him to give his address.
Sabak Namaskaram. Respected Presiding Officer Dr. Pramod Kumar, President of Alumni Association, and Chief Guest of the function, the legend of the psychiatry, Dr. Raghuram Reddy, Guest of Honor, and Present Superintendent of IMH Hyderabad, Dr. Umashankar, Dr. Shiv Kumar, Treasurer, IMH Alumni, Dr. P.G. Swarup, Vice President, IMH Alumni, Dr. Girish, Treasurer, and senior alumni members, teachers, the panel, and my younger colleagues from IMH Alumni, and present IMH students. Welcome you all, and good morning to all. First of all, I want to express my gratitude and thanks to all office bearers of present alumni under the leadership of Dr. Pramod, who allows us, who really accepted our proposal of having a global meet along with the IPSOCON conference. With all cooperation of our colleagues and teachers and blessings, we are able to do the mega academic event in Hyderabad. Started with IMH Alumni Global Meet today. From tomorrow onwards, 3 days South Zone Conference. And it will be closed, this academic feast of Hyderabad will be closed by Dr. P. Raghuram Reddy oration, 4th edition, with Keshavan's oration. And for this, myself and Dr. Umashankar, both are emotionally attached to IMH, and which is our professional motherland. We both felt something to give back to IMH, and we raised some fund on the name of Teachers Fund, IMH Alumni Teachers Fund, and that I think Dr. Uma Shankar is going to declare today's in networking meet, and the details of that proposal, which was we initiated with the permission of Dr. Pramod and and other office bearers. Only request for me from my side, I'm requesting all alumni people. I know how much hard work done by Dr. Shiva and Girish day and night with the guidance of Dr. Pramod to coordinate all alumni people who scattered over the globe with different timelines. Fortunately, yesterday trial run was successful. We are going to have a wonderful academic feast today. And I'm requesting all the alumni, please cooperate for successful today's function. Thank you, and over to the organizer. Thank you very much.
Dr. P. Kishan, for all the things you have expressed now for the betterment of this alumni association. And thank you once again. And now I request Dr. M. Uma Shankar, who is the superintendent of Institute of Mental Health. I request him to give he is a guest of honor for this today's session. I request him to address the meet.
Good morning to all IMH alumni to gather for this important gathering of global meet. Respected presiding officer Dr. V. Pramod Garu, president of past superintendent of the IMH, and today's chief guest and guru teacher for all the alumni is Dr. P. Raghuram Reddy Garu, and my senior is my close associate Dr. P. Kishan Garu, and other my teachers and my colleagues on the dais of the dais. Today is very important occasion. We can share our experiences. With that, we can enrich our knowledge, as well as we can support the needy people, those who are underprivileged. That is the motto behind this global meet. It is a great pleasure and honor to be here as a guest of honor. So very happy to share dais with my teacher, mentor, and guru, everything, Dr. P. Raghuram Reddy Garu and Pramod Garu and Kishan and other my colleagues. We learned a lot from our teachers, especially myself, not only education, by seeing almost more than 20 years, Raghuram Reddy Garu, Krishnamurti Garu, Gauri Devi Garu, and Pramod Garu as the superintendents. By observing them, by interacting with them, I learned a lot as administrator. Now that was helped a lot, and right now I am most of the things we learn, like what to do, what not to do for the society. Thank you very much, sir. This is a global meet is a good opportunity to share our experiences and help the juniors by seniors, as well as hospital and society. I think the alumni may initiate some of the activities in the IMH, like they can provide a lot of people are in abroad. They can provide some of the journals, which is help the juniors by acquiring the knowledge. In that way, some of the seniors, they can help. Even the people in the India and Hyderabad, they can also help by organizing some of the CMEs in-house. as well as some of the community psychiatry also. That is a very important part what I feel. It is started very way back, almost in 1980s by Dr. P. Raghuram Reddy. Before the government of India starting the national mental health programs. That is the vision of our teacher, Dr. P. Raghuram Reddy Garu, the importance of community psychiatry. So I feel everybody, not only IMH, everybody, those who are teachers and passed out from the IMH, they can help the community by surveying directly and also supporting the IMH. IMH is now we are trying to support ourselves as well as we are doing so many programs. We are recently in the January 2020 we started a drug treatment center with the help of AIMS and Cme Hospital Mumbai. We provide the substance abuse patients. If they come, we provide all the medicines freely under observation. That is almost every month we are getting around 25 to 30 patients. We are doing that. We also started some legal aid clinic that will help the society, those who are underprivileged, those who are needy, they can take the help from the legal aid center. One lawyer as well as one volunteer, paralegal voluntary, they will coming to the IMH twice in a week. They can help them. With the help of them, we are trying to discharge the patients. We are handing over to the family members. That is doing a very good job. Near future, we involved in even in national surveys also. In the near future also, we are participating in other surveys, those who are doing by NIMHANS. They approach us. Most probably in the near future, we are going to have a MOU with them. With this, I request all the alumni help the IMH to grow further, and also you suggest whatever we can do with the help of government, with help of the seniors and teachers. We'll try to keep the IMH in a good position. Thank you very much giving this opportunity. Thank you.
Thank you, Dr. Uma Shankar, for the good account of the activities going on at IMH. And here are our appreciations for you, laudable appreciations. And thank you so much. And I hope that it will progress further. And the association of the members of the association can help the development of the IMH in a big way. So thank you so much, Dr. Uma Shankar, for your address to the gathering. And now comes a grand event. Now I request Dr. P. Raghuram Reddy sir, who is online, and he will deliver his address and the keynote address, and I request him to give the blessings to the association in further progress of the association, alumni association, and also development of the IMH. So over to Dr. P. Raghuram Reddy sir. Thank you, sir.
Dr. Pramod Kumar, President of the Alumni Association, Dr. P. Kishan, President IPS South Zone and Guest of Honor, and Superintendent of IMH, Dr. Uma Shankar, Dr. Preeti Swaroop, Dr. Shiva, the ladies and gentlemen, colleagues on of the dais, participants from global areas, IMH, Hyderabad IMH alumni meet, global meet. You have really made it a global meet. Nice to have them all with us. I thank the organizers for giving me this opportunity to participate in the inaugural function. I was thinking, what is Global Hyderabad Alumni Meet? It's a meet of old students spread over the globe and who have holding many important positions and developed name for themselves. What is essentially IMH alumni? People who were trained in Hyderabad IMH, which includes teachers, environment of IMH, its programs, the way patients were treated, and how alumni participated in these activities of the conferences and were exposed to academics. Way back in 1970, when I joined as Deputy Superintendent and very soon took over as Superintendent duties, what we were noticing was the scene. There were the latecomers for the OPD who could not be seen, who could not be admitted, coming from districts. They would stay overnight under trees, under a shed, without any care, without any shelter. There were inpatients, about 640 of them. They received less attention and were at the mercy of the staff, facing very often physical harassment cases. After a break of 3 years, I rejoined IMH as superintendent in September 1978. We took up various reforms like keeping the latecomers in a ward with modest care initially. Later, it got developed as regular family wards with family members staying throughout the inpatient care. This reduced the length of stay of the patients from 3 months in the closed wards to 2 to 3 weeks. And family members also learnt about the illness from the other patients and etc. And that improved insight and care in the family later on. The OP latecomers who could not be admitted were kept in outpatient rooms overnight and cared for. That's how they got 24 hours continued care. In 1980, we planned to start rural community services for which we needed vehicle. This was even before initiation of at Indian national level Community Mental Health Services Act. And when we started, we wanted vehicle. It was luckily it is the great Finance Secretary, Mr. BPR Vittal, surprisingly approved our request for 2 vehicles. I thought if we ask at least 2, we will get 1. They got go. With that, we started Rural Community Mental Health Center at Shankarpalli, about 40-50 kilometers away from the institute. And later on, 4 urban mental health centers with monthly visits in Hyderabad urban. And in 1985, we started a community mental health center at District Hospital Sangareddy. Monthly once, on Mondays we used to visit. With the help of the alumni, we conducted various conferences, national and rural, including Indian Association of Social Psychiatry, Indian Association of Suicidology at national level, South Zone 2 conferences. After retirement in 2003, I conducted with the Association of Alumni, ANSIPS 2003, and alumni members came from abroad also, many of them, to help us, and they helped us a lot. In 9th 5-year plan, because of the community mental health work done, government approved 27 posts, highest in the state. Not only that, all the state hospitals put together did not get that number of staff. And that was the reward for the community centers. We explained the finance secretary, etc. Recently, IMH has been sanctioned by Government of India a Center of Excellence, a drug treatment center, and Sadaram Certification Center. And Center of Excellence was got constructed by Dr. Uma Shankar with great efforts. He has given more details, and he will be giving even more details in the Ascension lecture. Alumni, during training exposed to all these activities and programs, can shape their future in developing their own innovative mental health programs wherever they work. Interestingly, recently a young lady psychiatrist phoned me to ask, the question was a difficult one, uncle, how to develop ethical psychiatric practice? It was a difficult question. And I was thinking, why did she choose to ask me? I asked her, who is our actual teacher? Our teachers, teachers, and discoverers, all of them, for all of them, who was the teacher? Who was the learning center? It is the patients. One French psychiatrist has written huge biographies of patients. It's all patients, from them we learn. That if we remember during practice, probably basic ethical practice can be developed. For example, Dr. K. Chandrasekhar, Managing Director, Asha Hospital, who was committed teacher in IMH then, he once revealed about a side effect of a drug which we all missed. How? By observing the patients. Dr. M.S. Reddy vehemently and innovatively says there is no bipolar disorder 2. His confidence arises from keen and direct observation of the patients. He had stayed for some months in IMH before going for PG training. He can be a part of alumni in that sense. He was trained here. Very often, Psychiatrists depend upon group consciousness, mechanically listed, following list of signs and symptoms and writing prescriptions. No eliciting premorbid personality, precipitating factors, family dynamics, etc. When we examine patients comprehensively, we would know psychopathogenesis in the patient. Patient and family also understands, get sensitized, and care for the patient better. They would think hallucinations auditory are not his making. They understand that. Also, they are likely to inform others how effort was spent comparatively more, and that can promote one's practice too. Also, medical legal cases against such doctors are not likely. For example, there was a senior psychiatrist, a very nice person. In his clinic, a patient during ECT died. And they instituted a case. Before instituting a legal case, they came to meet the doctor and ask about the death, etc. He briefly told them, and he was going for a social meet, charitable meet. So it was time, in a hurry he went away. And he told me later that Ram Reddy, the mistake I did was, when they came to ask about the death of the patient, if only I had consoled them, told them certain factors, that all the care that was taken before giving ECT, etc., this would not have arisen. So medical legal cases are more in such cases. We can follow Christian saying, do to others what you would expect them to do to you. If only we take one of our family or close relative to a psychiatrist, what we expect, can we give it to the patients and get dividends? The Global Hyderabad Meet has a CME program with very good topics and learned speakers and an innovative networking session. I congratulate and thank the organizers for planning on such a grand scale participation from global areas and also sound academics organized programs. A quote, child is the father of the man. All of you know that. I believe, at least in my case, student is the guru of their teacher, which is my humble myself in time to come. They have already become my gurus in various things. I have learned a lot from my alumni, received abundant affection. My salutations to them. I wish and believe that this meet will be a great success. I'm happy to declare the Global Hyderabad IMH meet inaugurated. Thank you all. Thank you.
Thank you, sir. Thank you, sir, for the wonderful message. And we want to welcome. As per your advice, we put all the effort to see that what all we have said will be incorporated in our future activities. So thank you, sir. Thank you once again. Now it will be time for another presentation, and Dr. Kumar will give.
Sir, I request Pramod Kumar sir to give mementos to guest of honor, Dr. P. Kishan sir. I request Pramod Kumar sir to give memento to Dr. M. Umashankar sir. To Dr. B. Preeti Swarup sir. Dr. Girish. To me sir. I request Kishan sir to please give a memento to Pramod sir. As Raghuramdi sir is online, so along with memento presentation, there is a small felicitation, sir. Madam will be doing. I request Kishan sir to take.
Hello. Already the organizing committee and from the office bearers of alumni, the felicitation material has gone to Dr. Raghuram sir. Now I'm requesting Madam Malakshmamma to do felicitation on behalf of organizing committee of IMH Alumni Global Meet. Madam, kindly put the garland first, madam. It's very nice to both of you together. To all the students of Dr. Raghuram Reddy. Next shawl, madam. Shawl, presentation of shawl to by Madam Raghuram Reddy. Sir, మీరు కూర్చోండి సార్, మీరు కూర్చొని ఉండండి సార్, మీరు కూర్చొని ఉండండి సార్. Madam, great to see you, very wise couple. మీరు కూర్చోండి. Bouquet. Memento, madam. Memento, there is a memento also with that. Yeah. Thank you very much. And we sent everything sanitized, madam. Thank you very much for doing favor for us. And thanks to Dr. Raghuram Reddy for accepting. Thanks to madam for carrying the felicitation program. Over to Dr. Raghuram Reddy and Madam Raghuram. Madam, few words from Madam Raghuram. Malakshma, madam, if you want to talk, madam, 2 minutes.
It's great pleasure for me to get this opportunity. Is she audible?
Audible,
Is she
sir,
audible?
Madam
she
can sit
audible?
and talk. If she sits, she will be very nice. కూర్చోండి సార్ వీలైతే. Both of you, yeah.
Great pleasure to get this opportunity to garland my husband. And I thank all of you with immense happiness that this type of meeting should continue more and more forever. God bless all of you. Thank you.
Thank you very much, madam. And this is from message from Dr. Malakshmamma. She was retired Commissioner of Health of United Andhra Pradesh. Thank you, madam, for grace and very great couple. Thank you.
Dr. Raghuram Reddy sir to respond to this felicitation.
I would like to share the pleasure with the organizing committee, with the alumni association, and what I feel this global association, the global itself means that we are one with all. We are not sectarian. It's not as if alumni association will help itself and not others. We must be inclusive. We must be a part of the society. There is no division between patients and doctors, between this alumni and the other alumni. We welcome everybody, and that kind of a equality builds fraternity. And we should welcome sources of learning from all the windows of the house. And also, we do meet, we do share relationships. They're all okay. But at the same time, once out of the alumni meet, we should be part of the wider society, community. I think only thing is, if we achieve equality with the patients, that will go a long way for our own welfare and even material welfare and psychological welfare. Thank you.
Thank you, sir. So now I request Treasurer Dr. M. Girish Kumar to propose a vote of thanks.
Respected dignitaries and ayahs, and my teachers and chairpersons, speakers, and all alumni members. Presently, I am treasurer to my mother institute, IMH. As a treasurer, IMH Alumni Association. It's my immense pleasure to be a treasurer. Only briefly, we have a bank account with IMH Alumni Association. We have cash in bank deposit 2,08,699 rupees. And in cash form, liquid cash, we have 59,000 with us. And we want to strengthen our IMH financially also to serve our mother institute. We are trying our level best with support of seniors and all our teachers and students. Thank you. Now, I propose my vote of thanks. I want to thank teacher, chief guest, and teacher to all teachers, Dr. P. Raghuram Reddy sir, to chief guest for this today's program. I also want to thank our guest of honor, Dr. Kishan sir and Dr. Uma Shankar sir, who are the behind for the this program to make a grand success. And also want to thank our president, Dr. Pramod sir, to continuously persuade this program. And also, I want to thank our speakers and chairpersons and co-chairpersons who are going to deliver lectures for accepting to be part of this program. I want to thank all our teachers who supported to be in this program and also who educated us and continuously educating and supporting IMH. I want thank you all members who are going to listen to today's program. And at last, I want to thank Icon Life Sciences for supporting this program. Thank you.
Thank you, Dr. Girish. And before we conclude, we'll go for the national anthem. And this will be followed by the academic sessions. And Dr. Anita will be coordinating the sessions. And let us all stand for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत
Good morning, one and all. Good morning, one and all. Now, I would like to start the first session of the day. It is about the cognitive behavioral therapy of schizophrenia. The lecture will be delivered by Dr. Narasimha Reddy sir. I would request Dr. Narasimha Reddy sir to please come and deliver the lecture. I would like to request Dr. P. Raghuram Reddy sir to chair the event. Dr. P. Raghuram Reddy sir has done his MD from AIMS, New Delhi. He is the retired principal of Osmania Medical College and ex-superintendent of Institute of Mental Health, Hyderabad. He has been the longest superintendent of IMH for around 17 years. He has conducted ANSIPs and has trained many students in psychiatry who are now in high positions in India and abroad. I would also request Dr. Mukesh Sangaria sir to chair the event. Dr. Mukesh Sangaria sir has done his DPM and MD in psychiatry. He has done his MRC Psych and fellowship in geriatric psychiatry. He was the medical director and chairman of clinical services in Delano Clinic, Kalamazoo, Michigan from January 2002 to January 2010. He is presently working in San Diego, California in a community program with an ACT approach serving clients with severe and persistent mental illness. I would request Dr. Narasimha Reddy sir to come. Now I hand over the mic to Chairperson, Dr. Raghuram Reddy sir. Thank you.
Sir, Raghuram sir, please unmute, sir. I request the chairpersons to please take over, sir. Mukesh sir, you can start. Raghuram sir, please unmute, sir. Unmute.
We can't hear you, sir. So if you
Right.
unmute, yeah, okay.
Now
Now,
it's
now
okay.
we can hear you.
Right. It's great pleasure to see in Hyderabad our frequent visitor, Dr. P. Narasimha Reddy, a senior member of the alumni and a great teacher way back in United States. He was the first MD of IMH. He joined in 1964, and the first time he got cleared with appreciation from the examiners. He is sober, soft-spoken, but very assertive in his opinions, which are usually knowledgeable. He acquires knowledge, speaks when relevant context arises. He is very humble. He is very simple. Some thinker said, in simplicity, there is subtlety, a great depth, and that's what he is. He has been visiting and conducting and presentations with us here for IMH alumni, and They were all great presentations. And I request him to present his speech. Thank you. Sorry, before that, Dr. Narasimha Reddy, he is speaking on essentially on CBT for schizophrenic treatments. It is a very well worked out therapy which has spread all over the globe, CBT, and in schizophrenics, it builds insight and prevents relapses to a great extent in many of them. And Dr. Narasimha Reddy is the proper person to talk on that. I request him to deliver the presentation. Over to Dr. Narasimha Reddy.
Thank you very much, sir. Asmad Gurubhyo Namaha, to said Dr. Raghuram Reddy, the original teacher for everyone. I just want to make sure that my talk is clear and everyone can hear. Yes, give me a thumbs up. Yes, in the audience there. Okay, great. Okay, now I'm going to share my screen so that I have my PowerPoint presentation that you'll be looking at as I am presenting. Okay. 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 The audience who are there, are you able to see the PowerPoint presentation? Okay. I take it as yes. Okay, great. Thank you. I think that sign shows us. Okay. This is a topic that is close to my heart, in that I deal with a lot of individuals who are seriously mentally ill. And what I'm talking about is something that I do on a day-to-day basis. And I'll talk more about it as we go along in the session. This is a topic I initially got interested almost like about 15 to 20, between 15, 17 years ago, when Dr. Aaron Beck presented in Philadelphia in a psychiatric association conference about the effectiveness of CBT in serious mental illness. And then I went to the Beck Institute to develop additional skills in CBT for psychosis and schizophrenia, and since then I have been interested in that. Okay. Okay. I see some echo, but I think it must be someone speaker. And from then on, I did a randomized control trial. I have educated different people like nurses, case managers, and all, and have authored some articles as well as certain manuals in this particular topic. So that's where my kind of interest has been and comes from. So basically what we are going to do today is that it's a huge topic. I'm very conscious of everyone's time, and I'm allotted about 45 minutes, and I'll try to keep it to that 45-minute time frame and give about 15 minutes for questions. So we are going to talk a little bit about what is the current status of CBT in schizophrenia. And even before that, why CBT in schizophrenia? What is the current status of CBT in schizophrenia? How does cognitive perspective inform cognitive therapy in schizophrenia? And then talk about certain techniques that anyone can utilize in their interactions with patients in a routine clinic. Finally, we'll end with what is it that we can do. And when we say we, I'm talking about the distinguished leaders who are there, as well as the young budding psychiatrists who are coming up, in terms of how do we develop more effective systems in improving the care for the individuals, and can we take things like this into the community and spread in India. So that's where we would kind of end it. Okay. So first of all, why even bother for an illness such as schizophrenia, which is as biological as they come? Why do you even bother about psychotherapy? Okay, because number one, pharmacotherapy, even though it is critical, it is inadequate. Okay, we all know that positive psychotic symptoms respond in some, but not in all. Number one, in those people in whom they respond, they may not respond completely. Negative symptoms respond inadequately. There is a significant burden of side effects. Relapses are common despite people taking antipsychotic medication on a regular basis. And the topping it all, even when there is symptomatic recovery, is there complete functional recovery? No. Is there complete improvement in quality of life? No. Are they able to go back to the essential roles that they were playing before they started with this illness? No. So what do we need? We need more effective therapies for schizophrenia. While the biological effort is going on, we have to look at what psychotherapy can offer in terms of helping these individuals. Okay, so that is one strand of evidence why we need more effective treatments in schizophrenia. Now look at it from the perspective of the patient. Dr. Raghuram Reddy sir has mentioned how we should be treating the patients as someone who is equal to us. Okay? And I just loved that particular thing he said. One of the things I talk to my residents is that how do you practice ethical psychiatry was a question. So one thing I tell my residents, one, you all should have a personal philosophy of care. And it should be your personal philosophy of care. And I share my own personal philosophy of care, which stands for 3 C's. Number first C is a compassionate or a collaborative attitude, a compassionate attitude towards the patient. What is a compassionate attitude? As Dr. Sir has said, you want to treat the patient who is in front of you as if you are treating a family member or a friend. Okay. Yes, that is the 10th patient that you are seeing for today. However, that is the patient with only one life. That is a parent who has only one child. So every patient is as important as everyone else, even though they are the 10th or the 15th or the 20th. Okay. The second C is providing clinically excellent care, the best care that you can provide in terms of pharmacotherapy as well as psychotherapy. Number 3 is a collaborative attitude where you are not making a decision and saying, this is what you do, but hey, we are in it together. You on one side, I'm on the other side, both of us together working against a common enemy. And the common enemy is the illness that we are fighting. And how do we do that? So collaborative decision-making style. So I think these 3 things, having a personal philosophy of care, and whichever system you're working, whichever part of the globe you're working, if you're able to translate that personal philosophy into your practice on a regular basis, then all you can do is nothing but ethical psychiatry. So coming back to how it is relating to our patients. So what is the experience of the individual with schizophrenia? One, when we talk about schizophrenia, I want you to remember that we are talking about entire psychotic disorder. So what is relevant for schizophrenia is relevant for any kind of psychotic symptoms. So number 1, psychosis is extremely isolating to the individual. 2, it is stigmatizing. It is very demoralizing. In addition to all what it does, it takes away the very soul of the individual in terms of who they are. The very identity is affected. So in this kind of an instance, what do patients want? Patients want a relationship. One of the things what psychosis does is that it takes away the ability to form relationship. Normally, when we are in trouble, what do? We connect with people. We connect with people, and through the support, that is a source of strength and hope and recovery for us. Now, that is something that is disrupted in this particular illness. So it is very important for our patients that people are able to connect with them. Who best in that position to be able to do that? The psychiatrist who is providing the critical medication for the patient to be able to connect with the individual. And the psychiatrist, by his ability to connect very deeply with the individual, is also modeling the behavior that the family members can look at, the society can look at, the community can look at. And then what do you have? A community of people who are able to communicate and connect with the individual. And through that connection, you are going to awaken the healing power with the individual and help them on the path of recovery. Yeah. So the people who tell us how best to treat with schizophrenia are people who have recovered from this and are currently holding very high positions. So what you have in front of you is Dr. Sachs. Dr. Sachs is a professor of psychiatry and law in UCSD in California. And she developed psychosis at the age of 14. As she was walking back to home from school, she started hearing auditory hallucinations. She went on to complete her law school, ended up in hospital several times, went to England, did law in Oxford. Currently, she was a speaker in American Psychiatric Association a few years ago, and she is at the forefront of the best way to treat individuals with schizophrenia and other psychotic disorders. Why do I show this? I show this because people who are successful despite the illness are the people who instill hope in our individuals with schizophrenia. So any of my patients who come in, and when I sense hopelessness, this is the example I show. And this is what, this gives them a sense of hope, and this gives them the ability to kind of move forward. So this is what Dr. Sachs said in her autobiography, and the name of the book is The Center Cannot Hold. That is her autobiography. If anyone has any interest, and actually the younger psychiatrists should actually read this so that you get a good sense of what a personal experience of the individual is. You get a sense of what the personal experience of the individual is when the individual is forced to take medication against their will. And mind you, we as psychiatrists are in that position to have to do that. However, the attitude, the approach with which we do that, the compassion that comes with that is very important, because the individual who is being forced to take the medication or forced into restraints is able to sense who is doing it because they have a job to do, who is doing it to help you and with compassion, or who is doing it out of anger. They can sense it, and it is very important that we, even in those difficult times, continue to show our compassion. And what does she say? The humanity we share is more important than the mental illness we do not. So going back to the point Dr. Raghuram Reddy said, yes, we are on the two sides of the table. It just happens that we are on the two sides of the table. However, that once you go to the room, we are all the same. Okay, so based upon the fact that schizophrenia treatment is suboptimal, based upon the perspective of the individuals that they are yearning for connection and they want the psychotherapeutic experience, and based upon the information from people who are who have recovered and continue to advocate for recovery, we see why cognitive behavior therapy or other kind of psychotherapies are important in schizophrenia and other psychotic disorders. The reason I'm saying cognitive behavior therapy is because this is where a lot of study has been done. Psychodynamic psychotherapy in the studies that have been shown, even therapies, supportive psychotherapies and other therapies have also been shown, but CBT is the one that has the most evidence base for that. Okay, now that is the first part. Now, basically, what is CBT at a very basic level? CBT at a very basic level, you all know that it is that our cognitions cause negative emotions, cause or exacerbate emotions, psychological symptoms, and dysfunctional behaviors. And there are different types of cognitions. And by changing the cognition, you change the emotions, thereby change the dysfunctional behaviors, and then overall improve the symptoms as well as quality of life of the individual. So that is the basic CBT model. However, when it comes to psychosis, the same CBT model has to be modified a little bit, because we know psychosis is very different than other kind of illnesses, whether it is major depression, anxiety, OCD, and the whole bit. Okay, so how does CBT look at psychosis, and how does it understand and conceptualize psychosis so that the treatment can flow from that conceptualization? So we all are very familiar with the stress vulnerability model of psychosis. Okay, a combination of vulnerability plus the stress leads individuals to develop psychosis. The difference in CBT here is that CBT says that every individual and every brain is vulnerable to psychosis. The reason that you and I are not developing psychosis is that our brain is not put under the extreme degree of stress necessary to cause psychosis. Why that is important is just like every bone, whether the bone belongs to a young person and old person, breaks under sufficient stress. So also every brain can break under sufficient stress. And so that's now how it is kind of looked at differently than what we look at it from a biological perspective. From the biological perspective, we look at it as, hey, this is an illness. This is a category. This is where it belongs, and somehow it is different than normal. In cognitive model, what they say is that the symptoms that we see in psychosis, for example, delusions, are categorically not very different than what happens. If you look at the normal belief, you can see from normal belief to delusion, there is a continuum you can see if we are paying close observation to different types of psychopathology. Okay, so it is more of a dimensional thing as opposed to categorical things. Okay, and the third thing is that any kind of psychological, the psychotic symptoms have underlying psychological themes, the universal themes that we all kind of struggle with at some point or the other, are the themes that come in hallucinations, or the themes that come in the delusions. So then you can understand the delusions based upon the underlying psychological themes. Okay, and the trauma with childhood, adversity and trauma and subsequent traumas are known to significantly contribute to the etiology of schizophrenia. And finally, what it says is that every individual, however psychotic they are, have a healthy aspect of themselves, healthy coping skills that we have to tap into, bring them out into the open, and kind of build upon them. Okay. Finally, the psychological interventions, not only do they improve the symptoms, that there is adequate evidence to show that the psychological interventions actually modify the brain circuits. I provided a couple of references here as to how you can see functional MRI changes pre and post CBT, And also, you can see the changes in DNA fragmentation, which is an indication of the degree of stress an individual faces that over a period of time with therapy is known to decrease. So you can see how effective therapies like these are. What the broader point is, not only CBT, but I think you would find evidence for other kind of psychosocial treatments as well if we look for it. So essentially saying that, hey, biology is not the only one which changes biology. Psychology can change biology too. Okay, so these are a couple of universal psychological themes we talked about. For example, safety versus danger is the underlying universal theme in any individual with persecutory delusions. Superiority versus inferiority is the one which comes in grandiose delusions, so on. So there is something much underneath the delusions, and we can go underneath to understand the individual from a deeper perspective. Okay. So that kind of lays the groundwork to look at, hey, what has been done in CBT so far, and what is the evidence base for that? So what I did was that I actually took one meta-analysis, and then I took the next slide is about a combination of all meta-analysis. So the first meta-analysis that I'm just going to look at, it looked at 34 clinical trials that have been conducted of CBT for schizophrenia and psychosis. Okay, out of this, what does it show? Out of 34, 32 show improvement in positive symptoms, 23 show improvement in negative symptoms, 15 of them show improvement in functioning, 13 in mood. How big is the improvement? The effect sizes are mild to moderate, 0.35 to 0.44. So this is significant in that it improves the quality of life of individuals. Okay. So if you look at the meta-analysis, okay, a total of 20 meta-analysis, and I will just mention what the final thing was. CBT was found to be better compared to treatment as usual with respect to positive, negative, and general symptoms of psychosis. However, when it comes to looking at improvement in functioning, are they going to jobs? Are they able to play their roles as a parent, as or other roles as a spouse, etc.? The more evidence is needed. There is evidence that it improves, but we need more robust evidence to be able to say that yes, definitely it improves functional outcomes. Okay. So based upon the evidence and everything, what do the current treatment guidelines say about where does it fit into the algorithm of treating individuals with psychosis? So the United States is a very kind of a funny country. You don't necessarily go by what is the best evidence. What you go by is what is most in vogue. And I'm saying that in relation to if you're looking at something like United Kingdom. And the reason for that is how the healthcare systems are there and what are the different kind of lobbying groups are there and who lobbies what. Because of the universal health that the National Health Service provides, and because of the system that are there in UK, what they go by is the evidence and not one particular modality getting more exposure compared to other modalities. So that is where I find UK information from UK kind of much more objective. So the United Kingdom National Health Service, the treatment guidelines is that CBT has to be offered for all patients in their first episode of schizophrenia and any patient with persistent symptoms despite medications. Okay. Now, coming to United States, port recommendations are recommendations by a group of expert academic individuals relating to how do psychosocial treatments impact schizophrenia, and their recommendations are CBT to be offered to any individual who has symptoms despite pharmacotherapy. You do your pharmacotherapy, they are having symptoms, they have to be offered CBT. That's the ideal kind of a recommendation. Okay. What is happening in terms of in real world? The real world is actually much more, in terms of United States, the real world is, in some areas, it is much more advanced than what the guidelines are saying. And there have been CBT studies in a variety of different formats and are shown to be effective. So it has been shown to be effective in individual format and group format. And it has been, there is some emerging data of the effectiveness in teletherapy. And the people who are providing the therapy have been psychiatrists, psychologists, social workers, nurses, and even case managers. So who is a case manager? Case manager is someone who goes into the community, to the individual's home, and helps them with things such as transportation, their benefits, making to the appointments, getting medications and all. Typically, these are individuals who are bachelor's level people who, with their bachelor's level training and in mental health, are able to learn the CBT interventions and able to utilize them with their patients. That is something important for us to know. And there is some evidence of using family members as therapy extenders. So basically, the therapist does the therapy, but teaches the family what to do, and the family kind of extends that and utilizes that at home. Okay. We're going to talk very briefly about how does the session itself is different in classical CBT versus in CBT for psychosis. In a classical kind of a CBT, the person comes to the office. They come every week. You are seeing them for about an hour. Okay, so everything is kind of structured and directed. However, in psychosis, you have to be much more flexible. How it has to be different is that there has to be a lot more emphasis on the therapist working harder to build relationship. That is most important, because as we talked about before, one of the things that people lose is their ability to connect with other individuals, because that's part of what the illness does. It takes away your ability to connect and connect at a deeper and meaningful level. So relationship building is very important. Second thing, this therapy has been offered not only in the office, but in the community. Third thing, in terms of flexibility, is that it can last only 15 minutes if the individual is not tolerating it, or it can last for 50 minutes if they are tolerating it. So the therapist has to be flexible. It is not a structured 15 minutes every week. Okay. Now, any homework assignment which is given is very simplified, very simple kind of things which the individual is able to do. Okay. And typically what has been shown is that the therapy is done initially weekly, then every 2 weeks, and totally for a period of about 6 months is when it has been found to be most effective. Okay. So that is, kind of covers the basic about the CBT, how it is utilized for psychotic disorders. Now, what we are going to talk about are actually things that you might be able to utilize with your patients. And this is the part that actually where the rubber meets the road, which is, so what are the techniques? So first of all, I want you all to keep in mind that your patient does not need to go to a therapist and have to see someone every week. In United States, even in the population that I have, I don't have that kind of a luxury. Not every patient can find a CBT therapist. However, what is important is that what CBT therapy has shown is it has helped me to change my own approach and also change the approach of not only me, but the entire team who is responsible for that individual. So how we are approaching, so we are taking the CBT perspective, the CBT interventions, and incorporating them into our practice on a regular basis. And these kind of interventions fall into two different categories. One are techniques that are used, which are called discovery-oriented techniques. Okay, and the other one is change-oriented techniques. Discovery-oriented technique is a technique, for example, if an individual has a delusion and you are helping the individual to find out the triggers of the delusion where it is increasing, helping the individual to find out about where the delusion is decreasing. And so that is a discovery-oriented technique. Or if an individual does not want to take medication, and you are able to have a conversation with the individual and come to their underlying beliefs that are motivating them not to take the medication, that is a discovery-oriented intervention. A change-oriented intervention is you once you found out that, hey, this is a trigger, then you come up with a plan to address the trigger. That is a change-oriented technique. So this is important to know, because as you want to kind of incorporate this into your practice, knowing, hey, whether it is a discovery-oriented or change-oriented, will help you to kind of modify your intervention based upon where the patient is. Okay. So what I thought was that instead of just talking about all the different topics that need to be covered, which we don't have the luxury of time, that we are going to talk about 3 different things. And this is where I would like Dr. Sangadia to tell me if I have enough time to do all 3. The 3 things I have is 1, individual who is presenting with irritability, anger, or aggression. That is one topic. 2, medication non-adherence is a second topic. 3 is dealing with delusions. Okay? So we will go along with each of the slides, and if I am getting very close to time, Dr. Sangadia will kind of jump in and let me know so that I can modify so that I don't go beyond my time. Yeah.
You have about 15 minutes.
Oh,
and,
thank you.
Then another few minutes for the comments and question and answers.
Okay, wonderful. Okay, thank you, Dr. Sangadia. Okay, so irritability, anger, and aggression we see very commonly in individuals with schizophrenia. Okay, so if an individual with schizophrenia has this, what do we do? Okay, number 1, okay, we have to find a way to connect with the individual. Okay, and we have to find a way to connect with the individual at a deeper level than most people around are able to do that. Even family members are not able to do that because they have this baggage about their behaviors that they have to deal with. Okay, so a couple of techniques is when you see an individual showing non-verbal behavior that they are upset or angry. Okay, the addressing the anger and then talking about it. Number 1. Number 2, if there is a patient and a family member, first actually going to the patient before going to the family member in asking what the issue is. Because once you start asking the family member, if the patient already has that the family member has forcibly brought them, now you are aligned with the family member as opposed to aligning with the patient. Okay. Then 3, being very clearly expressing your intent and in a very specific manner. Okay. For example, like saying that, look, my job here is to help you to stop the voices that are bothering you so that you can get back to your job. Okay, very simple thing where you are able to connect and talk to them. Second thing, always validating their feelings. People are angry because they do not know any other way to deal with what's going on inside. Okay, so validating statement is something like, hey, look, if I believe that someone is trying to poison me, I would also be upset like you. Okay, when we are validating them, we are not saying that your belief is correct. No, we are saying that if I'm in that situation, I would also be having it is natural or normal to have these kinds of feelings. Okay, and so this is another way of connecting. Then the third way is where actually you once you connect, you start gathering information. For example, when did you first start getting angry? Okay, if this is a change for you, what is different? So then you go to the experience that actually started the anger. And then you can say that there are certain things that trigger the individual into anger. And when you're able to go and talk about that, you are able to bring to light, not only to the individual, but to the family, hey, simple things you say or do can either trigger the anger or decrease the anger. Okay. And finally, tapping into the healthy aspect. Every individual, even though they are having angry outbursts, there are several times they have controlled their anger and they have not responded to that situation. Tap into that and say, and ask them, how is it that you're able to ignore the voices sometimes, but other times you're not able to? What is different? What makes you able to ignore the voices? So that is where you're tapping into the healthy self. And when you're tapping into the healthy self, people get more animated, more interested in talking to you. Okay. Okay, so once we do some of these discovery-oriented techniques, we come to a point where the individual either we find out that the anger is ego dystonic. Yes, I should not be angry, but this is why I got angry. Or ego syntonic. Hey, there is nothing my fault, it is someone else's fault. So if it is ego dystonic, then it's always okay. Building their existing coping skills. Hey, looks like there are times when you're able to ignore when your dad is saying something like that. Can you do it? How can we build it so that you can do it more often? How, instead of doing it 8 out of 10 times, how can you go to 10 out of 10 times? So building on that. If it is ego dystonic, basically then ask the individual, are you gaining anything by your outbursts? Is it helping you in your relationship? Is it helping you in life? So it is utility of that. So when you talk about the utility, you are not talking about, hey, whether you're doing right or not. Hey, do what is best for you, kind of a thing. Okay. So this just generally kind of gives a little bit of an inkling into how to deal with the anger and irritability. What I find useful is if, along with the slide presentation, I actually have a written material that is part of a manual that we have actually written for individuals with psychotic disorders. So particularly individuals who are a little bit more educated, you give them about anger. It explains in much more deep in depth about what anger is, how it happens, what can be done. And that should be there along with the slides here. Okay. Yeah, one other point in terms of anger, what you do is limited. What you want the families to do should be extending what you're doing. So giving a sheet of paper to the family with about 10 points, okay? When the example of the points, 1, most individuals with psychosis, anger is very common. Anger is not personally directed against you. It is because they're having difficulty dealing with their internal emotions and experiences. Now, if you cannot control your anger and deal with them in a positive manner, how can you control how can you expect someone who is sick to control their anger? So that would be the way to kind of explain to the family members. And giving written material is always helpful because people forget 60% of what we talk to them the day after they leave our office. Okay, moving on to, now I think we can go either to medication non-adherence or delusions. So I probably would like to go to delusions and come back to medication non-adherence if we have the time. Okay. Okay. So
you have about 6 minutes.
I have 6 minutes. Okay. So I think I'll just complete the delusions and then probably end. So the delusions have underlying dysfunctional beliefs once we start going underneath the delusions. Okay. For example, I'll just give an example. Okay. I am not good at anything. That is my belief. So what do? I come up with a delusion. Do you know what? I created a robot and the robot can do anything that I want it to do. That's an example of, and for every delusion, there is an underlying belief system that we can go into. And sometimes instead of dealing at the level of the delusion, we go at the level of the belief system where it is easier to kind of deal with. Okay. So what is a good, good intervention to deal with in a delusion? Any intervention where you're having a conversation with the individual and the individual is able to actually not feel that that you are putting them down. They're not upset by the conversation and overall feeling better at the end of the conversation is a good one. So lot of times the simple technique which is given is what is called as collaborative empiricism. In very simple terms, look, you and us, me, are going to be like scientists. You say that this is what is happening. What we are going to do together is we are going to look at the evidence for that. So you're being in a collaborative empirical manner. That is the typical way of dealing with kind of delusions. Sometimes delusions are based upon people not having the real world knowledge about what is happening. One of my patients did not want to go to a pharmacy because the pharmacy, they poison the medication. Now, when I explained, do you know that right from the time a medication is manufactured to the time it comes to your hand, it is tracked in every single step. And if it is not tracked, it cannot come to you. And if anyone like a pharmacist does anything, do you know what? The pharmacist is going to be behind jail. That was an eye-opener for the patient. Okay. And that in itself kind of changed the mindset. And she said, okay, I won't go to that pharmacy, but I'll go to a different pharmacy. So giving real world example is another way to kind of deal with delusions. Sometimes giving them behavioral experiments to do, and I don't think we have enough time to kind of go into the behavioral experiments. Behavioral experiments is one thing, and also therapeutic self-disclosure where it is appropriate. And I don't think we can go very much into that. Okay. There are different kind of interventions which are recommended for different symptoms. Auditory hallucinations, there are different interventions recommended. If there are triggers, if you can identify triggers, if you can identify what the content of the hallucination. So so for hallucinations, disorganized behavior, for anxiety, depression, anything related to that, there are interventions which are very different. But I'm going to kind of come to a close here, just talking about a couple of things. What Dr. Sachs said is that while her medication kept her alive, what helped her was psychoanalysis. How did it help her? It helped her to, it instilled hope in her. It gave her a sense of purpose in life, and it kept her going when nothing else kept her going. So this tells us the critical importance of therapy in addition to medication. And in this instance, it is psychoanalysis. Okay. The last two slides of what can we do to kind of actually change your practice. The bottom line is, hey, what do we do with all the knowledge that we have? At the end of the day, we want to bring about a change in our practice with the individuals and give them a better experience. Okay. Certain things I would recommend. Have written education material for patient and family for the top, at least half a dozen problems that you come across very regularly, number one. Two, identify a family member who has the right mindset and educate the family member to be therapy extender. Three, also see, can you optimize your time by having someone who can be your extender in that they are doing the things for you, whether it's a bachelor's level, whether it's a social worker, I do not know, but that is something that can really extend your time. Four, leveraging technology. When I have done an intervention, I ask the patient to actually record it if they are comfortable and kind of review that at a later stage. Everyone has a cell phone. It's very easy to have a recording. So whatever you're doing, so even instructions, that can be done. And finally, considering group intervention. The last slide, Dr. Sangadia, and then I'll stop, okay? What do we need to do at a systems level? Because we need to create a better system, okay? What do we need? I think all postgraduates should actually take a couple of cases of CBT and have training and actually supervision in CBT, okay? I think with the Zoom sessions now, people can be accessed from anywhere. Expertise can be accessed from anywhere. Two, we have to advocate for developing training in nursing and social work. We have to train and evaluate family members as therapy extenders. In United States, we have people who have experienced psychosis and have recovered, come back and work in teams as peers. And when peers talk to patients, they are willing to be more open and listen to them. And finally, see if we can encourage people either whose family members, people who have resources, who can actually form groups like National Alliance for Mental Illness in United States and actually help to fight stigma as well as improve the services that are available. Okay. I think that kind of the next two are references. So I'm going to kind of end it here and give it to the moderators.
Thank you very much, Dr. Pinetti. First, a big round of applause for a wonderful presentation on cognitive behavioral therapy of schizophrenia. Awesome presentation, really comprehensive and thorough. And I'm sure there are lots of questions in the audience. But before that, I will just take 1 minute to introduce myself and some more about Dr. Pinetti. We both were the first batch of the MD Psychiatry program at the Institute of Mental Health and Usmania University. I have known him from before then, from Gandhi Medical College, where I graduated. And we had a very parallel course of career through the Institute of Mental Health, and we both completed our degrees. And then Dr. Pinetti went to UK. I followed him shortly. And he was very close. I mean, he was in the same rotation. So, our friendship really deepened at that time. And then he moved over to the United States, and I followed him there also very shortly, all by accident, not necessarily by intent. So since then, our careers have diverged significantly. I have been more in private practice or non-academic situations, although I've done some of that, as you can see if you are able to see my CV. But when I saw his CV yesterday, I was really bowled over. I mean, he's got 15 pages of CV. He's got multiple awards, multiple books, and presentations and papers and everything. And I have maybe about 3 pages of my CV. So he has done extremely well academically, and I really respect him for that. And uh, it is obvious in his presentation, how much he has accomplished. So that's a minute for him. About the presentation, I had one more, a couple of comments. Specifically speaking, the meta-analysis that you presented, Dr. Pinedi,
Yes.
Uh, the reduction in social anxiety was shown only in 2 such studies of over 30 such meta-analysis studies. So were the studies designed to look for all the outcomes, including social anxiety, or was it only social anxiety that was studied in that particular?
Very good question. Actually, not all the studies did not look for all the different categories of symptoms. In fact, every study looked for positive psychotic symptoms. Some studies looked for negative, and only few studies looked for anxiety. So yes, it is. That's the answer. So generally, social anxiety is helped in individuals with CBT.
Good, thank you.
Excuse me, Dr. Mukesh.
Yes,
Can I
Dr.
speak for a
Ramreddy.
moment?
Before that, my namaskarams to you,
Thank
my
you.
Guruji. Really, you are the number one guru for us.
I know.
And
you are my gurus now. I just want to butt in. I saw both of them, Dr. Pinninti Narasimha Reddy and Dr. Mukesh Sangaria, as the first batch students of MD. They were equally intelligent, equally studious, patient care oriented. Both of them are empathetic. It was like a tug of war between them. And both became my friends equally. Dr. Mukesh, I went to his place in the United States once, stayed in his room for some time.
I cherish those memories.
That's right. It was a sweet memory. And I look forward to contributions. And all of them are not of the same mold content-wise. Form-wise, maybe we are equally good. But each one chooses his own and makes innovations in his own field. And that's how, honestly, Dr. Sangadia said, have different lines in certain things. And both are necessary. And somebody else will do something else. So all of them are necessary for a comprehensive care of the patient. And it is nice to see both of them, and I'm so happy and look forward to a greater contribution to society, to patients, and to themselves in years to come. Thank you, Dr. Sangadia. It is very nice to see you here. Thank you.
Thank you very much, and likewise. And you look the same. You don't seem to have aged much at all.
Thank you.
So
there is a question. There is a question, Dr. Sang. Yeah. There is a question on the from the chat room. Can I just answer
I'm not able to see the questions posed by the audience. I've seen that one hand was raised by Dr. Shirisha, but I don't know what the question is. I can't see it.
So let me answer the question which is here. So please elaborate on vulnerable to psychosis. What is normalization? So basically what it means is that if any of us are put under the sufficient kind of stress, that we become psychotic. Example, there have been studies. So medical students, what they did was that in every way fine, except that they've participated in a study. In that particular study, they were sleep deprived. They were sleep deprived initially for 24 hours, 48 hours, 72 hours. By the time it was past 72 hours, people started becoming paranoid. People started having illusions. People started having hallucinations. So that is an example. Or if you are in a situation of sensory deprivation, what happens? You start actually hallucinating. So there is evidence from a variety of different situations which shows that apparently normal people with no family history, no nothing, can under those kinds of situation develop psychosis, which means that if there is extreme stress, that every brain ultimately can develop that kind of a psychosis. And that is important because most of the patients are thinking, I am somehow very different than everyone else. And when you know that, hey, look, what is different is that you have a little bit more vulnerability, but we all under certain circumstances can develop, this is a common thing to kind of remove the self-stigma that individuals experience. There is a second question here. Do we use any scale to measure the severity of symptoms before start of therapy and also end of therapy? Absolutely. In fact, there are a variety of rating scales. The initial scales that were used were the PANS, positive and negative symptom scales. Subsequently, what they have devised is actually a scale called CIRATS, which is typically used for the positive symptoms. And they look at delusions, they look at hallucinations, and look at different dimensions as opposed to, do you have hallucinations or not? Do you have, how frequently are your hallucinations? Do you have any kind of sense of control over the hallucinations? How distressed are your hallucinations? Yes, if you want to do research on actually CBT or other psychological interventions for schizophrenia, what is recommended is these kinds of rating scales, which are specifically designed to show the effect of these interventions. So those were the questions here. I don't have any more here. Yeah.
Thank you. If I don't see any other questions here, but I would like to share my little bit of experience in using CBT. And I think we all do, basically. We may not label it as such and may not be aware that we are doing this. But I think the majority of us, when dealing with patients and in the process of building a relationship and empathy, I think we verbalize much of, supportive statements that point in that direction. So, and I work in an aggressive community outreach team. So it is a wraparound program where everything of all aspects of the patient's life are helped with. So that minimizes the stress. That includes housing, money, benefits, like Dr. Reddy said. And it's the best, probably best model that exists currently in psychiatry in treatment of severely mentally ill people. So I would encourage you all to read further into it and recognize what aspects of your own practice you can use these mode of therapy in, and how you can develop it within your own Indian context.
So a couple of things, if I can make a couple of points. Yes, I do. I have to in the interest of disclosure, for every new patient, I have about at least 45 minutes to 1 hour for a new patient. For a follow-up, I have 30 minutes. Granted that I have to spend about 10 minutes in documenting, 10 to 12 minutes in documenting, but still leaves me about 18 to 20 minutes to have the interaction with the patient. Yes, it is. When you have that kind of a time, it is easier to do these kinds of interventions. However, there are times when I go to weekend on-calls, when in one day I see about 30 patients, and for the entire day. And these are all new patients on whom I am rounding in the hospital, or belonging to different attendings. But even in those kinds of interventions, if we have the right kind of mindset, if it takes sometimes as little time as exactly 3 minutes for someone who you did not see at any time to make them comfortable. When you see a distressed individual, first of all, you pause what you're doing. Just be in the moment. Then once you stop your train of thoughts, you say, okay, I'm going to be here with you for a couple of minutes. As soon as you make that kind of a non-verbal and verbal kind of attitude change, guess what? The patient senses you. The people, individuals with psychosis are very extremely threat sensitive when the threat sensitive level is very high. Okay, as soon as your body language is, okay, I'm here, I'm not in a rush, I'm here to talk to you. Guess what? They are ready to talk to you. And I have had people talk who were agitated, who were going into restraints. And guess what? And we were able to connect, and I was able to say, I'm going to come back tomorrow. And if you do not go into restraints tomorrow, tell me what is the best chocolate you like. Okay. And they say Kit Kat. I'll say, I will get you a Kit Kat tomorrow. Okay. If you don't go into restraints the entire day today. Okay. And the nurses would say, no, 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 no. After half an hour after you leave, guess what? He's going to get agitated. I said, let's give it a try. Okay. And the next morning, I called the nurse. What, did he go into restraints? No, he did not go into restraints. This is the first time in 1 week that he did not go into restraints. All because you give him a sense of hope. And guess what? You have to deliver it. I buy the Kit Kat, I take it to the patient and give it to her. Then that day, he goes around showing everyone, guess what I got? Guess what I got for good behavior? Okay, there are things that we can do. It doesn't take much because at the end of the day, we are human to human. What stops us from connecting with each other is this thing up here, all the things that we have built. Okay, I see if I talk, I keep talking, so I'll stop here.
I know, I was about to stop you. Just kidding.
Yeah.
So, are there any other questions?
I just want to, not a question, a little comment if Mukesh permits me.
Sure.
One is CBT or therapy, any therapy, proper therapy may not prevent relapses, but the distress and the content and the patient, how he behaves, takes, can be modified. He can be made much more comfortable to face. I just give an example. I had a case of NRI who had 6 sessions for hallucinations. And at the end of it, he said one thing, even if I get hallucinations, I will not be bothered about it. I will not be distressed. I think this is the one thing which is also therapeutic. You need not prevent relapse, but the severity of the relapse can. And I have heard a masterly and professorial presentation by Dr. Narasimha Reddy, and his uncontrolled enthusiasm to convey to the IMH did not, he went into a little dialect details to impress upon them, and that's how he could not take up all the slides. We only wish we had given him more time. Thank you, Dr. Narasimha Reddy.
And if I can just leave with one comment, well, just one last comment, Mukesh and Dr. Raghuram Reddy. Our job, when the patient is coming in, they should be less distressed going out of your office than they come in. You look at your body, look at their body language. You should see a smile on their face if possible. You should see a sense of hope in them when you talk, when you have done talking to them. I think then we have done our job, because we take care of the moment. Then rest takes care of itself. That's it.
A question, Dr. Narasimha Reddy, a question.
Yeah.
I don't know whether you have ever seen a laughing therapy. If we include laughing therapy to the patient in a session,
yeah,
make him laugh,
Yeah.
How would it go?
Actually, I did not have enough time. The part of connecting with the individual is actually able to laugh with the individual. I use self-deprecating humor a lot of times. Okay, I have an example of a patient who was very psychotic, who we developed a way to kind of laugh. Oh, absolutely. Humor is definitely a way to kind of connect with individuals.
Yes,
Thank you.
Of course, you have to choose your patients to do that, obviously.
No, absolutely. That is true. That is true.
With paranoid patients, you cannot really, be free at least in the beginning until you've developed a trusting relationship.
And with a paranoid patient, especially if a paranoid patient is paranoid towards you, first I ask the question, do you at any time have those kinds of thoughts against me? And initially they are hesitant. I say, the reason I'm asking this question is because if there is anything that I'm saying or doing that is increasing those thoughts, I want to know, because I don't want to cause that to you. Guess what? You have told them where you stand. You have showed them, because I love when the individuals are paranoid against me, because I have the proof right here in front of me to show that your delusion is wrong.
Okay. Right. Very good. Very good. Before I close this session, with permission of Dr. Raghuram Reddy, I just want to make one comment. I am really impressed with the organizers for the awesome getting together of this very difficult meeting online. I'm sure there were lots of technological challenges, but overall, I think this is probably one of the best online meetings that I've attended. And my role is going to be coming to an end with this one. And I really want to thank everybody for allowing me to be a part of it. I'm really honored. Thank you very much.
Thank you.
Dr. Mukesh,
Yes.
small thing. Your role has not ended. In future, you must make presentations. Your experiences are important for us. I know your depth of study of patients. Thank you.
Absolutely. That would be, again, my privilege and my honor. Would love to do it.
Thank you for the wonderful speech, Dr. Narasimha Reddy sir, Dr. Raghuram Reddy sir, and Dr. Mukesh Singadia sir. Now moving on to the next session. The topic is an update on ascension of IMH by Dr. M. Umashankar sir. The first chairperson is Dr. Krishnamurthy, who has done MD from NIMHANS Bangalore and is a member of the Royal College of Psychiatrists. He was a PPA awardee in 1987. He is the superintendent of Institute of Mental Health, Hyderabad. He is proud holder of ICMR Community Fellowship, Japanese Government Fellowship, and several others. Second chairperson for the session, Radha has done MD from Medical College. She has been working in government hospital for mental care in Visakhapatnam since 1992 and became its superintendent in 2014. Officer, member secretary of the state mental. She has played a pivotal role in restarting the program and Center of Excellence for GH. Published papers in international journals and around 20 national journals. Now I hand over the session to the chairpersons and the speaker.
Hello, can people hear me?
Yes, sir.
Okay, thank you. Then, okay. So shall we start the session? I can't see Dr. Radharani.
So, good afternoon, sir. My video is disabled by the host.
Okay, okay. See, I had the same problem. I think they'll take some time to enable it. Yeah.
Yeah.
Yes.
Yeah. I think I'm busy.
Yeah, we are back in. Yeah. So welcome all of you to this very nice webinar which has been organized by the IMH alumni. It's a pleasure to be part of this. Well, I've been in IMS till 2004, and I then went and joined the National Health Service in UK. And then after retiring from the National Health Service, I'm now working in the private sector in the Forensic Psychiatry Department of Signet Hospital in Greater Manchester. So that's where I continue to work. It's been a real pleasure to join all of you. So before I introduce Dr. Uma Shankar, the eminent speaker for today, I thought I'll give a background about this great institution, the Institute of Mental Health, from where so many great students have passed out. As I recall, we had the Institute of Mental Health moving from Chanchalguda prison to Jalna. And from Jalna, it moved to where the current location is, which was actually a part of the Royal Air Force. And the first superintendent who came with the train which brought the patients and the contractor was Dr. Natarajan, who was the superintendent of the Institute of Mental Health, Hyderabad. Then Dr. Shiv Kumar Shastri Sista took over. Maybe I'm missing a few names here and there. Then Dr. Nilkant Raj Yadav was the superintendent. Then we had the eminent Dr. Raghuram Reddy, who's been the legendary figure of mental health in then Andhra Pradesh and now Telangana. Then I had a brief stint as superintendent. It was followed by Dr. Gauri Devi, and then Dr. Pramod Kumar, and then we have Dr. Uma Shankar, the present superintendent. I welcome all of you. And before I hand over, I'll just give the format. I'll introduce the speaker, Dr. Uma Shankar, and after that, I request Dr. Radhani to take over the concluding session. Is that okay? So Dr. Uma Shankar did his MBBS in 1992 from KMC Warangal. He did his MD in Psychiatry 1999 from Usmania Medical College, Hyderabad. He worked as Professor of Psychiatry at HOD at Gandhi Medical College, and then took over as superintendent since 2016. He's been member secretary of the State Mental Health Authority of Telangana State and the CEO of the State Mental Health Authority. He's occupied several positions as past president and general secretary of IPS Telangana, and also joint secretary of the AP Chapter State Conference. He is now currently the principal investigator for OMC for National Survey on Extent and Pattern of Substance Use in India, conducted by the National Drug Dependence Treatment Center, AIMS, New Delhi. So Dr. Uma Shankar has been very active in the field of mental health. It has been my privilege to have worked with him as a colleague. I now hand over to Dr. Uma Shankar to make his presentation, and after which Dr. Radharani will offer her concluding remarks. Dr. Radharani has also been a colleague of mine in Institute of Mental Health, Hyderabad, and now she understands she is at the Institute of Mental Health. I don't know what it's called, or maybe it's called the Government Hospital Mental Care at Visakhapatnam. But she's a professor there and superintendent, and she's been an eminent colleague of mine. And it's a pleasure to chair this session along with Dr. Radharani. My regards to you, Dr. Radharani.
Thank you, sir. Thank you.
Dr. Uma Shankar, over to you, sir.
Thank you very much, sir, for your kind words, sir. Can you have my presentations, please? Okay.
Yes, sir.
Full screen. Full screen. Okay. Good morning, all of you. This is a pleasure to be here in front of my teachers and seniors and my students and colleagues. And this is my privilege to update an ascension of IMH. I think since almost 96, I am in the IMH. I studied there. I worked as assistant professor, associate professor, and professor. My guru, Dr. Krishnamurthy sir, and Dr. Krishnamurthy sir, I learned a lot. Thank you very much, sir, for chairing this session. And also, I'm happy to see Dr. Radharani Madam we shared so many things regarding the mental health, all those things. Thank you very much for sharing the session. Thank you. Next slide, please. Next slide, please. This is the entrance right now. This is the beside one is the past the entrance. The Institute of next place. The Institute of Mental Health Eragadda, also known as Eragadda Mental Hospital. Suppose most of the people in even sometimes in assembly also says in the fighting says that I'll send to the mental hospital Eragadda. That is the way everybody knows that Eragadda Mental Hospital. It is situated in the Eragadda and established by Nizams in the Hyderabad state. It is run by the government right now. It is run by the government of Telangana, and it serves the patient with mental illness from all over the state and also neighboring states of the AP, Karnataka, and Maharashtra. Next slide, please. And it is established as the Darul Majnan. And the meaning of Darul Majnan is it is a mental asylum. Initially, it was started as an asylum. It was most of the patients were kept in like almost just like a jail. It was in the at present Chinchalguda jail is there. There it was started and with 400 beds. Then after it is shifted to Jalna, it is in Maharashtra right now. The institutes were moved to Jalna, and from there again that after formation of Hyderabad state, it is shifted back to Hyderabad in 1953. And while Jalna is right now, it is in the Maharashtra. While shifting the patient, the last superintendent, Dr. R. Natarajan, was the last superintendent of the Jalna. He, along with the patients in the trains and buses, everybody shifted to IMH Hyderabad. So that is a place right now where we are working. And initially it was started as a sheds. After that, in 1950s, they constructed the present buildings. It is a 600-bed hospital right now. It gives services to medical, teaching, and research activities will take up. This is only the place in even most of the places. This is the place where we treat most of the prisoners, those who are admitted in the mental hospitals. Those they will be referred to here. We have a separate place for the keeping the patients in the ward, that is a forensic ward. We give here services like outpatient services. Daily almost 400 to 500 patients, they will be coming to the hospital. All the patients, new patients around 50 to 60 patients will come. Rest of the patients are old patients. Everybody is reviewed and given the free tablets, and most of the tablets are given and it will be uploaded on the same day to the pharmacy to know the count, how much. This is the auditing. As well as we have inpatients almost at a given time. Before this lockdown, almost it was 450 to 500 patients were there. During the lockdown, some of the patients got discharged. Now it is around 350 patients are available. We have some lab facilities also. So we have a lab. In that we do basic investigations. Suppose if any investigation is not available, we have to send the patient to the Osmania for test getting done and also fitness regarding the medical people. Even we give ECTs, we give modified ECTs only. No, we don't want to give ECTs without anesthetist. That is the reason we give only modified ECTs. Even we have a good psychological department. We do psychodiagnosis services and psychotherapies also give. Even certification. Because of now governments, most of the government, they are giving some remuneration to the people, those who are mentally ill. For them, we certify. That is under Sadaram, we issue the certificate. Those people will get benefited financially. Next slide, please. we have a cadre strength of right now we have 6 professors and also 6 associate professors, 21 assistant professors, and 6 senior residents. And the postgraduates every year 14 seats are available since last 2 years. Now presently we have 40 students. All the diplomas, previously we have 4 diplomas. All the 4 diplomas are abolished. Everything is converted into MD seats. Thank you. Next. This is academic activities. This is not only the servicing center, we have a good academic activities. Every day till 2 o'clock, most of the OP work and ward work will be completed. After that, we'll go for the teaching programs. So monthly, we have a teaching program, out of which every week we have a case conference, we have a general club, we have a seminar, and also group discussions. Like that, every week we have a teaching program. And also we teach the undergraduates and nursing students also. Medical college people, they give a circular. Now it is a mandatory to have psychiatric posting for the undergraduates as well as the house surgeons. 15 days, they will be coming to our hospital. We arrange. So after coming them, we'll arrange how to take the history. The important cases will be explained to them. For senior house surgeons, we allot the cases as well as every student, they have to present one topic. We allot the students a topic wise, 15 topics will be allotted. That will be on rotation. Every student, they have to present in the just like a seminar. That is mandatory before getting the certificate. Even most of the medical colleges doesn't have forensic psychiatric facility. This is the institute where we have forensic ward. Here, most of the medical colleges students will be given the posting for 1 month. Even some of the students from the Karnataka also, they come for the forensic posting. And also we do some in-house CMEs regularly as per norms by the university, as well as some of the things through our senior colleagues. Whenever they visit the Hyderabad, we take up some of the CMEs. And also we are also involving in the research activities. Now recently we completed one of the national survey, that is the national survey on extent and pattern of substance use in India. It is organized by this AIMS Delhi. We are the part of that. And also now also one more research activity with the collaboration with the NIMHANS. Again, we are going to join with them. Next slide, please. These are the places we used to have a learning. These are the places. This the first one is the this is one is the old auditorium. We have a discussions here. This is the new thing. This is a part of the Center of Excellence building. All the chairs and everything is arranged here. It is a good place. So this is some of the things are donated by the students, as well as we saved some of the money from the organizing the CMEs and the conferences, and we brought all the things. Next slide, please. And here diploma courses started in 1979 and MD courses were started in 1984. Initially only 2 diplomas and 4 MDs were there. Almost till 2011 were there. Initially diplomas or MDs were not recognized. With a lot of struggle, almost in 2009 we got recognized retrospectively all the MDs and diplomas. Now after that, there is an increase of seats from 2 to 4, 6 MDs, and also by reducing the 2 diplomas to 2 diplomas. It was still 15. After that, again it was increased another 2 MDs, it became 8. After that, again it's from 8 to 12. Like that, gradually we increase. Now it is since last 2 years, we have 14 MDs. Completely all diplomas were abolished. And for this, we not only CMEs for PGs, we also take up some of the medical officers. Under National Mental Health Program,
commissioner of Vaidya Vidhana Parishad, they are sending some of the doctors. Now, under National Mental Health Program, every district hospital should have one psychiatrist. So where the psychiatrists are not available, what we are doing is we are training those doctors will be deputed to the IMH. In the IMH, for minimum 3 days to 1 week, we are training. In the part of training, we are showing the patients as well as the we are giving some lectures to them. Next slide, please. Our postgraduate students regularly they are presenting the papers in national level, state level, and they got so many accolades in this process. We conduct some of the censorography also for judiciary. What happened?
Attention to organizers. Attention to organizers, please check the noise.
Okay, thank you. Yes.
Please take over, Umh Shankar.
Okay. Hello?
Take
Please
over,
go
Umh
back.
Shankar.
Please go back.
Carry on, Umh Shankar.
No, go back to the slide. This is the forensic ward. This is the entrance. Hello? Hello?
1 second, sir. Yes, sir. Continue, sir.
Go back.
So much into
some of the slides are okay. This is a okay. Next, okay. After that, this is
Next
a slide.
slide.
Okay, fine. This is a slide. Okay, fine. So we were doing as a part of this new Mental Health Care Act. We are training some of the officers like judiciary as well as police people. Regularly, we are training them in the mental health issues. Our institute okay, next. Even our people also training the DM. Most of the people from the Usmania Medical College, DM Neurology students from NIMS DM Neurology, and also Ayurvedic students and nursing students also, they come for the training at IMH. And also, we recently, after discussing with our Director of Medical Education, they have given regularly one senior resident of anesthetist and one general physician. He was deputed to IMH. So any physical problem is there, we can take up in the IMH itself. Next slide, please. This is the building constructed long back. This is a OP building where all the OP services and lab services will be taken up. Next, please. This is the forensic ward. This entrance. One more slide. Next. This is the entrance to the forensic ward. It is opened recently in the 1916 and 2016 it was opened, and this is a lot of greenery was developed within this thing. So here 50 beds are there at any given time. Some 20 to 25 patients are admitted. Even here, most of the even VIP patients, whenever they are coming, there are some of the wards are created for them. We are keeping the patients there also. Thank you. Next slide. This is the ward. Next slide. Next, please. Next, please. Next, please. This is the place where our APCU. Next, last slide, please. Go back. Yes, this is the place. This is the acute psychiatric care unit and de-addiction ward. Both of them are here. Here we keep the patient. Whenever the patients, as morning Dr. Agram said that now, whenever the patient is coming after registration, usually registration will be done from 9 to 11:30. After that, most of the patients are not attended. So that is the reason what we are doing is whenever the patient is coming after afternoon, after registration, we are keeping the patients in case of emergency, that emergency come observation room, we are keeping the patients. And after that, when the patient is admitted, where a patient is very agitated, we are keeping those in the acute psychiatric care unit. Here, 24 hours doctors will be available, because nowadays there is a lot of number of PGs are available. So at any given day, 4 to 5 postgraduates are on duty. That is the reason here one postgraduate always it is available here. This is the place for the emergency. Next slide, please. This is the thing we does some most of the times for the recovered patient. Some yoga activities are taking up here. Our yoga instructor, Dr. Mr. Murthy, is there since very long time. He is working here. Now even some of our postgraduates also, they know yoga. They are also helping us to getting the yoga. Now little because of this COVID, some of the things are we cut down. Again after this, again we will go back to yoga therapy for some of the patients, those who are recovered mentally ill. Next slide, please. These are the closed wards. Whenever it is very long back, Dr. Raghuram Reddy sir period only, they made closed and open wards. There is some meaning for that, because closed ward patient here, most of the times patient is not willing, patient's attendants are not willing to stay along with the patient. Even patient is very much excited. In that way, what they do is here we put most of the voluntary patients, those who are assigned for the admission in the ward, and also some of the court ward admissions through the magistrate admissions, and also some of the special circumstances also we admit the patients here. Okay, here patients once admitted, they cannot go just like that. Even after discharge committee meeting only, if they feel for fit for discharge, then only they declare fit for discharge. They'll send the letter to the concerned authorities. After permission, them only will release the patient, and we hand over the patient through police magistrate, through the police station, or the attendants directly sometimes. Here, food, everything will be given in the bedside only. Especially these patients will be provided breakfast, lunch, and dinner in the hospital itself. In the open ward patients here, most of the patients will be staying along with the family members. It was started in 1984 by Dr. Raghuram Reddy sir, and here patient can be admitted voluntarily, and also one attendant will be there along with the patient, and the patient will be educated along with the attendants, because most of the times patients will be, because of they deny the illness, they don't take the medication. So what we do is we try to educate the attendants to get the treatment, continue the treatment regularly. Next slide, please. These are the closed wards. So here closed wards. Please next, all the slides, please. This is the closed ward. This is a male closed ward. Now we provided some of the cameras also. So previously, some of the patients used to run away, escaping, and also quarreling with among them. Even sometimes these MNOs will be try to beat them to protect them, to avoid assault on them. We kept some of the cameras in the ward, in the verandas, and also examination points, except in the some of the places which are private to leave the privacy, we not kept, but most of the places we kept the cameras. This is the female ward. This is the female ward. This is the ward. These are the entrances of the male closed ward. Next slide, please. This is the family ward, actually open ward. Next. This is the entrance of the open ward. This is the open ward. It constructed when the Dr. Krishnamurthy sir was there. It was constructed, and a little bit we did some renovation, and also we put some of the trees. It is a more greenery. This photo is a very long back photo. It is we developed a lot of greenery in that, and also these beds are we are maintaining even lighting as well as maintenance. Also, we're trying to do better So every patient will be given the bed sheets and everything will be changed. Why? Because we could maintain so much of hygiene. Means government of Telangana, they gave 150 workers extra in addition to that. So out of which are 50 sanitation workers, 50 are patient care, 50 security. In that way, that is the reason we could. Here, food will be served. Here, previously we used to have a kitchen. There we used to cook on gas all things. Now it is only the steam cooking. We are doing the steam, and also these tables are for the closed ward patients. Next, previous slide. Here, most of the patients they come to the dining hall. They can sit comfortably. Like almost most of the people, they know that in Tirupati tables are like this. These are the chairs. Most of the chairs will be foldable chairs. So these where they can sit comfortably. They can have their lunch, breakfast, and dinner. They can go back. After that, they will be cleaned. So we are regularly we are giving 2 eggs, 2 plantains, and also sufficient food for them. Next slide, please. Actually, this is the most important thing. Actually, community psychiatry services started in Shankarpalli. This is in Medak district in 1980. It is almost 2 years before NMHP initiation of starting community psychiatry. That is shows our Raghuram Reddy sir vision towards the community psychiatry. So after that, after initiation of NMHP, we extend our community service to other parts of the Telangana. Even when the Krishnamurthy sir was there, the NMHP program, under NMHP district mental health program started. Entire Medak district highway satellite centers, almost 5 satellite centers, we used to go and used to serve. Now it is NMHP taken by the commissioner. They are organizing now, and NMHP, most of the districts, they have one psychiatrist. They are looking after the services. Whatever the services like training, we are doing IMH as a nodal center. Every month, our faculty will be going to this Aramgar, Bansilalpet homes. These are the old age homes as well as the district homes. And as well as along with that, we used to visit Chanchalgoda and Cherlapalli. There, our recovery patients will be reviewed, as well as if any new patient is also, we treat there itself. Otherwise, we'll bring to the IMH after formalities. Next slide, please. This is the important center of excellence. This is government of India in the 11th year plan. That time they were sanctioned 9 center of excellence centers throughout India. Out of 9, one is our Institute of Mental Health. So Institute of Mental Health, that was sanctioned in the June 2009 because of various reasons, because of change of government, so many problems. We could not start the center of excellence. In the 2017 September, we laid the foundation stone by then he's the Lakshma Reddy, Minister of Health and Family Welfare, and he is our MLA. They consented and the foundation stone, and there is here it is a inaugural function. That is the foundation stone function was done. Next slide, please. With after 2 years, we could able to construct that building, part of the building. Not is the entire building is only we got only 5.28 crores sanctioned in the first part. Out of what 3 crores was for the building. That part we spent and we inaugurated. In that we are utilizing the services and we are doing it. Here it is inaugurating our Honorable Health Minister, Little Rajendra Garu, and also DME Dr. Ramesh Reddy, and other local leaders, MLA, whatever is available. Thank you. Next slide. This is all. Next slide, please. This is important. What I thought is even super chamber also we have the monitoring system. So everywhere here all the 16 cameras available. This is entire administration, even OP, everything will be monitored from the super chamber. So okay, any patient is getting any not getting any treatment or anything is directly we can watch, we can instruct those people to services make it available. So here it is installed in 2017. And also what we did is, after speaking to the GHMC people, entire hospital also, we made a good lighting to avoid any problems in the night. That also done by the help of the chairman, Sridevi Garu, IAS officer. She took the initiative and she did all the things. And also one more important thing we are doing is we are providing the food. Previously what we used to do is, most of the family ward patients, they used to cook themselves in the ward. So to lessen the burden on them, some of the NGOs, we spoke to the NGOs, they are providing lunch and dinner, even breakfast also sometimes. In the OP, the almost 400 patients they'll come. Some of the patients get delayed going back to home, and also admission process. For them, almost daily at OP, we'll serve 100 meals to the patients who are staying back. So in that way, even OP as well as IP also will providing the lunch and dinner to patients. The important thing is we started some legal aid clinic. This is the very important. What we thought is, most of the patients, underprivileged patients, they're difficult to get the legal aid. That is the reason here we started legal aid clinic. Here one lawyer will be coming, and also paralegal volunteers also, they're coming twice in a week. If any problem is there, they can approach to them. These people will be helping them to get resolve their problem. As well as whenever the patients, long-standing patients, we are not able to discharge, some discharge problem is there, we are taking the help of them. They themselves, they go to the state authority and they are discussing with them, and also they're talking to the concerned magistrate, and they are helping us to get discharge the patients. In that way, we are getting a lot of help from them. Next slide, please. This is the administrative faculty. Administrative AD is there, RMOs are there, dietitian, everything is, even deputy superintendent, everything is available. This is the administrative faculty. Next slide, please. Thank you, sir. This is my essence of the IMH. Over to my chairpersons.
I'll have to unmute my mic. Okay. Dr. Imh Shankar, thank you very much for your presentation. I can see that IMH had made rapid strides, a lot of developments. There's a new criminal ward building, which I can see. But there's still a long way to go compared to what the Western countries are. Of course, there can be no comparison, but nice to learn that the patients are getting some benefits from the government, and that is encouraging. We'll also have to strengthen the follow-up services in India. Like we have got some laws in the UK, like community treatment orders, where a patient has to be monitored in the community to see that he's safe. And we've got various conditions of the Mental Health Act. So lots of improvements have to take place, but that's a slow pace. I've been in India, I know how difficult it is to get things moving, but you've done a wonderful job, and congratulations for that. I hope the IMH continues to improve under you. I now request Dr. Radharani to take the questions. Thank you very much.
Thank you, sir.
Sir, thank you very much, sir. Thank you, Dr. Imh Shankar, for your excellent presentation and showing all of us how the hospital was before and now how it is developing. And before going for the questions, I would like to thank all the organizers for giving me this opportunity to be with as part of the alumni. And it's my immense pleasure to see all my teachers and all my senior colleagues of the seniors of the alumni and the juniors, and also my teachers, especially Dr. Raghuram Reddy Garu, Dr. Ramakrishna Garu, Dr. Krishnamurti Garu, and others, Dr. Gauri Devi, Dr. Niranjan Reddy Garu, to see all these people. And mainly I would like to thank all of them on the same platform for giving me such an excellent position by teaching me all the skills, not only academic, but also the administrative skills. As I have worked, after completing my education, I have worked there for a year, even though it is short period. I have learned many skills which are helping me in my administration now. And I would also, it's my pleasure to chair this session on the same platform along with my Professor Dr. K. Krishnamurthy Garu, under whom I worked as a tutor in the initial stages of my career. And he was an excellent teacher and also a good like administrator too. And I still remember how he used to dictate us the certificate writing whenever we issue a certificate for a criminal case or a civil certified case, which are referred from the magistrate by the magistrate. Actually, now after becoming professor, I've noticed the importance of drafting that type of certificate. I still remember how he used to take care in correcting us whenever we write a certificate. So thank you very much, sir.
Thank you. It's been a pleasure to work with you.
Sir, and I thank all my teachers for making me to attain this position. Thank you all. And also, it is nice to see the parent institute of mine, which I had my post-graduation and I completed my DNB from the same institute. Even though the stay was a short period, but every time it will be in my memories, and it is an unmemorable thing for me in my life, which has shaped my entire career into a different thing. And because of that institute and because of Dr. Raghuram Reddy Garu and other teachers, I'm still, I think I'm able to do the administration and continuing as a superintendent. Thank you all. And coming to the present topic and Dr. Uma Shankar, I know how hard it is to develop an institute in the present situation, and he is working very hard to bring the institution to this shape. And before, I used to come to the institute many times. I visited the hospital, but not in the recent past. So after, in the recent past, there are a lot of changes. Like even I didn't see the criminal ward also, new criminal ward also. Now there is a lot of development in the hospital, and as Dr. Krishnamurthy sir said, it is still, we require much more to do for the institutions. Whatever, how much we do, it is very less when we compare it to the Western countries. But I feel proud that you have developed the institute to this extent, and I congratulate you for this, and I think I'll wish you the best of luck for future improvement also, for further developments also. Now it is open for questions. Any discussions? I'm not able to see anything on my screen. If anybody has any questions or any...
Yes, here one question is there, madam.
Yeah.
And do we use any scales to measure the severity of symptoms before start of therapy and also end of therapy? I think this
that is for the previous session. I think
previous
session.
Hello. It's not particularly a question, but just a comment, really. This is a great platform. I'm really honored and privileged to be here. And just looking at the pictures in your presentation, Dr. Uma Shankar sir, brings back so many memories of IMH, and some of the buildings are so sort of brand new. They're obviously more recent, and it just shows how much time, energy, and sort of leadership is invested in bringing it to this new standard. And just listening to the number of MD seats we have got, and the number of psychiatrists we are training in IMH, I think you're doing a great job of putting mental health right in the forefront of healthcare policy, really. So really encouraging developments. Thank you.
Thank you, Kiran. Thank you.
Sir, there is a question, sir, to the thing like its speaker, like it says from Dr. Sudhir, sir, to kindly share the details of National Substance Misuse Survey.
Okay,
Sir,
definitely. Definitely, I share it. There is a lot. Book is there, even a hard book is there, even a soft copy is there. I don't mind sharing it. I'll share it. Please share your email address. Definitely, I'll share it.
Kriti, Kriti.
Dr. Ashok Ravi wants to
Ashok.
say something. Dr. Ashok Ravi.
There's only one.
Dr.
Hello?
Ashok Reddy, sir, raise
Dr.
your
Ashok
hand.
Reddy,
Sir?
I think you raised your hand.
No, Supriti has no.
Madam, one comment. As the
Yeah.
Madam Radharani Madam said, is very true. We learn a lot of things from Krishnamurthy sir, Gauri Devi Madam and Raghuram sir, all the things. How to write this very important. Nowadays also, most of the times they'll come with some draft. So after listening that, we have forced to change some of the things because I used to learn some of the specific words will be there. Krishnamurthy sir words specifically, that word should be there. In that way, he used to educate us. That was wonderful,
Yeah,
sir.
I remember. In those days, we used to think he was.
That's right. Sir, whenever whatever we write, no, sir, suddenly compulsory used to change some of the things. Okay, in that way, now also our some of the assistant and professors used to say, okay, after coming here, again you are making some changes. This is compulsory, sir, whatever it may be. But that is we learn from our professors like Dr. Krishnamurthy and Gauri Devi Madam, Raghuram Reddy sir, and these people. There are very lot of things, sir. Thank you very much, sir.
Dr. Umashankar, one comment from my side.
Please.
So the present institute is a lot of developments under your administration and your leadership. There are a lot of private medical colleges headed by the IMS students, like Dr. Sharavandra, Dr. Ashok Reddy, now even myself, and a lot of institutes came up. But our students outside are not able to expose to the IMH Hyderabad. So can you provide 1 week posting a request of HODs of private medical college? They can see what is the structure of criminal ward, what are the procedure. At least 1 week is enough. Even that is for a full time. They can say how you are receiving the patients, how the ADMO pattern, how the pattern of DMO working, or where is the how the structure of administration, as well as from admission to discharge, what is going on. So everything, the whole any psychiatry PG, whoever educated from Telangana must expose to the institute. Probably that will improve their understanding. I think this is a submission from my side on behalf of other medical college to Superintendent Umashankar and Superintendent Institute of Mental Health. Thank you. Over to
Question, sir, I don't mind providing 1 week, sir, but I think it is 1 week is not sufficient for them, sir. Just coming and going only 1 week. If they come for minimum period of 1 month, they can learn something like forensic psychiatry. They can learn the admission discharge procedure. Most of the medical college, they doesn't have the involuntary admissions like that, by even special circumstances. If they want learn, you can send for 1 month, as well as you instruct all the people to attend regularly. That is also very important. What they do is after joining back, okay, they don't appear, they disappear. Again, they'll come at the end and they ask for the attendance. This is the problem I am facing, sir. Suppose if you send it, we don't mind, because of their future psychiatrists, they have to serve the society. We can support them. You send proper channel letter along with them, we'll support, we'll train them. There's no problem. And also I'm appealing all my seniors and those who are even abroad here and everywhere, they can support the institute by providing some of the journals or some of the improving the community psychiatry services. Like that, we try to improve. As Krishnamurthy sir said, whatever we do, definitely we are not on par with the Western things, but we try our level best to things get better. That is my way of thinking. But everything not come in a 1 day. We have to. It definitely takes a long time to achieve some of the things. We have to struggle for everything. Otherwise, we cannot get the things. As sir said, government is not in a position to give what we ask. So even mental health is last priority, even government, many times we attended the meetings, they will be calling last. So whatever the review meetings are, they will call now. But when I joined, I used to just sochukoni povam, that is I'm doing sometimes because of some of the people may be knowing to me. In that way, I'm trying to get the things done. We are giving most of the medicines, even whatever the new medicines come, we are providing to the inpatients all the medications, even outpatients, whatever the medications we are giving. In that way, we are trying our level best, the things done. Definitely, with the support of alumni, still further, we can improve the services. Thank you, sir.
In this present context, actually, I had the privilege because the Director of Medical Health Services had a provision earlier. So when I was the first candidate, when I joined, I had a privilege of going to NIMHANS for 1 month. Actually, this provision was there because there are facilities available as elsewhere. With the permission of the Director of Medical and Health, we could take the permission, and I had the fortune, with the help of Dr. Ram Reddy Garu and Dr. Krishnamurthy, to go and live in NIMHANS for 1 month. College students to come and attend at mental hospital. That will be really worth it.
Definitely, sir, we do it, sir. No problem, sir. That's within the state, there is no problem, sir.
I think before we conclude this session, I once again, it is my privilege to be associated with Dr. Krishnamurthy sir in chairing the session. And I thank you very much, sir. And I thank the organizers for giving me this opportunity to thank all my teachers on the same platform. And I am delighted to see all the members of the alumni taking up a very good position globally and doing very well. And I think, I hope that we all should be able to do something for the Parent Institute and thereby to the community and to the society. Definitely we'll try to do something. And I thank Dr. Raghuram Reddy Garu and the other teachers, Dr. Ramakrishna Garu, Dr. Krishnamurthy Garu, Dr. Gauri Dev Garu, and psychology professors, that time Dr. Jhansi Lakshmi Madam and Niranjan Reddy Garu. And I would like to tell all of you one thing, that because I think I was the first lady postgraduate in IMH. By the time I joined, Dr. Gauri Devi and Dr. Bhuvneshwari Garu were there as teachers, but first lady postgraduate. So I used to get a lot of attention as well as support from all the faculty members and the staff of the hospital, being a female postgraduate, first female postgraduate. And I thank all of them for giving me the support during those years and bringing me to this stage. Thank you all, and my pranams.
Now female postgraduates are more, madam, than male.
I know. After me, 1 year after that, Dr. Purnima joined, registered for DNB and joined. Later on, many female postgraduates have come up. Even in our institute, out of 19 students, 17 are females and only 2 male postgraduates in psychiatry. So this is how the status is now. And thank you all.
Thank you all very much. Thank you, Dr. Umashankar. Thank you, Dr. Narani.
Bye.
Thank you, respected professors. Moving on, our next session is Challenges in Psychiatric Practice, which is a panel discussion by Dr. Keshav Rao, Dr. Kishan, Dr. Sridhar Raja, Dr. P.V. Kiran, with the chairperson being Dr. K. Chandrasekhar sir. He has done his MD from NIMHANS and is currently working as a managing director and senior consultant in psychiatry at Asha Hospital. He has also been conducting DNB course in psychiatry at Asha Hospital since 2006. His special areas of interest include neuropsychiatry, geriatric psychiatry, and mental health legislation. Over to the chairman.
Am I audible and visible?
Yes,
Visible and audible?
Yes.
Okay, thank you.
I'm requesting organizers to allow me my video. Something block, some technical people are blocking my video. You can
Can I continue?
So please start, sir.
In fact, I am very grateful to the IMH Alumni Association for having included me in my program. The only qualification I think I have to be in the proceedings is that I was in IMH between 1982 to 1988 as the faculty. And it was during that tenure that we started the first batch of MD in psychiatry in IMH. And I was fortunate enough to be in the team of the faculty which trained the first couple of batches of MD in psychiatry. And today, I was really proud to see two of my students, Dr. Narasimha Reddy and Dr. Mukesh, reaching the great heights. It was in fact a very fulfilling experience. There are fond memories of IMH during the few years I worked there. In fact, sometimes when I see the logo, I'm reminded to tell, at least I should go to a little bit of the history, that this logo was designed by me and Mukesh Sangadia. Long back in 1985, when some conference was happening, we thought of creating a logo for IMH. That's how the logo took shape. And I'm happy that it still continues to be there on several banners of IMH. And now coming to the topic of discussion today, on the panel, we have very eminent panelists, all well experienced. Dr. Keshav Rao, who has got experience in 2 continents, frequently shuffles between United Kingdom and India. He has got vast experience. Dr. Kiran, who is again in UK and practicing there. Dr. Sridhar Raju and Dr. Kishan, both working in different parts of Telangana, and in fact are quite conversant with various challenges of psychiatric practice in the state of Telangana. Though there are several challenges in psychiatric practice, let us try to limit them to few important areas. What I look at it is, there is a challenge of translating the knowledge gained from advanced research in psychiatry to the day-to-day clinical practice. There is a challenge of limited human resources in mental health and how to cater to the vast population these limited human resources. There is a challenge of ethical practice in psychiatry and how one translates the basic medical ethics and psychiatric ethics into one's own practice. And in Indian context, there are several challenges of various traditional therapies which interfere or sometimes which complement our basic treatment modalities. And there are various religious and cultural connotations to most of these therapies, and how we are challenged into accepting or discarding those treatment modalities. So there is another challenge of increasing awareness about health issues through, say, internet or various social media, and how they interfere with the current clinical practice. So you can list out several challenges in clinical practice of psychiatry. Of course, we also have the challenge of certain situational challenges, like how we are facing the challenges in the COVID-19 epidemic. So there may be some more crisis situations where we face some challenges in the delivery of mental health care. So with this introduction, probably I will request my panelists to focus on some of these areas during the next 45 to 60 minutes. And what I thought was the pattern will be that each panelist will speak for about 15 minutes. At the end of it, probably, I think if the organizers, I hope the same amount of time is being allotted, is not cut short. So or we can have about 20 to 30. Excuse me, to the organizers, is someone going to introduce the panelists, or
You can self-introduce, sir. It might save time.
Okay, sure, sure. That's better, I think. Then I'll start. Then I'll start my panel discussion with Dr. Keshav Rao, and let us see what he has to say about various ethical dilemmas in psychiatric practice and how they pose a challenge to our day-to-day clinical practice. Over to you, Dr. Keshav Rao.
Sir, I'm Dr. Keshav Rao. I did my MD in 1994 to 97, and thereafter I worked for another 2 years as assistant professor. And before that, I was in government service for 16 years. I worked in the primary health centers, AP Vaidya Vidhan Parishad. So I put up about 17 years of total service in government. Then I got this opportunity under ODTS scheme. At that time, Dr. Raghuram Reddy sir and my friend Dr. Sudhakar Rao in UK, they both were instrumental in sending me to UK. And it was a good experience, but I had to leave the government service because of that. Sir, this question, because I worked both in England and India, probably I compare things and give some kind of insights from that angle rather than giving a scientific talk. Ethical dilemmas in practice and instances where you are expected to opine or handle non-clinical issues. Things are very clear in UK. Actually, you don't have much scope. Everything is well defined. There are clear laws. There are clear protocols. And particularly in, you don't get into this kind of ethical dilemmas, particularly if you are trained in, you are a UK undergraduate, they just follow the rules. Suppose, for example, in India, we prescribe medication without patient's consent. We prescribe, we hand over the prescription to parents, and parents, without the patient's knowledge, give the medication to the patient. These kind of things are totally not acceptable in UK. Even in India too, we are moving towards that direction. We are moving in that direction. The younger psychiatrists, I don't think they are giving prescriptions without the patient knowledge, this kind of thing. And it is not safe also, because the human rights, patients' rights have become more important, and we cannot break the law. So actually there was a discussion at the South Zone last year in which I gave the talk, whether you have to follow the morals or ethics, morals versus law. The law is ultimately important. When something is clearly defined in law, we have to follow the defined law. And the remaining things, always this conflict of thing. In UK, particularly for every interview, they will ask about conflict, particularly conflict with other staff like psychologists, other ones. I answered once, where is the conflict? If I put the patient interest in the first place, there will be no conflict. If I put my interest, my profession psychiatry versus some other profession psychiatry versus psychologist psychiatry versus occupation, then the conflict comes. If everyone puts the patient interest first, then there is no conflict. So in India, we all put the patient interest first, but at the same time, we have to be aware of the law, particularly when there is a clearly defined Mental Health Care Act. We have to follow that act. I think, sir, that is my opinion on this. Do you want me to take up the following questions, or you want to ask the question again? Probably you need to read the question again. Hello, Chandrasekhar, sir. Hello. Hello.
Sir, attention to Chandrasekhar, sir. Sir. Sir, please unmute, sir. Chandrasekhar, sir. Please unmute, sir. Yeah.
See, sir, should I read the second question and I will go ahead?
Yeah, I thought I gave the questions. So that
yeah, sir. Yeah, okay, sir.
And you want me to read them?
Yes, sir. You can read, sir, for the benefit of everyone.
Yeah. How to circumvent the problems surrounding controversial diagnosis and controversial treatments, especially in the course of the clinical practice. For example, say there are different opinions about administration of the ECTs. There are different versions about the diagnosis. The cultural aspects of diagnosis sometimes come into conflict with your professional diagnosis. For example, say any, especially with reference to sexual disorders. Right. So, yeah. Though homosexuality is no longer a crime, for example, the parents come and say, do something for this boy. So there are some ethical and controversies which we have to address.
Yes, sir. Yes, sir. This homosexuality is a very more recent, and the Indian Psychiatric Society is very interested in this topic. I have seen some discussions in the national WhatsApp group that we should not offer any treatment. I know of one case in USA where the psychologist, they wanted him to remove his name because he has offered psychotherapy for someone who wants his sexual orientation. They said, how can you change? How can you offer treatment to someone who is normal? Right. Actually, sir, I had one patient about 6 months ago. This person is about 27-year-old person, homosexual orientation, had a kind of relationship with another fellow of his same age. But when it came to marriage, he married his cousin, close relative, very close families. And he said that he thought that he would be able to perform because because he used to have erection, no problem. He thought he could perform here also. But then he failed. And this is about 3 months ago, I think, failed. And then he visited two, three psychiatrists. He came to me and he said, "Sir, this is my last attempt. If I don't improve within a month, I'm going to commit suicide." He did not give his phone number, and I'm sure he did not give his correct name also. So this is not in a situation like in UK where you take the step to inform police or something. Okay, I said okay. Then fortunately, one of our psychologists, he said that he has previously managed some, and I referred to him. I don't know the outcome of that one, but even in many young psychiatrists in India are now believing that we should not offer treatment. But in this case, I felt that since the person himself is asking for treatment, and we should offer treatment. Opinions may be divided, but we should offer treatment. So these are areas where the law has not defined, so the individual's own opinions count, but it's good idea to discuss with other colleagues. That is what happens in UK. If you have any problem, then you discuss with your colleagues. Sometimes you discuss with the legal advisors of the trust, but you don't do things on your own. But even prescribing outside the BNF guidelines also, one can do that, provided that he has got good evidence. So suppose if something goes wrong, we should be able to explain our position. So most of the time, clinicians don't do that, and we simply refer to a higher institute to get a second opinion. So in India, of course, things are changing very rapidly. The litigation is increasing. So I think the future generation, the younger psychiatrists have to be careful about what they are prescribing. Maybe we should ask every patient whether, suppose we are prescribing sodium valproate to a young woman of 25 years, and we don't routinely ask for whether she is planning pregnancy or she is pregnant at that time. So if there is a fetal abnormality for whatever reason, there is a high risk of being sued. So these things we have to, I think, train the young psychiatrists these possibilities also. And there are certain things in UK, I think one is about the communication, how they communicate to the patient is very important. They communicate. These people, it is your responsibility. See, in India, what we see is we are doing a favor to patient, but they don't see us doing a favor. We are doing our duty, and we have to be very, very polite to the patient, and we have to answer their questions. Decisions are mostly taken by themselves, unlike in India where patients ask you to take decision for them, and then they want their decision to be taken by you. That is what I notice most of the time. But there they are very clear. They take the decision and they say the doctor will want this course of action. So it is part of our occupations, the controversies and this kind of thing, particularly in psychiatry.
See, another issue is that, see, sometimes during the course of your practice, you are asked to take some stand or some sort of a role, is something like a dual role, a social role, apart from your practice. How far is it ethically to give opinion about various social issues as part of your psychiatric practice? I think it's another challenge. I think a lot of people talk about different social issues, either to the media or during the course of either individually. How ethical is it that we involve ourselves
into various social issues? I think, sir, I think see, every person, not only psychiatrist, every person has a role to involve in social issues. So as we as psychiatrists, as Dr. Raghuram Reddy sir used to say, that if we don't do this, who will do that? Because we are closer to social sciences like psychology or sociology or anthropology. Those subjects are much closer to us. Um, Again, here we can learn something from the UK kind of communication system. Of course, there are some like Dr. Krishnamurthy sir. Even before going to UK, I am sure he was very thorough with what to talk and what not to talk. Most of our people, I realize that we don't talk. So I will give a small example. So if I ask someone in UK, are you if you ask someone here, are you coming tomorrow for dinner? I will say yes or no. They will say, they don't say yes or no, but they will say, yes, I would like to come. Let me see if I am free tomorrow, or I'm most likely to come. They always put a kind of leverage. If things go wrong, they will play on that. When we write a letter or a report or something, we give it in a black and white. They never write in a black and white. The forensic psychiatry is one subject. I made court reports, but I could never make a court report like a UK born and UK educated psychiatrist. And after reading that, you don't understand what he's telling.
I think your mic has been muted somehow.
Hello. Hello.
Yeah.
Yeah. Hello. Sorry. There was a, I don't know. Yeah. Hello.
Yeah, we can hear you now.
You can hear you, but you are not able to see me, I think.
Yeah. You're not able to see
Now
me.
you can see me. So, sir, this is something which you can definitely learn from them, how to communicate. Hello, can you hear me now?
We are able to hear you, but we are not able to see you.
See you, sir. Okay.
You can.
Yeah. Nice.
Yeah. Now you can see me, sir.
Yeah.
Sorry for that. So it is always important to develop those kind of skills. How not to, like what we call politically correct language, to speak politically correct language, and not to speak in black and white, but to speak in grace, like as in the CBT. So that may be the point here.
But do you think that ethics in psychiatry is much more important than other medical specialties? So in general, medical ethics is an important thing. But do you think psychiatry is much more to do with ethics than other medical specialties?
Yeah, no, because it is a subject which is nearer to us, so we tend to discuss more. Suppose, sir, many medical people. I tell you, sir, one example in UK itself. Once we had a patient who had chronic schizophrenia, and they wanted to operate him for a bladder tumor, and this was in UK, and everything is prepared. And at the last moment, one of the nurses or someone raised the question: this person doesn't have the capacity or that kind of thing. And then there was a big there was a meeting with nephrologists and everyone. And one of the medical team members said, if this patient happens to our patient, we simply take the opinion of some people and we do it. Why are they doing such a big thing? So we tend to be a bit guardians of these things, or we tend to discuss more because maybe we are more verbal than them, whatever reason. So even if a AGB of Indian Psychiatric Society is probably takes much longer than the AGB of the surgeons or some other conferences. Maybe language is our forte.
But do you think that how often in the practice your ethical principles come in the way of the patient's demands, patients or the family's demands? How often does it happen in clinical practice? The patient's demand and the relatives demand something, but your ethics says no.
Yes, sir. If my ethics says no, I will not agree to that, sir. But most of the time, sometimes actually it is not right to prescribe, say, without the patient's knowledge. The parent asks, okay, you prescribe. But in the Indian context, probably I prescribe, but I can't do the same thing in UK. But even in Indian context, I don't advise youngsters to do the prescription. because it could be a big risk in future. So, as far as we put the patient interest on top, that is fine for our own feeling. But from a legal point of view, also we have to be careful, but not too careful. Also, sometimes I see youngsters are being very cautious. Things which are like giving a small letter, also they are worried. Can I give the letter or not for treatment? Even if they are given treatment, they are afraid of giving letters. I don't understand why that reluctance kind of thing.
So I think probably a lot of common sense has to be added into our ethical principles when
Yes,
delivering
sir.
patient
Yeah.
care.
Yeah.
I think ultimately that is the bottom line. I think, yeah. Now I would probably go to Dr. Sridhar Raju, a very senior practitioner in the state of Telangana, a well-known personality in Warangal, and an actor, and also a very socially sensitive and social responsible person. I thought I would ask him to see how in the community where he practices, how the various other traditional treatments come in conflict with the evidence-based psychiatric treatments of what we are familiar with. Over to you, Sridhar Raju. You didn't unmute.
Good afternoon, sir. I thank all the organizers for giving me this opportunity. And see, this is a very important discussion happening over here. And after ethics and morals of a psychiatrist, I think it is traditional practices, or in our area we call it as RMP practice. And for medical side, it is RMP practice, and other traditional or cultural practices like Chetabadi, Virugudu, Mandu, and Tayat, and such things are there. Actually, why people go to them is first is economics. People afford going to them rather than coming to a psychiatrist, because psychiatrists are not available in mandal headquarters or rural areas. Most of the psychiatric practices are in district headquarters. So people reaching this district headquarters, it needs a lot of expenditure for them. And travel, in some villages, there are no traveling facilities till today. So they are more tend to go to them because as a first choice. See, if they don't get better there, they are demanding more money for than they expect. Then they think of regular hospital treatment or medical treatment. Yeah. See, another important thing here is financial aspect. One thing, another thing is reach. They can reach them very easily, and at least to impress the family members, neighbors, and relatives. Most of the times, family members or caretakers of a psychiatric patient or tend to go to them. First of all, to brand somebody as a psychiatric patient will carry a lot of stigma in it. To avoid that stigma, they taking the name of some witchcraft or Devud Jesadu ani some religious explanation, they tend to go to a quack or a faith healer. And the other barriers, if we see, are homely environment is very important thing. Native environment or homely environment makes them think of the faith healers rather than a doctor. A doctor, hospital. Even our receptions in our hospital receptions. If there are nurses or a manager, they speak in more grammar dramatic language, English or finer Telugu and all. See, his language barrier and that homely environment is one which is becoming problem with the hospital environment. And as I said, it is native language. Many a times when villagers they approach the hospital, with a Urodu annattu, Urodu ante one from rural, they get discriminated. Akusava, the person who is in charge in reception, they say, Akusa, Ostad, Ravadusta. And వాళ్ళు proper attention they are unable to get in the hospital environment. See, these are the barriers. And another important thing is literacy rate. Till today, in our rural areas, it is 65% literacy rate. In cities, it is 70%. And district headquarters, it is 70%. So, lack of literacy, and another very important barrier here. And it is not that people won't believe in medical practice or medical doctors. They believe in doctors, they believe in medical science, but thing is the accessibility, finances, literacy rate, and the question of impressing the family members, neighbors, relatives. These are the common causes.
It is the ease of approach. I think
Ease of
approach, and probably that is where we have to see it as a challenge and then improve our communication patterns. Yeah. And do you feel that stigma is an important factor even in the rural areas?
There are two types of things in it, sir. What I observed is one is cultural. See, culture to avoid the because there is stigma, they tend to take the chance of going to a faith healer. And see, after 25 years of practice, what I observed in Warangal district like places is most of the patients, they carry myths about the psychiatric medication. They call them as Nidra Golilu. Even most of the patients who ever come to us, they ask for, sir, so this we psychiatrists are responsible for labeling our own medication as Nidra Golilu. So of course, at medical shops and pharmacies, people call them as Nidra Golilu, and see, it has become a it is a bad propaganda happening about psychiatry. See, Nidra Golilu. Another important myth carried by people regarding the psychiatric medication is if you use psychiatric medication, they develop impotency. They lose their vigor, they'll develop impotency. This is another very important myth people are carrying about psychiatric medication. And the third one, what I observed is people are, see, they have to use the medication for lifelong. Whoever approaches a psychiatrist has to use medication for lifelong. So this is another myth. See, maybe in the delusional disorders or schizophrenia, some psychosis, we advise them to use a maintenance treatment for lifetime. But in anxiety disorders, depressions and all, and episodic disorders, we don't advise them to use medication forever. But still the people are carrying such myths with them regarding the medication of psychiatry. And most of the medical practitioners, even MBBS doctors or alternative medicine doctors, Ayush doctors, they feel that there is no diagnosis in psychiatry. They won't accept that this is evidence-based psychiatry. So for last 2-3 years, what I am doing is, I am telling my patients that you are suffering from a dopamine-related disorder or serotonin-related disorder. So in that way, see, if we call it as schizophrenia, depression, mania, see, for example, if I say it is depression, they think that depression there is no treatment for depression, or depression is because of some reaction to some event happening, stressor.
Right.
So in that way, they are neglecting the medical treatment and they are going for their own common sense. They start using their common sense. So here, so many people, so many medical doctors also, they still say that there is no diagnosis in psychiatry. It is only symptomatic treatment available with a psychiatrist. See, these are the myths carrying in our society, among common man and common people and doctors, which is becoming hindrance in actually accessible people coming to the psychiatrist.
But do you feel that there is a lot of difference between the rural patients and the so-called urban patients in terms of understanding the disorder or compliance to the treatment? Do you find a lot of difference in that?
Sir, particularly if a patient is patient is educated and is coming from the urban background, see, nowadays this internet has become very big problem for the treating doctors. Because if we say we say some diagnosis or we emphasize on some symptom, they go back to their home and they browse the internet and they come back with a problem, so many questions. In rural people, see, there are one advantage is they respect the doctor like anything. So suggestibility or we can dominate at times. See, we can dominate them or we can order them. They make them understand the use of. So I may not be able to make them understand in terms of neurobiology or the benefits of the medicine and all, but I can say that, see, I can give back your job. I can make you a successful person. You can go back to your fields and work. You can have your family back, and you can satisfy your wife and your parents. You can take hold of your family responsibilities. In that way, I can motivate them. It is very easy to motivate a rural person than in urban educated. See, there are advantages and disadvantages, but once the rural people, if they come to a clinic, they respect the doctor, and still we have a good doctor-patient bondage and understanding in our rural areas. The whole difficulty is, it is they coming to us is a problem. Once they come, they mobilize with us most of the time. But in urban educated, particularly youth, this internet has become very big problem, and they demand more time. In our regular practice, what is happening is, see, we cannot spend much time with them. Very few patients, they offer us full pay for the time. Very few patients. See, most of them, they don't pay us. They demand more time, but they cannot pay. At times, they may not afford to pay our actually consultation.
Thank you, Dr. Sridhar Raju. I think your things raised a lot of several issues as I see some of the responses on the chat box. Anyway, we'll come to that during the course of discussion. Now let us move on to Dr. Kiran, who is from UK, and probably what I would ask him to throw light on is whether there is so much of research happening around the world in various psychiatric disorders in terms of therapies, the biological therapies, psychological therapies, and even various etiological implications for various psychiatric disorders. But when it comes to the practice of psychiatry in the clinic, are we able to translate some of these advances into the clinical practice? I mean, how challenging is it to translate some of those advanced hypotheses or advanced treatments into the regular clinical practice? I would like you to take on that, and probably now over to you with a brief introduction about yourself. Over to Kiran.
Thank you, Dr. Chandrasekhar. I'm hugely honored and privileged to be here. I've seen you, Dr. Chandrasekhar, in lots of academic meetings as a postgraduate. And I think it's a surreal feeling that you're moderating this session, and I'm one of the speakers. So I graduated from Calcutta actually, and then I came to Hyderabad Institute of Mental Health to complete my MD in psychiatry between 2002 and 2005. This is, I cannot express in words how grateful I am to be here today and be given this opportunity to say a little bit about myself. I'm not an academic. I'm a frontline sort of clinician with interest in involving patients in their own care and sort of positive risk-taking approach to recovery. I also have medical education interest, and I am psychiatric module lead for our Sheffield University. The topic I've been given is how research, what are the barriers for sort of cutting edge research to translate into day-to-day clinical practice. And I think when we answer that question, we probably need to think about what happens behind the scenes, really. The one thing that I strongly feel is that no treatment comes without costs. So every treatment has to be paid for. So when it comes to new research, it takes years of hard work, lots of perseverance, lots of resources, lots of money pumped into doing new research. No wonder research takes place is conceived at least in very higher centers. And the funding of it in itself is quite a big minefield. I'm not going to get into that, but you can see how if a pharmaceutical company is funding research, they will choose what type of research to fund and what to do with the product that or the treatment that they develop. So I'll come on to that in a bit more detail. I think the point I'm trying to make is that all treatments have to be paid for, and there are choices to be made. Choices in terms of somebody making a decision that they would like the treatment for themselves or a family member, and then something about who pays for it. And also in terms of making choices, I think every country has a way of making sure people who are not able to make choices for themselves do still get access to treatments. Then I suppose it depends on what sort of a country we live in and what sort of society we are. What are our fundamental values? How do we distribute our resources? So I think there are barriers at individual level as well as at systemic levels on many layers, really. If I think about how sort of societies, for example, decide who gets what treatment, I suppose it depends on whether you are a wealthy country or a poor country. And then the other side of the equation is what sort of value systems you have about access to healthcare. Are you a society that really values on people being able to pay for their own treatments? So whoever has the money can get the treatment that they need. Or are you a country where you espouse the values of universal healthcare, for example, where you are trying to work in the interest of the greater good, and you're trying to balance availability of new treatments versus cost effectiveness of a treatment that works and that can be made available to huge populations of people, whether they're able to pay or not. So So, and then there is also this thing about what importance do you give to mental health as opposed to physical health as a society. Even in Western countries, there is huge disparity between how much money is spent on mental health, physical health care, how much more money is spent on physical health care as opposed to mental health care. But there is a lot of challenge to that. So the systems are trying to, in a sense, sort of catch up and try and bridge this gap between funding for mental health care and physical health care. So if I think about UK as an example, UK is a wealthy country, and it also has a system that means that people don't have to pay for their healthcare at the point of need. So if you need I don't know, a heart bypass, you get it done free of charge for you when you need it. If you need CBT for psychosis, you get it free of charge. It doesn't matter whether you can pay or not. But in the UK, there is also a parallel private sector where treatments are available. If you are able to pay, you jump the queue, and you can get it by paying money. So being wealthy does come with its own privileges. So you can really buy the treatment that you want. Obviously, there has to be someone who is able to and willing to offer you that treatment, which can be a barrier sometimes, despite having the money.
So ultimately, you feel that economics plays a significant role in translating the advances into the routine practice. It plays a significant role.
I think money underpins every choice that is made by individuals or made for them by others.
And what about this issue of more empowerment with the knowledge now? See,
yeah.
It could be internet, it could be social media, it could be any other source of information. Now, a lot of patients are empowered with basic information about a lot of things. Do you think it is posing a lot of challenge in practice? Like, suppose with your clinical experience, you suggest a particular type of treatment. The patient says, no, I have read somewhere, this is a better treatment than what you are suggesting. So how do you really tackle that sort of a challenge?
Yeah, it's really interesting and challenging issue, really. I think for me, as you say, knowledge gives people the information, and as they say, knowledge is power. So I suppose it puts a lot of power in the hands of the patient or the family member when they have some information they think is really helpful to them, and I suppose it gives them some sort of a leverage, or I won't say leverage. I think it rebalances power. Dr. Sridhar Raju was so eloquently putting the power imbalance within doctor-patient relationship, and how sometimes knowingly or unknowingly we exercise our power and authority and make people sort of almost sort of less deserving of what we are in a privileged position to be able to provide them. So I think having that knowledge does go to an extent in sort of rebalancing power dynamic. I think to that extent it is quite a helpful challenge, really, back to doctors who might believe that they know all and they know what is right for the person sitting in front of them. Within, I don't know, sometimes maybe within a 2-minute consultation, or even sometimes without seeing the patient, because we are put into all of those scenarios, I think, when we practice in really challenging circumstances. So I think having that information does give the patient some a voice. And I think that is healthy in many respects. I think it helps the doctor stay a little bit alert, really. Yeah, but it has its sort of massive downsides as well. So
I think all over the world, probably this paternalistic attitude of the medical profession is slowly changing, and patients' choice are being given more prominence. I think we'll come back to these things probably during the course of discussion, and we'll again probably discuss few of these issues during the course of discussion. Now let me bring in Dr. Kishan. Dr. Kishan, of course, is known to everyone. He doesn't need any introduction anymore. He is currently the president of South Zone Psychiatric Society in India, and also very widely traveled. He attended various international conferences, has vast repertoire of knowledge. And let me bring in Dr. Kishan, and I would like him to touch upon this particular aspect, which always bothers me. See, psychiatry, as all of us know, is a multidisciplinary team approach for a lot of psychiatric disorders. But in reality, in clinical practice, very often it is the single psychiatrist who has to handle. How do you really balance this? How do you really balance this multidisciplinary approach strategy of a treatment processes with a single psychiatrist attending to this? I think as an experienced clinician over the last 2 decades or more, I think I request you to throw light on this. Over to Dr. Kishan.
So, thank you, Dr. Chandrasekhar, sir, and all the colleague panelists. And thanks to organizing committee for considering me to be in a elite panel. Over to the question, answer to the Dr. Chandrasekhar's question. Here, this problem, that multidisciplinary approach problem, can be seen in different type of domains. For example, now more than 2 decades I'm practicing, now in 3rd decade. But now generally I will put my comment in this way. I'm all young practitioner, message from me to all young practitioner. You must be thorough with your artisans, your general medical knowledge, and anything when you are examining a diagnosis of psychiatry, you should thoroughly examine, especially inpatients or the comorbid patient. You thoroughly must able to examine CVS, CNS, respiratory system, and other medical system. You must have that basic knowledge, and you should try to improve. That is my thing. If you are having that basic knowledge, then your interaction with the patient, interaction with the attendants, interaction with the colleague doctors with other specialty will be the better, and you can avail the services of the multidisciplinary approach. You can deliver the goods to the patient without having a multi-specialty hospital. So here you can see Sridhar Raju expanded his hospital to multi-specialty hospital. A lot of problems will come in management and maintenance, so many things. But of course, he was successful in that because of his area of personality. Personality is different. But at present, still I am running my clinic as a psychiatrist. But now, when you write, first you work up. When you work up the case, try to have a record system. That is my advice to all my colleagues psychiatrists. Try to maintain a record to every patient, number one. In that, should have a diagnosis, psychiatric diagnosis, as well as the comorbidities. As far as diabetes and treatment, thyroid and treatment, or something untreated, that should be maintained. And whatever the treatments also should be maintained, number one. Number two, what consultants they are already approached. So try to reveal the diagnosis to the concerning consultants. For example, in my clinic, if I refer to a doctor, a physician, or a cardiologist, or anything, I will have my own choices. Number one, number two option. Always you should have 2 options because the doctor may be there, may not be there immediately. So try to have 2 physicians, try to have 2 dermatologists. If you treat a tegretol, in the HS syndrome, you should have a dermatologist in hand immediately. Sometimes the holidays, 3-4 holidays, the doctor may not see the patient. Sometimes you should take a photograph, send a thing, and you have to diagnose it. Something that you should have good rapport with standby doctors like 2 dermatologists. They may not be in your clinic. They might be under your setup. You should have a good two neurologists, two physicians, two orthopedicians to handle the trauma cases, alcohol cases with trauma, with alcohol cases with injuries, and even the schizophrenia, many cases with a lot of injuries. The other people will beat him. So a lot of these cases will have multi-specialty problems. First you diagnose, then already comorbidities, what consultants we are having in that particular city. So you should have what are the area of practice, in which area, and you should have, when you're referring to, my practice at Karimnagar, I know who is leading physician in that Mancherial, or two physicians in that, Goarkani, two physicians. Like that, you should have a network of doctors. So you can still deliver the multi-specialty, same quality of work if you have a good battery, good rapport with your panel of doctors. And even our setup, even in a psychiatric setup, I am having now two MBBS doctors come, and there's no need to a complete 24 hours MBBS doctor, complete physician around the clock. I'm paying the physician, he will come, he will do rounds morning and evening and go. So that is the way how you can deliver the multi-specialty services in your own setup.
Yeah,
So
Dr. Kishan, Dr. Kishan, I understand very well how good, I mean, it's a very eloquent way of looking at the various physical comorbidities with reference to psychiatric disorders and how to tackle them. That is because that can happen easily because we are all medical graduates. We know some fundamentals of medicine. As you said, detailed physical examination will help us in delineating those things, and it's good. But what I am trying to understand is that how do you compensate for the lack of services of, say, psychologist, a psychiatric social worker, or a speech therapist, or an occupational therapist in a practice? Because the patient who comes to us may require service of any of these people. So in the practice of psychiatry, how are we compensating that? Or sometimes are you compromising with the care of the patient? A lot of patients do require these other ancillary services. So how are we able to meet this challenge in day-to-day clinical practice?
In the initial stages of my practice, I used to refer some cases to the psychologist where I will oblige to pull up the patients, or refer psychometric analysis, or personality assessment. Some cases for IQ assessment, you should have one or two clinical psychologists standby in nearby city. Try to take that services, number one. Number two, now I'm in my clinic, I'm having a full-time clinical psychologist who's is a junior clinical psychologist, who's doing assessment of that scales, depression white box for OCD, PANS in schizophrenia, something like that, even BPRs in non-psychosis, like that. So even now, my setup is supporting a 24 clinical psychologist, as well as nurses are getting trained by him. Nurses are getting trained by him because by helping. And one more senior clinical psychologist coming every month, pulling of all cases for good personality assessment, IQ, and other comprehensive diagnosis. And this junior psychologist will sit with him. They plan the management, even non-pharmacological management also they plan. And there you should have a social worker. My wife itself is a social worker. She was trained after my qualification, getting MD. She trained in sociology with social work. So we can do some counseling when you participate. Even I'm having a nurse who was trained for how to apply the skills. Even nurse was trained how to assess how to do occupational therapy. You cannot have a occupational therapy unit in your clinic. But if you go to most of the rural population will have a occupation-based communities. So how to tap, or whether this person is from high socioeconomic or low socioeconomic, you can do social equation, social background for them, Gowda, the tidy tapper. So how to train him, alcoholic, when you are giving benzodiazepine, what occupational rehabilitation we have to do. You can plan with the help of the clinical psychologist, you can plan with the help of the nurse, because you will not have time. So you have to train the senior staff, maybe a MS psychology, maybe a nurse, to train in these modes. Even for autism, even for speech therapy, even for even sometimes even mentally handicapped with some assessments. Now, district headquarters like Warangal and Karimnagar, we are getting the therapist, speech therapist. We are getting the audiometric analysis of all these things at district hospital, especially Warangal and Karimnagar. Now, let us utilize them, invite them to our clinic to have a better liaison, what we want actually from that specialty, and what autism is. So you have to liaison with them. Even what I do is I train the mothers. What is autism? What will happen? How to do sensory stimulation? What are the basic concepts of child psychiatry? How to know what are the basic behavioral interventions? So you make mother. Some of the mothers, I refer to the name NIMH, there's a separate quota for them to get a diploma degree in NIMH. So after training, you can go to NIMH, you apply for that. Some mothers applied and they started rehabilitation center in some units peripheries. So like that, you make mothers, empower them, do counseling. For 1 or 2 sessions may be big, little big, but after that, you can how to stimulate visual input, how to stimulate the auditory input, how to stimulate the tongue, gustatory, how to stimulate the olfactory stimulation. I will tell the mothers will certainly they will put it in a book. You are the therapist to your kid. You do this. You can stimulate. So they will get results. And a psychiatrist, little more time, if you spend with the mother, you can do. Because limited resources, you have to tackle like this. This is a method how
I think building up the human resources within our own environment is the answer to this challenge, I hope. See, I believe in some places they also train what they call as mental health assistants, taking basic graduates and trying to train them in various aspects of mental health care. Another thing which I'm curious to know from you, you being an organization man and widely traveled and various association activities, we all indulge in various awareness activities of mental health care or mental health. About mental health in the community, we conduct a lot of awareness sessions and all these things. But when it comes to the providing the services, what challenges are met because of this increased awareness in the community? Do the real people demand more services? And if they are demanding services, what is the challenge which the clinician faces in those instances? I'll give an example. Suppose I come to say a remote place in Telangana, and I talk extensively about how to identify a mental disorder, how they can be treated and what benefits they get, and I disappear. And where do these people approach for the knowledge which they gain through me? I mean, how is it being translated, and what is the challenge for that in the regular psychiatric practice?
Thank you, sir. Coming to the opening comment is, you have to improve the awareness in one side. At the same time, you have to improve the services in another side. These both should be balanced. So in initial phase of my practice, somebody used to call us to talk somewhere. You go on calling, you go on giving awareness programs, and even conducting the even South Zone level activity of academic activity. Now we are conducting in Adilabad. Now the Telangana State Bank has given permission to do a CME in Adilabad. So it's only inviting persons, academicians. So going to the press, and every academic program we will issue a press releases. Automatically it go to the public. What are the advances are going on? So Dr. Gangadhar came and has given a press release. There are so many people when we do conferences. The presidents will come. They all messages going to the press. We are educating the press. We are educating the village leaders. We are educating the village social workers, even health personnel in the PSC. So all these are going on at the same time. In last decades, what I want to say is, I can see that Raj is actively listening. So in the district of Warangal, in the district Karimnagar, you can see a model districts after Hyderabad, a second tier city. We are having 2 medical colleges now. When I gone to Karimnagar, no medical college, but slowly, because of a lot of doctors came to Karimnagar, one medical college came up with, because resources are there. Now they can start different departments. Like that, they started a psychiatry department. We are having now 6 postgraduates are coming from every year from Karimnagar. So here the duty doctors are available around the clock in 2 institutes with ADMO specialty and psychiatric DMO specialty, and we are having we are also liaisoned with police stations how to deal with wandering lunatics. Now, there suddenly flush of patients will come to the system where services overload to the existing services. At the time, I am the only person under Bhagirathi. Now we are having more than 12 persons, individual practices. There are 3-4 nursing homes in our district, private nursing homes, as well as 2 medical college institutes, and the civil hospital also well equipped with ECD facility, everything. So 3 institutions provide, we are encouraged the 3 institutes, as well as the institutional, very academic, and both medical colleges are associated with the civil hospital, where our PGs are also going and serving there. So these type of setups are also evolving. And I am visiting personally to the district jail. There the police personnel trained how to deal with even police station, police personnel, even police commissioner, everybody sensitized how to deal the medical legal problems. And I'm liaising there, the now district medical board not yet to come, but district legal services authority, I was on the panel of 2 terms, 2, 3, more than 2 terms. A lot of cases were settled. My records, again, I'm telling you, record section will help us to do all these activities, to present to the authorities what is the data you are having. Now I am no 71,000 patient data. You can present, you can how the legal, how can you prevent the legal problems? How, if district legal authority, no, that is also a service provider. We are creating a service provider by attending free, offering free clinic. Myself and Bhagirathi will go and attend the judge. What are the liaison? We give a pass, free pass, sir, for counseling for this much period. So judge will, with the liaison to the psychiatrist, a judge with all both parties together, they will come for counseling and it will be handled. So we are improving the private services, patient services, rehab services. I'm running a wellness clinic now. Now, initially I used to do neurotic, only Jacobson's relaxation training. There is a Thursday clinic, neurotic. Now I'm doing wellness clinic to neurotic disorders, wellness clinic to psychotic disorders, wellness clinic to bipolar disorders. These are all developing slowly, and we are improving the data. So like this, you are improving the services, you are improving the awareness, and you improving the departments, academic departments, you are improving the also civil hospital. I have told you one thing, that Lakshman came to me 15 years back, whether can I go for DPM or not. I encourage him personally. He stayed with me for 3 days. He was sensitized to do. First advantage you will get, you will escape from the PSC Baba. At least you will go to civil hospital. He was retired now as a superintendent of civil hospital. So that was the duty of a doctor, to sensitize the people, sensitize the medical doctors. He was sensitized. Now he was retired of the superintendent. Now he is the president elect of Karimnagar Psychiatric Society, the Lakshman. Even though he is junior to me, he was elder person, was well sensitized. Well, now he is attending so many clinics or NGOs like that. I think we are improving the services. We are improving the rehabilitation services. We are improving the even awareness also. If you balance, I think there's no gap between two. Thank you.
Thank you, Dr. Kishan. I thank all the panelists for having.
Sir, can I add one?
We are coming to the discussion.
Yeah,
we are coming to discussion. Huh? So let me check. Yeah. I think it was an excellent deliberation by all the panelists. And okay, the question to Keshav Rao from Dr. Shiva. If a homosexual requests for treatment in writing, can you take up?
I will take up, sir. I will take up, because it is not illegal in India, and I'm not worried about the comments by my fellow IPS members. Some people are not. I'm not worried about them. So I will do that. There is no doubt. Even in UK, I can do that. There is no law against not treating. So if the person needs help, if I can help, I will help, or I will refer to someone who can help.
Any other opinions?
Recently I got a case.
Raghuram Reddy, sir.
Homosexual. Just 10 days duration of marriage. He married a male, and his face is completely, he went to the beauty parlor and with the whole family members are 3, 4 young boys and cousins are brought him to me. I've taken a consent from him. I used to take consent when the patient became pregnant and using special consent for using psychotropic drugs in pregnancy. The same consent, my assistant is laughing. So we are creating a new consent form, sir. They are taking using psychotrophy. I have taken for that homosexual for treatment because that so-called husband may come and attack me after 10 days. Why you are changing my wife, so-called wife, male wife? That will come and attack me. That's why I have taken a consent. I have taken a consent for use psychotropic medicine for I have taken all witnesses, father, mother, and cousins are witnesses. And in that way, one more point I want to tell is even I think Kiran told and other colleagues told that the law, other things in India, law and other things is different. We have to balance three. One is the truth, that is satya, and whatever in the court and all this law will be the nyayam. Nyayam is not different, dharma is different. Dharma is different, nyaya is different, satya is something different. So you have to balance these three. In India, this place, the parents will come. It is our dharma to protect my daughter. And the other party will come. Now here you can see the homosexual case. So my dharma to protect my son. As a son they want, And your dharma to protect he is paying 200 rupees for you. Your dharma to help you, the client. But at the same time, your dharma to protect yourself. No, that is why you have to take consent. So, okay, remaining things will come. The court will come. Ultimately, you have to follow the court also, whatever the rules will come. That today's psychiatrist, especially in India, will have three components. Dharma is there. Dharma is whatever your duty. They are paying to you. You must be partial to your client. You must be partial to your client parents. So, little partial means not against court, against law. So, you have to balance the law. You have to balance your dharma and duty to the patient. You have to know the realities of the patient and record. So you have to balance all three. You can escape the law if you calibrate these three. I think for that you have a multifaceted personality. Thank you.
But one second. But what I understand this situation. At the same time, don't you think as psychiatrists, all of us talk about biological basis of various disorders, and we know now with adequate research that is internal wiring, which has gone wrong in homosexuals, and they're biologically made to be like that. So how successful are you going to be by treating them?
Sir, can I draw a parallel, sir?
Yeah.
It is very similar to anger management. A person with anger management has got a propensity to lose his temper very easily. But what does that CBT or anything that? So things which are biological do not respond to psychological treatment is the kind of argument I am seeing more and more in national WhatsApp groups. Particularly young psychiatrists, they are commenting very heavily and adversely on any psychological treatment offered by psychiatrists. So that is the kind of thing. Even if it is a very biological hardwired thing, if the person can be helped, he will be helped. And the wiring may not be absolute, sir. Some people that wiring may be very strong. Some people the wiring may be here and there. So what percentage of wiring? It is not an absolute. It is a gradation again, like in a CBT. It is like in a continuum kind of thing. So we should offer.
What diagnosis would you put, sir? Before treating the person, what diagnosis would you prefer to put?
For this person?
Yeah.
The
homosexuality is not a psychological disorder, no? See,
it is not a psychological disorder. Anger is not a psychological disorder.
If he is having, see, we have to demarcate between normal and abnormal.
So if
anger is becoming hindrance in his interpersonal relations or his development, then it is abnormal. Then only we treat. Otherwise, we don't treat that anger like that. See, homosexuality is a biological phenomenon, okay, but it is individual preference also. See, if the person who is opting for that may be suffering from depression, which he needs our help. See, maybe he is delusional or something.
No. That particular patient I have seen, he has got clear homosexual preferences, but he also wants to get married and have a child and have a sex with his wife. So it is not that the hope that homosexual person will not have that kind of wishes. So if it is causing dysphoria to him, we will treat. Otherwise, we are not treating forcibly. If the basic duty of any physician is to allay suffering, so here we are allaying the sufferings of that person. So it is not illegal. So
Can I come in, sir?
Please, sir. Please. Sure.
Yeah, very, very interesting conversation. I think, I mean, obviously practicing in India is far more challenging for lots of reasons that we've already heard. Relatively speaking, it is much more structured and organized here. But I think some fundamentals are true no matter where you practice medicine. Around, I think, first no harm, primum non nocere is the dictum that we follow, and the oath we take when we become doctors. So I think as a psychiatrist, I'd be looking to see if I am really dealing with a psychiatric disorder, and both, well, across the world now, even ICD also does not recognize homosexuality as a psychiatric disorder. And I think there is so much research that is coming out now. I think maybe many of us as psychiatrists need to come to sort of we need to do a lot of catch up about this whole gender and sexuality issue, really. So I think on this topic, I would say if there is a diagnosable psychiatric condition, then I think I'd be legally in a position to be able to, even morally in a position to be able to do something about it. I think if it's a case of somebody coming to us with distress due to any cause, if that distress is caused by a psychiatric disorder, then we would treat the disorder itself. The distress can be a manifestation of something underlying. If there is no underlying psychiatric disorder, I think the distress needs to be somehow sort of supported and managed rather than treated in a medical model. That would be my view.
Thank you.
Sir, can I make a comment, sir?
Hello.
Sir, can I make a comment here?
Yeah, please.
Sir, as a psychiatrist, I am not only helping psychological disorders, but also psychological problems. It's not that we have to help only the coded disorders. Even the psychological problems have to be managed. If somebody asking the help from us, we have to provide the help. This is my comment.
Okay. I think we had a very interesting discussion on this. Let us move on to the next one. There is a question here from Dr. Sanjay Kumar. How to handle the current trend of reductionism in psychiatry practice and even in psychiatry training? Is it only a national or international trend as well? Any panelists can take it.
Sir, I will take this, sir. I have also given small answer there.
Yeah.
Sir, the reductionistic approach why is it happening? Is it because of the trainee's attitude or the trainer's attitude or the curriculum? These are the things we need to look at, sir. But from a practical point of view, today we have got about 40 MD seats, 40 MDs coming out in Telangana every year, 30 to 40, maybe 40, I think, sir. And if you look at the number of clinical psychologists, there are only 4 clinical psychologists. And today we at Chetana Hospital, we are looking for a clinical psychologist who can deliver in Telugu. There are hardly any available. So I feel actually that today we have listened to Dr. Narasimha Reddy, the opening lecture, CBT for psychosis. Now there is a huge scope for CBT, for anxiety disorders, kind of self-esteem development, etc. Many of these things. And we don't have any trained psychiatrists. Now, all these psychiatrists are not going to survive on treating seriously ill patients. Our curriculum, particularly the postgraduate curriculum, should expand to psychotherapists as well.
2:30 అయ్యేటట్టుందమ్మా, postpone అవుతుంది.
And even we should look at doing some psychometric assessments also. For example, IQ assessments, there is no one to do any IQ assessment in districts, hardly anyone. So that is the area where the psychometries also should be taken up by postgraduates, ADHD assessments, autism assessments. Why not? So I think I answered the question partly.
We feel the psychiatric scope of psychiatric training has to be broadened and
yes, sir, broadened, and they should put it into practice.
Sure.
I envisage, sir, 5 years down the line, there will be 200 psychiatrists. That you should be able to comment. Where will we get so many patients?
Yeah. Another question is, share some experience on ECT in district and rural practice. People believe that ECT will cure the difficulties. How do you overcome that belief and their thinking? Sridhar Raju?
Generally, the role of psychiatry has come down, sir. Even in psychiatric hospital in districts, people coming for ECT are also coming down actually.
Okay.
And in the recent past, I didn't find any person coming for ECT. See, to convince them for ECT is becoming a big problem. Another thing is, see, in OPD, we are not giving ECTs. I don't entertain ECT in OP because the poor compliance of the patient, or they develop so many side effects or memory disturbances, like, and if we allow them to go to home, what happens? They start counting the money and all. So there are so many issues coming up. So we take the we admit the patients, and then we educate. I take 4 to 5 days to educate the family members and the patient, prepare the patient. So after that only I go for ECT. See, 1 in 100 or 2 in 100, they generally they don't go for ECT. But 98%, 97% of the patient, they accept for the ECT. In that way, I'm not getting any patient asking for the ECT. And for sure, if we are treating a psychotic, I tell them the maintenance is a must, and there is no cure for it. Only control is there. If we educate them, I think it is not a big problem, because earlier we don't have olanzapine or risperidone. Before that, only haloperidol, trifluoperigen, CPZ, such molecules were there. Those days, ECT had definitely very important. And particularly in suicides, it is a life-saving this thing. And acute psychosis, at times when the patient is very aggressive and very difficult to handle him, people are asking for it.
So in general, your comment is that the trend of giving ECT itself is decreasing all across.
In my practice, I am happy that people are having positive approach towards the ECT. They are having positive opinion regarding that.
Yeah, good. I think with this, unless there are some more questions, most of them are comments and statements, so I'm not going to them. I think we reach the last leg of this discussion. Any panelists would like to share any further things about what we have about these challenges in clinical practice, and we'll probably close the next 5 minutes. Yeah, sure. Kiran.
Sir, so just reflecting on some of the things that have been said earlier, just picking up on one thing. There was a theme about when there is a sort of a bit of a divergence between what patient wants or demands and what you think is right, and how do you deal with that sort of a challenge. So from time to time, I have patients, they come with some sort of a screening questionnaire they've completed about bipolar disorder, and they say, well, I have bipolar disorder. Or they may say, I've researched this particular vitamin treatment for my son who has treatment-resistant schizophrenia, and I want you to prescribe it. Or sometimes a patient will come and say, I've got bipolar, and you must give me this medication. So these these conversations are very challenging. But I think sometimes as doctors, we have to obviously educate the person in all cases. If you have a good reason to disagree with what they are coming to you with, because I think the problem of internet-based knowledge is that it's not combined with the training and experience that the doctor brings in terms of analyzing that information, making it individualized to that person. So unless that conversation happens, you really you're not getting the benefit of what you've read on internet. So I think we have a duty to try and be the individual who does that for them and with them, and give them the reasoning for why you are disagreeing with them. At times, patients have demanded certain medicines, for example, benzos, when I have completely disagreed with it. And I have had to say that is not an option I'm able to give you. So while there is patient choice, there is also the clinician has the I think the right to decide which options are on the table to choose from. So to that extent, I think the doctor-patient relationship and the responsibilities on each side does come to our rescue really in those sorts of crucial conversations.
Thank you, Dr. Kiran. I think we had a wonderful discussion. Thank you, Dr. Keshav Rao, Dr. Kiran, Dr. Sridhar Raju, and Dr. Kishan.
Sir,
Yes?
I'm Dr. Ashok Reddy, sir. I would like to
tell
add
me.
points, sir.
Sure,
Here.
sure.
Sir, this is about the important challenge what you brought out. There is a non-medical services provided by non-unqualified professionals providing mental health services.
Yeah.
The point raised is the ease of access is the main reason for having services from these non-qualified people. So the solution for this should be, like as of now, almost every district has a psychiatrist now. So if all the psychiatrists who are members of IMH alumni or a brethren, if they extend weekly one services, 3 hours of services to another remote area, maybe 50 kilometers from them, ease of access will become more, and probably this challenge can be faced more easily, and we can serve the population in terms of mental health more positively. Thank you, sir.
I totally agree with you, Dr. Ashok Reddy. Yeah. Thank you very much, all the panelists. I once again thank the organizers of this meet, the IMH Alumni Meet, for giving me this opportunity. Thank you, one and all. Over to the organizers.
Thank you, sir. We move on to the next session, the fourth session. It's the pharmacological management of dementia by Dr. Ajay Verma, sir. The chairperson are Dr. Gauri Devi Madam and Dr. Madhusudan Joshi, sir. Dr. Gauri Devi Madam has done her MD Psychiatry from NIMHANS, Bangalore. She was a teaching faculty at IMH and Nilofer Hospital for 28 years. She was a medical superintendent of IMH, and she's presently the academic director and DNB coordinator for psychiatric training at Hausha Hospital. And again, Madhusudan Joshi, sir, he was the first person to join first batch of DPM in IMH. He started Retreat Hospital, Mind Clinic, and Dr. Joshi's Mind and Body Fitness Center. He was the past president of Imh Hyderabad. He was the past president of Hyderabad Psychiatric Society. With this introduction, I want to hand over the mic to chairperson, ma'am. So please take over, ma'am.
Thank you. Yeah. Good afternoon. I think you are all charged with morning 3 sessions, it looks like. So, and good afternoon to all wonderful alumni of IMH and also the faculty of IMH, the students, the past superintendents of IMH, and people like me who are not alumni of IMH but associated with IMH. So it's very nice to be in this platform along with my student who is going to speak on the pharmacological management of dementias, and also chair the session along with the first alumnus, Dr. Joshi, and who was also my colleague in Nilofer Hospital. And I thank the organizers, Dr. Pramod Kumar and Shiva Kumar, Uma Shankar and Girish and others for giving me this wonderful opportunity. And I was associated with IMH, maybe in between I went to Nilofer, but all my life I was the faculty in Usmania Medical College. And we had the privilege, Dr. Chandrasekhar and myself and Dr. Wagre, privilege of starting the MD psychiatric course at IMH. We were the first teachers, assistant professors. And it's wonderful to work with Dr. Raghuram Reddy Garu and as assistant professor, later with Dr. Krishnamurthy as a professor and deputy superintendent. Later, I was HOD, Usmania Medical College as well as superintendent. See, one thing I learned is that you can learn quite a few things from your seniors, especially the administrative abilities and maybe problem solving skills. The second thing, I always feel that I'm still working. I'm the HOD, Department of Psychiatry and Child Psychiatry at Asha Hospital. It's a wonderful experience being a teacher. The reason is that when you come out of the institute, you are wonderful, you have so much of knowledge, but you need to translate your knowledge into, you need to put the knowledge into your students, who are very raw. So that's one thing which is interesting. And you learn a lot of things from your students. When you train them, they have so much of potential. Maybe you need to guide, but they come out with so much of knowledge. And I feel that I learn quite a lot from the students. Like at this stage, you will not be in a position to read all the books or the latest things. I think you give a seminar and I think you get everything out of it. I'm sure I'm going to get a lot of things from Ajay, and who has become one of the authorities on, dementias. And what I would say is, I just want to say a brief introduction about the psychiatric disorders as such. Most of our psychiatric disorders, whether schizophrenia, bipolar disorders, or, child psychiatric disorders like autism and ADHD, and, the so-called simple, easily diagnosable conditions like OCD, they take a long course, a chronic course and varying course. And the worst thing is the disability which these people have. And when you look at those things, and especially dementias, because most of the neurologists, they'll diagnose and then leave at the psychiatrist to handle them. So that is the case. What is that? We psychiatrists are going to do it. And our aim is that we just need to see that we diagnose early. And if it's possible, like other day we heard Keshavan, I heard him many times. You need to diagnose early in the sense of preclinically, prodromal stage or early symptoms you need to identify so that, we can prevent the prolongation of the illness, one. The second thing is you treat, but you need to see that it doesn't occur, recurrence, most of our psychiatric disorders. And the third point is you need to think about preventing disability, because you need to integrate the person into the society so that the person will not be a burden to the family or the society. The cost of the treatment on the country or the family is quite evident. The fourth one is we need to think about rehabilitation and putting back into the track. So these are the four things. So coming to dementia, where Ajay is going to talk about it, we know that we can't diagnose them pre-clinically, the so-called mild cognitive impairment. We don't know how many of them turn out to be Alzheimer's or how many of them going to develop other neurological problems. So none of us know. So you can't think about diagnosing early. By the time you diagnose, already the progression is there. And you don't have disease-modifying drugs, to take care of and arrest the progress of the disorder. That's a disadvantage with the dementias. And then this person has a lot of comorbidities, and especially it occurs after 60 years, and then they have renal problems, cardiac problems. So much is there. So when you have to handle such problems, so we need to be very careful. So that's one thing. So in this case, so what is that? We psychiatrists can do it. So we know whether it's Alzheimer's or the Parkinsonism related dementias or vascular dementias. The three common things are, the cognitive, the behavioral and emotional problems. And these are the things that need to be helped. Yeah, we know that majority of the times we treat with the psychosocial, whether it's UK, USA or India, we need to. But maybe we have the, the joint families, or to some extent, we throw the burden onto the family members. So that is the case, and when the burden of the behavioral problems person is paranoid or disinhibited, the family has such a lot of pressure by the patient. So there we need to really think about the medication. So one side we need to think about the medication. At the same time, you need to think about the safety of the patient, especially above 60 years with comorbidities and disturbed metabolism, changed metabolism. So we know that a lot of medications are there, anticholinesterase inhibitors are the NMDA antagonists for cognitive, how much they will help. So we need to, they are all very expensive. So we need to think about the cost and then effectiveness and the problems to the patient and the family. The second is behavioral thing. You need to give solace to the patient. At the same time, you need to take care of the dignity of the patient. So all these aspects, when you need to take, you need to weigh between the advantages and disadvantages. I think we need to go about it. I'm sure Ajay is going to talk to us about these things with his evidence as well as the experience. Now, with this brief introduction, I'll pass it on to Dr. Joshi, who's my colleague and is going to co-chair the session to give a brief introduction about Dr. Verma, Ajay Verma. Thank you, Joshi.
Thank you, Dr. Gauri Devi. After the academician spoke, a clinician like me would be more interested in listening to Ajay and his experience about dementia, because there is a lot of difference between what we do in the academic activity and what we do in the clinical practice. And I have the pleasure of introducing Ajay Verma. And it is really nice to see, because I want him to have more time to talk. So I would like to tell him that he's an MBBS and MD from our alumni, my alma mater, and then went to England. He was worked there. He learned. He did his MD, MRC psych, and he went to Scotland. He worked there, and then now he's in Australia in Keynes Hospital, and he's doing a consultation license psychiatry for older persons, ECT director and chief training supervisor in Keynes and Interland Hospital and Health Services. He has 23 years of psychiatric experience with postgraduate degree, MD psychiatry from our IMH, MRC Psych from London, CCT in old age from Scotland, and I'm sure he's going to enlighten us more. And then I'm probably going to take him up for in the clinical practice, because as Gauri Devi said, we are actually going to see in a tertiary hospital those advanced cases. In clinical practice, I happen to sometimes get cases, as she said, about the mild cognitive deficits and all that. And what my experience was, if we start early treatment, they have been living longer in a more healthy way. Anyway, now I leave it to Ajay, and then after that we'll discuss. Thank you.
Thank you very much, Dr. Joshi, for a warm introduction and for the preamble, Professor Gauri Devi, Madam. Let me share the screen. Can everyone see?
Yeah.
Yeah. It's an absolute pleasure to be here, and I'm truly honored. And the credit should go to my respected teachers, colleagues, and friends from IMH who laid the foundation and what I am today. And special respects to my guru, Dr. Chansekar, who inspired me into dementia and old age psychiatry whilst I was doing my post-graduation in India. And also at the outset, I would like to thank the organizers for the first alumni meeting, and also Dr. Kishan, Drs. Kishan and Keshav Rao for getting me on board. Thank you very much, everyone. So following a stint of 17 years in Scotland, I moved to Keynes last year. So Keynes is a very small city, about 160,000, and it's almost in the far north Queensland, next to the Pacific Ocean. And it's surrounded by 2 World Heritage Centers. You are well aware of the Great Barrier Reef with the fish, and probably David Attenborough with his Our Planet programs coming in Blu-ray. It's very well known. But what you do not know is the Daintree forest, which is a tropical wetland forest, which is more older than Amazon and more denser than Amazon. And there's an absolute delight. Whenever you plan to come in, please stay with me. So coming to Keynes Hospital. So Keynes Hospital is a 630-bedded hospital, of which 50 beds are mental health beds. And it covers a vast area of the far north Queensland. It's the only general hospital in the far north Queensland, almost of the size of the United Kingdom. And this is a picture of the Great Barrier Reef, which extends to about 200 kilometers and covers around 2,900 reef islands. It's a great place for tourism, but unfortunately, the COVID has dented some of the businesses here.
Move the slides, I think.
Is it moving?
No,
it's not moving.
Okay. Sorry about that. All right.
The slideshow you can use. It's a slideshow, I think you need to
maybe you need to go to the slideshow.
Yeah.
You able to?
No.
All right, just a moment. I'll disconnect this. Sorry about that.
Ajay, probably if it's not working, you can click each side from the side if that's not working.
How about now? Has it moved?
No.
Right, just a moment.
Yeah,
that's right. That's right.
Yeah, that's good.
That's fine. Okay. Has it moved now?
Yeah.
Yeah. Yeah.
Okay, right. So that's the picture of the Great Barrier Reef, which extends to about 200 kilometers and covers around 2,900 reef islands. It's a place of adventure and a place of tourism and a popular place for backpackers, but unfortunately, COVID has put a lid on everything. It's a land of beauty and the beast, and I have just had my first sighting of a crocodile, which is about 4 meters in length in the Daintree River. So these are called as salties, which live in the sea as well as the freshwater through the river. And also it's all natural beauty around because it's a tropical wetland forest and lots of gorgeous fauna, flowers, and waterholes. So it's quite popular tourist destination for Australia in itself. And more importantly, lots of culture and history. So there is a lot of concentration of Aboriginal and as well as Torres Strait Islanders. And it's quite an interesting experience dealing with the psychiatric problems with these patients, which is very much rural and remote. So let's get into the business. The resources I have utilized for the rest of my talk is with regards to the NICE guideline on dementia, which was published in 2018, and the British Association of Psychopharmacology guidelines from 2017, and the Australian guidelines from 2016. So what's the need? Dementia is a ticking time bomb with around one diagnosed every 3 seconds and with substantial numbers increasing over the years. And with this worldwide spend doubling in the next 10 years. But in the next 3 decades, a huge surge of 68% is going to come up from low and middle income countries, and predominantly Asia will play a major role. So India and China will have a major impact with regards to the world dementia numbers. So these are the population pyramids of how India and China would look by 2050. So what you see is plus 55 age groups bulging in both countries, but with the Chinese having a single child norm, their younger population is going to dwindle, but our population looks healthy with the younger adults. But with the internal and external migration of the younger adults, families are becoming more nuclear and posing more problems. So what are coming to the demographics in India? So currently there are more than 4 million who have dementia, and these numbers are going to substantially increase. There is a projected 300% increase till 2040. And as population ages and with better healthcare and improved longevity, the dementia is expected to increase. So as a country, we need a specific health policy. So coming to the dementia costs within India, this is a 2013 paper from Nimans. So these are the urban and rural costs of dementia and how they compare with other chronic disorders like diabetes and epilepsy. This is all published data, and probably I feel there is a gross underestimate. And also, 7 years down the line, the costs would have doubled significantly. And the study also states that the costs increased with increased severity, and as Dr. Gauri Devi Madam has just said, majority of the care is provided by informal carers such as family members or spouses or some of the daughters or sons who have given up their work and to care for their parents. More demographics. So with regards to the sex ratios, so dementia is common in females than males. And the highest prevalence in males is in the 80 to 84 age group, and in the females, it's between the 85 and 89 age group. What's the story in Australia? So it's the second leading cause of death in Australians and the commonest cause of death in women since 2016, surpassing heart disease. The numbers are gradually increasing, and with regards to the prevalence, you're talking about 30% of over 85 have a diagnosis of dementia, and about 10% of the over 65 have a dementia diagnosis. And the young onset dementias are gradually increasing with the improved awareness. So costs are soaring in Australia significantly, and who is paying it? As taxpayers, we are paying these costs. And it is one of the single greatest cause of disability. Again, Professor Gauri Devi did stress on this, and this is what will impact on the amount of money we put in for these patients. And with the increasing numbers moving into institutionalized in nursing homes, it has become a national priority in Australia with rapid expansion of old age psychiatry services in the next 6 years, especially in Queensland. How does annual cost of dementia patient compare with other popular disorders like cancer, heart disease, and stroke? So add the three of them, still they don't touch how much we spend on each dementia patient per year. And comparatively, for such an important disorder with important outcomes, the annual government and charity investment in research is negligible. I think our preoccupation with regards to donations, voluntary services is predominantly with cancer and heart disease. And there's an unfortunate status, maybe add in stigma, throw in stigma to that. And we need to address this, and more money needs to come into investment in future research. Okay, so the rest of the talk, I've divided the management into the subtypes. I'll touch on the behavioral and psychological symptoms in dementia, and I'll finish off with the future research prospects. So the guidelines I have used are the BAP guidelines from 2017, the NICE guidelines from 2018, and the Australian guidelines from 2016. The Scottish guideline has been withdrawn, and before I left Australia, I have put in a proposal for a new guideline, which was approved. And if I did not move, probably I would have been chairing or co-chairing this guideline. Before we go full on, let's go into the general principles of management in elderly. I see that there are a number of trainees who are listening to my talk. So the dictum in addressing any elderly patient is to start something low and go slow, and think about frailty. Respect the pharmacokinetics and dynamics. It's very important. What I mean by that is at 30 milligrams of furosemide, which was relevant 20 years ago, may be hyperperfusing the brain of this individual, and maybe we need to address it. So medication optimization, medication reconciliation is extremely important, and we need to address the polypharmacy and as well as the anticholinergic burden. Coming to regular prescribing and PRN prescribing. I'm not a big proponent of a PRN prescribing, because PRN medications, especially if you live with haloperidol or paracetamol, will never get given. And they get, the patients eventually get huge doses of these medications because of a crisis. So as long as the right doses are maintained with regular prescribing, probably that's the way forward. Consider drug interactions and as well as physical comorbidities, and also a route of delivery. There was a lot of ethical discussion in the previous chat with Dr. Chansekar around medications, and covert pathway is one such medication administration, especially relevant to dementia. So if the patient is refusing and is sightless and lacks capacity, you need to get the multidisciplinary team involved, involve the family carers in getting the covert medication pathways. So mixing the medication in food or in the right juice, and also getting the pharmacist's view around whether the mixing is safe. So, and the other aspects I would be looking at physical monitoring, which is extremely important in elderly. So I'm looking at a management which is holistic and with a biopsychosocial approach. My agenda is physical, psychological, cognitive, and social well-being, and with the vision of promoting independence. Just a word on minimizing delirium, because we are dealing with a huge COVID era and a huge surge of delirium patients. I have chaired and published this evidence-based guideline on delirium last year, and co-chaired, in fact, sorry. And this is widely available online for you. It's called as the SIGN 157 guideline, and it's currently the only evidence-based guideline on delirium. So try to utilize for these patients, because there is a huge issue with these patients in UK and as well as in India. So just a recap around the diagnosis. There is a lots of new terminology which has come into evolving in dementia. So the advent of the terms like neurocognitive disorder, which was coined in the DSM-5. So the reasons why it has come is with regards to reducing stigma and also incorporating new research findings and improving the accuracy of diagnosis. What DSM-5 has done is expanded the pathology from neurodegenerative disorders into acquired disorders like HIV, head injury, etc. ICD-11 has adopted similar terminology, but there was some controversy when they classified dementia under neurological disorders rather than mental health disorders. I'm glad that Indian Psychiatric Society has strongly condemned and joined forces with the international consensus, where the diagnosis has been reverted back to mental health classification in ICD-11. But there's a change of coding and everything, and it will not come into force till the 2022, if I'm right. So just to touch the base of the differences between the DSM-4 diagnosis and DSM-5 diagnosis. So in DSM-4, you needed two criteria. So there is a memory impairment with another cognitive domain deficits for diagnosing dementia, in addition to exclusion of delirium and depression with substantial loss of independence and biopsychosocial functioning deficits. But DSM-5 seems to have diluted some of that, and the onus on memory has been diluted. And what it said was one or more of the cognitive domains is deficits is needed, and they have included social cognition as another cognitive domain. Again, cognitive deficits interfering with independence in every day, and also it's important to exclude depression, which can cause a pseudo-dementia type of picture, and as well as delirium prior to diagnosing these patients. So coming to management of Alzheimer's dementia. So let's go into the pathology. So dementia, especially Alzheimer's, the pathology surrounds mainly the neuritic plaques and neurofibrillary tangles. So the plaques are formed with amyloid beta deposition, and the tangles are formed intracellularly with hyperphosphorylation of tau. So, and there are a number of mechanisms. So you're talking about risk factors, mutations, trisomy 21, and inflammation, etc., which can lead to these abnormal metabolisms and the processing of the amyloid precursor protein, which would lead to these plaques and tangles, and which eventually cause neuronal damage. And this neuronal damage projects in the form of poor acetylcholine and the nerve endings. And that is the cholinergic hypothesis, which is currently holds the day with regards to the dementia pathology. So currently, there are two classes of drugs which are approved by NICE. So we have the acetylcholinesterase inhibitors, which can be utilized in mild to moderate dementia, and the NMDA receptor antagonist memantine are recommended for moderate to severe type of dementias. So how do the cholinesterase inhibitors work? So they inhibit the acetylcholinesterase enzyme, and obviously, sorry about that, and the increased availability of acetylcholine in nerve cells. Studies have proved that the lasting effects last for about from 6 months to 2 years, and the outcomes I'm looking at with regards to starting this medication is the ability to think clearly, improving the memory and day-to-day functioning, and as well as minimizing some of the behavioral and psychological symptoms or delaying these symptoms. So how do we titrate these medications? So donepezil is commonly used because of ease of titration. So it goes in one level. So you start with 5 milligrams in the morning after breakfast, and you increase that in a month's time to 10 milligrams. So this is the outpatient titration, what I'm talking about. So galantamine at 3 levels, so 8, 16, and 24 on a monthly titration, and rivastigmine about 1.5 to 6 in 6 milligrams BD in a fortnightly type of titration. But if these patients are titrated in an inpatient setting, probably it could be titrated a bit more earlier. So the follow-up is through MDT, the multidisciplinary team, working and memory clinic. So with regards to efficacy monitoring and as well as monitoring of side effects, and cognitive testing every 6 months to address the efficacy monitoring of the cognitive functions improvements. Side effects are common with cholinesterase inhibitors, especially the gastrointestinal side effects and as well as the cardiovascular side effects. One way of bypassing the gastrointestinal side effects is with regards to using a rivastigmine patch, which bypasses the initial metabolism. And cardiovascular side effects, be wary about lowered blood pressure and bradycardia. And the combination of both, I wouldn't start. It's a major contraindication, and probably I wouldn't start. Get a cardiologist involved and try to get more information about the safety of starting such medication. Donepezil, drug of choice in chronic kidney disease and liver disease. And more information about the cholinesterase inhibitors. So there is no difference in efficacy between these 3 generic medications, and switching between them remains valid, with about 50% appear to tolerate and benefit from the switching over. And monitor your Parkinson's symptoms. So your take-home message with cholinesterase inhibitors, consider combination of acetylcholinesterase inhibitors and memantine. So NICE does, for the first time, brings in this view. And again, don't stop donepezil based on the severity of the illness. So continue treatment of donepezil beyond MMSEs of less than 10, and because this is clearly associated with the cognitive and functional benefits when you continue donepezil. So I was involved in this study as a postgraduate in Scotland, and I was a co-investigator, which was eventually published in the New England Journal of Medicine. But the greatness of the study is this did help the NICE guideline to make amendments and change their guidance with regards to utility of donepezil in advanced dementias. So coming to memantine, it's recommended in moderate to severe dementia. The titration is you start at 5 milligrams in the morning and you increase by 5 milligrams on a weekly basis up to a maximum of 20 milligrams. So you combine with acetylcholinesterase inhibitors for better effect, and cognitive functional benefits last for about 12 months, and with delays in admissions to nursing home care. And the outcomes I'm looking at is improvement in activities of daily living, and as well as addressing some of the PTSD issues. So how does it work? So memantine competes with glutamate, so it's the NMDA receptor antagonist. Glutamate, higher levels of glutamate are found in Alzheimer's dementia, and glutamate damages neurons, so you're trying to control glutamate through memantine. Side effects are evident, hallucinations are very common, and psychosis is common in some of the cases, but caution should be exercised with in chronic renal failure, and it has the potential to increase, lower the seizure threshold, so and blood pressure changes. Coming to MCI, or the minor neurocognitive disorder, as it's the new term given to it. Unfortunately, the cholinesterase inhibitors and memantine have no benefit in these patients, but there has been lots of interest in research around the MCI and prodrome, because the monoclonal antibodies, which were utilized in moderate to severe dementias, which have failed studies, they have come back to MCI and mild dementias, and unfortunately, it's still a failure. I was a principal investigator of one of the studies, the cranizumab by Roche, and this is infusing the patients with monoclonal antibodies. Unfortunately, it doesn't work. And we were just discussing about the fads of Alzheimer's, and we have tabloids in UK such as the Daily Mail and Daily Star. Unfortunately, every weekend they come out with some of the pills which benefit the Alzheimer's dementia, and next day we are completely inundated with queries from the patients of, doctor, can you start these things? And we need to reassure them. So it's more of entertainment for others, but stress for us as treating clinicians. Moving on to vascular dementia. So there are no current licensed treatments for vascular dementia. The focus is on control of cardiovascular and cerebrovascular risk factors. There are mixed messages with regards to cholinergic hypothesis, and the key is to prevent recurrent stroke, antihypertensives in hemorrhagic stroke, and antiplatelet and lipid-lowering strategies in ischemic stroke. So there have been a number of studies which showed initial benefits with cholinesterase inhibitors, and the meta-analysis clearly stated that the data is insufficient to support these medications. There is a possibility of utilizing cholinesterase inhibitors, especially in a mixed dementia picture. When I say mixed dementia, it's mixed Alzheimer's and vascular dementia. So one of your take-home messages is consider cholinesterase inhibitors or memantine in mixed Alzheimer's and vascular dementia, but there are no clear recommendations for vascular dementia on its own. So coming to DLB and PDD, so dementia of Lewy bodies and Parkinson's dementia diagnosis. So here you see the photograph of Ian McKeith. Professor McKeith is the guru of DLB, and I had the opportunity to share the stage with him in the British Association of Psychopharmacology a couple of years ago. Humble man, a great person, and do have a read around his consensus report from 2017 for diagnosis. So DLB is a major, major challenge, and especially you're playing with receptors here and as well as dopamine. You're looking at the challenges of cognitive versus non-cognitive symptoms, and as well as psychosis versus Parkinsonian motor symptoms. So antipsychotics increase Parkinsonian features, anti-Parkinson's increase psychosis. So it's how you optimize it as much as you can. So there is a clear evidence for rivastigmine for both cognitive symptoms in DLB and as well as non-cognitive benefits, such as neuropsychiatric symptoms, including visual hallucinations, apathy, anxiety, and sleep disorders. So the NICE clearly recommends donepezil or rivastigmine in mild to moderate DLB. And if there are contraindications for some of the cholinesterase inhibitors, memantine can be considered. And for PDD, the only licensed medications in Parkinson's dementia diagnosis is only rivastigmine according to the NICE Parkinsonian guidelines. So the other cholinesterase inhibitors, including are unlicensed, and consider memantine if cholinesterase inhibitors are contraindicated. For the non-cognitive symptoms, so suppose if someone has visual hallucinations, which are very common in Parkinson's-related dementias, I normally do not actively treat a visual hallucinations if it is not distressing. So they could be a very pleasantly, the person would be seeing a cat or a dog or a human. And if it's not acting over, probably I will leave it and follow up these patients. But if it is distressing, probably the plan A for me would be to reduce the dopaminergic medication and without compromising the motor functioning. And Plan B would be considering cholinesterase inhibitors prior to starting the patients on antipsychotics. So for REM sleep issues like nightmares, consider clonazepam at tiny doses, and melatonin is gradually creeping into the NICE guidance. Daytime sleepiness, narcolepsy, considered modafinil, and psychosis, low-dose quetiapine or pimavanserin, which is FDA approved. Frontotemporal dementias. Unfortunately, cholinesterase inhibitors and memantine do not work in frontotemporal dementias, but what happens is these patients end up with a cocktail of psychotropic medications of a combination of antidepressant and antipsychotic. It's unfortunate because of the need, especially with their social and sexual disinhibitiveness and aggression, they end up with these medications. Other dementias. So you have some other rare dementias and Parkinson's plus syndromes. The studies are inadequate and recommendations, we do not have any recommendations with regards to cholinesterase inhibitors or any other medications. Ginkgo. Ginkgo showed some prospects, good prospects in the initial trials, which are very small trials. But the two large RCTs which were done on Ginkgo, unfortunately, showed no benefits. In fact, they increased the stroke and TIAs. Hormone replacement therapy. Well, the agenda behind this is females live longer and estrogen and the female sex hormones being protective in that nature. So they tried the HRT and the ERT, and in both arms, it increased the risk of dementia, unfortunately. So more therapies, B12 and folate. So if you go back to the Framingham study, so obviously, homocysteine is linked to Alzheimer's dementia diagnosis. So B12 and folate try to reduce the homocysteine, but RCTs no beneficial effect. Statins, again, no benefit, no effect at all. And Suvinate, I'm not sure whether it is available in India. This is nothing but an infused yogurt drink, which comes from Scandinavia, repackaged and 10 times the cost. And unfortunately, it's not recommended. Right, let's move on to the behavioral and psychological symptoms of dementia. There are multiple causes, and the new term for this to reduce the stigma is the stress and distress. So up to 80 to 90% of dementia patients experience these symptoms at some point in the course of their illness. The symptoms, the common symptoms are agitation, anxiety, wandering, vocalization, aggression, and psychosis. So, but the real controversy is using antipsychotics, and the real nail driven in the head was because of this study from the Department of Health by Professor Subi Banerjee in 2009, where he looked at various, it's a multicentric study, and he said that 25% of the patients diagnosed with dementia are on antipsychotics, and out of the 180,000 sample, he felt that 140,000 prescriptions were inappropriate, and he demonstrated that it increases mortality and also it increases the risk of stroke. So this was piggybacked, and the psychiatrists and as well as the general practitioners and geriatricians have been accused of a chemical cost, and this led to inclusion of some of the commitments in the national dementia strategies in Scotland and England of taking a pledge to reduce the antipsychotic treatments, which eventually happened, and there's a significant reduction over a period of time. So how does US compare with regards to the psychotropic use? This is from a recent JAMA study published in August 2020. 75%, 3/4 of the population are on psychotropics or opioid medication. If you look at the antipsychotics, around 20 US. So antipsychotics, you're looking at 22% there, and antidepressants around 42%. So again, significant numbers. And again, what you see is a polypharmacy too. So reacting to that, the Australian government, the Department of Health, has come up with this 6 steps of safer prescribing. The important dictums are consult the team, assess the person. It's more of a person-centered care what you're providing. Use other strategies like non-pharmacological strategies, distraction, get informed consent, and start low and go slow, and plan a review. So management principles. So obviously, non-pharmacological approaches and person-centered care is the most important thing which needs to be considered. And the vision is promoting cognition, well-being, and independence. So psychosocial multi-component interventions mainly revolve around cognitive stimulation, behavioral aspects, and physical exercise. But I would concentrate on the reminiscence therapy. Playlist for Life is a Scottish app which tags your date of birth to the music which is played. So if you're born in the 1950s, it almost prepares the music album for you, which is relevant for popular music, which was relevant for your age. So I hope someone develops this in India. This is a huge, huge benefit and has made a huge difference in some of the patients in the nursing homes, especially with the BPSD side of things. It is used as a distraction strategy. So coming to the pharmacological principles, psychotropic medications, especially antipsychotics, they are indicated. When are they indicated? Only in severe distress and psychotic symptoms, when the person is risk to self and others, try to start, but involve the patient and carer and discuss the risks and benefits. The prescription should be time limiting and frequent reviews. And the proposed review is in 6 weeks' time with the best evidence for risperidone in the NICE guideline. Quetiapine, evidence is weak. Olanzapine, aripiprazole, and haloperidol is a very small benefit. And more importantly, quetiapine, postural hypotension, and the prolonged QTC, it adds to our woes. So NICE further reiterates what I have just said. Routinely, they shouldn't be prescribed, and they should be prescribed only in severe distress and in severe psychosis and agitation. What are the other medications we could use? So agitation in BPSD. There is some evidence with using citalopram. I would caution you in using citalopram with QTC prolonging agents. So it's a clear contraindication. And the maximum dose of citalopram in elderly is 20 milligrams. And escitalopram is 10 milligrams. Cholinesterase inhibitors and memantine in agitation, studies failed to show benefit. Calm AD trial by Rob Howard from London, unfortunately from Maudsley, it hasn't shown any benefits. Depression is very common. 30% to 40% of dementia patients develop depression. Many of the antidepressants are commonly used, but there is no specific guidance. This study from Cipriani et al., which was published in 2015, hasn't showed any particular guidance. So if someone develops depression, probably the existing guidelines in management of depression should be employed. Dextromethorphan. This is an antitussive, which is used in cough mixtures. So sudocrem that is the lability of effect you see in vascular dementia. I have used a number of for my majority of my patients, and it had a proven benefit. Trazodone. Unfortunately, I don't get trazodone in Australia, but this was the most abused medication by me in UK. Because this is an atypical antidepressant and low doses help with the sleep pattern improves the behavior the following day. But unfortunately, I looked at various studies, evidence, and there is no evidence to support trazodone in dementia patients. Mood stabilizers, there are a number of RCTs, and carbamazepine and valproate do not work. Melatonin, again, NICE 2018 guideline says that it doesn't work. And I looked at melatonin in delirium, it doesn't work. Benzos, refrain from using long-acting benzodiazepines such as diazepam. Lorazepam could be considered in crisis. Other aspects of care, driving, especially with the nuclear families, would be an issue, which affects one's independence. So properly, the important thing is education, which should go with the diagnosis and requesting the patient to give up some of in the best interest of himself and as well as safety of others. Carer education to reduce the carer distress, and again, advanced care planning. So you're talking about preparing the patient for power of attorney and guardianship issues, advanced health directives, and preference of place of care and death, and do not resuscitate policies need to be discussed. And again, research participation, give the material. If there are drug trials ongoing in your vicinity, in your areas, give them the information about them. So future treatment prospects. So looks like we have put all eggs in one basket with regards to our amyloid, the impetus on the research and the billions of pounds and dollars pumped into the beta amyloid. Unfortunately, it's doom and gloom. So There are various medications which have been tried, and it's all failures. So initially, the monoclonal antibodies have been tried in moderate to severe dementias. Because they did not work to preserve the molecule, they moved to MCI and mild dementias. Unfortunately, they haven't worked. So there are other study failures with regards to amyloid, oligomer, and plaque prevention. And I had established a research place of excellence in Scotland, where I worked, and was involved as a principal investigator for various studies. So made minocycline, which is a tetracycline group of antibiotic. We did use it as an adjuvant in mild Alzheimer's dementia. Unfortunately, it doesn't work. ILAD, which is liraglutide. Liraglutide is a GLP, glucagon-like peptide, which is commonly used in diabetes mellitus. So it's a neuroprotective agent. So we did do this study on liraglutide. Unfortunately, even this study has failed. And I have already told you about cranizumab, which is a monoclonal antibody. And again, there was no sort of negative result. So gradually, things are moving. So the researchers felt that because of the failure and the doom and gloom with the research nihilism towards dementia molecules, they felt that with more PET studies, they felt that the amyloid is not the basis, and probably amyloid and tau are separate, and they act summatively. And maybe the tau seems to be the more important aspect. And in the future, maybe in the next decade, we'll see a lot of studies and molecules coming with regards to the tau pathology. And hopefully we crack it this time. So I'll finish off with the prevention. So there is no evidence at present to support drug prevention, but lithium is a curious case. The story of lithium goes back to your bipolar patients. So people studied that the bipolar patients on lithium had less cognitive dysfunction. So they have done fMRIs on these patients, especially elderly, and there was a preserved hippocampal volume. And subsequent studies showed that lithium in the drinking water helped in reducing some of the cognitive dysfunction within a community. And there is a study which is coming from Sao Paulo, which was initially published in 2011, but a subgroup analysis was done in 2019, which showed with a very small sample of 41 patients, where it showed that continued use of lithium in MCI prevented progression into dementia. Sometimes in this therapeutic nihilism and research nihilism, we may have to accept some of these small studies, but a large RCT with lithium is warranted before we start treating patients actively. So coming to prevention, combination of exercise, diet, cognitive training, and cardiovascular health optimization can slow cognitive decline, but the timing is very, very important. So it should be before the preclinical dementias, and some of the strength of evidence is moderate for physical activity and vascular risk factors, but extremely low for the other things. If nothing works, we have learned from Mr. Trump that you create your own cognitive scale and you deem yourself as good enough to be the president of US. And my final words, dementia is a huge blind spot and a major unmet need. It should be considered as a national priority in India. And we need some collaboration, especially bigger institutions like Institute of Mental Health should collaborate with NIMANS and other institutes to create those dementia champions and awareness, and also create that skill set and resources with massive expansion of some of the psychiatric services, and aged care facilities are the dire need. And more importantly, the driver to these, what I have just said, should be a national dementia strategy, which should come from top down from the government with necessary standards and commitments, is the need of the hour to face this challenge. So it's a sunset here. These are some of the shots, parting shots from my home. And thank you very much for listening.
Thank you, Dr. Ajay Verma. It's very comprehensive, and you give us evidence, and I mean, you have taken us through the, diagnostic classification and, the categories, and you also spoke about the medications, like where indicated and with usefulness, with the evidence. It's quite interesting. I'm sure we'll be having some questions. Dr. Joshi, do you think you have some questions in the mail box? Yeah. And before he goes into things, I'll ask a couple of questions because I want people to learn more from you. One is that I just want to ask you, spoke about the aripiprazole. Like in the US, they use, as well as in like Nimans, the dementias, they do use for agitation as well as, for behavioral symptoms, elderly people, especially the people with Parkinsonism, they have risk of EPS. They do use small doses of aripiprazole. I mean, how do you take it? I mean, what's your experience or take on it?
Yeah. So, I mean, if you are strictly asking me as an academician with evidence-based practice, aripiprazole comes as the plan C for me. So plan A would be quetiapine, low doses. And you'd be surprised to see from the Parkinson's guidelines from Scotland and as well as from NICE, proposing clozapine as one of your treatments for psychosis, which is very difficult, especially in elderly, to really manage and follow up these patients. Yeah, I have used lots of aripiprazole, especially with prolonged QTC. So if you have prolonged QTC, your medications become very limited, especially antipsychotics. And yes, brexpiprazole and aripiprazole are some of the medications I commonly use in Parkinson's patients, especially with distressing neuropsychiatric symptoms.
Thank you.
There's one question.
Like now we've seen that clozapine is one of the best drugs.
It
the
is.
small doses, the visual hallucinations and the auditory hallucinations, which are troublesome for the patient as well as the relatives. I agree with you.
And just on that aspect, when you're treating patients with dementia, psychosis and dementia, Professor Reeves from Maudsley again has published extensively on this aspect. You don't need big doses. You need tiny doses of risperidone or tiny doses of quetiapine, so to address some of your psychotic symptoms when compared to your psychosis in schizophrenia.
Yeah, Dr. Joshi.
Yeah, there is one question by Vyasa. Can Ajay expand on the lithium in prevention of AD, please?
Yeah. So as I said, yes. So this is a curious case of lithium. That's how I would put it as. So it's an incidental finding, and in fact, one of my trainees in here has presented a very detailed journal club, and I was astonished to see the preservation of the hippocampal and entorhinal cortex in bipolar patients. So I mean, it's, if I'm not wrong, the person who has published is for Lanza from Sao Paulo, Brazil. So have a look at it. His first initial paper was in 2011, and his subgroup analysis came in 2019. The subgroup analysis had just 41 patients. So we can't base our treatments based on such a small study. So it needs to be replicated as an RCT. And there were flaws in that study. So the p-values, confounding factors, but with the therapeutic nihilism, with the very limited treatment options, sometimes you're forced to accept, but I think I would wait for a longer RCT before I try a lithium in this vulnerable age group with kidney disease and thyroid disease, which needs to be taken into consideration in elderly.
Any more questions, Dr. Joshi?
No, actually, in the clinical practice, when you are seeing variety of people coming to your clinic, and in the Indian setup, when you have to see 10, 15 patients at a time, and when you find that the dementia patient with a fluctuating moods, that is unstable mood, what a mood stabilizer would you prefer in these patients?
Sir, I have extensively looked at the mood stabilizers. I mean, carbamazepine and the sodium valproate has those days. So 2000, I did start a memory clinic in care hospitals, and I did utilize some of those. There is a place, especially if you're thinking of advanced dementias. Seizures are pretty common, and non-convulsive status can lead to those fluctuating type of presentations. So you may be controlling some of those, but in the absence of these non-convulsive status or seizure phenomenon on EEG, I don't think there is a place for these medications. These are dangerous medications and very sedating medications. Dementia is a confused state, and you're already confusing the patient more with pregabalins and these anti-epileptics, which further lower. So it's a difficult question. I mean, when you have 15 patients in your OPD and with a lack of an MDT approach, it becomes very difficult to manage. I'm saying here that you should really invest your time in psychosocial aspects of care. You try to educate the family as much as you can, but you need a team to really address these issues. I had the liberty of a full MDT in a community as an old age psychiatrist to control some of these with an inpatient facility, with a day hospital facility, with a respite facility. So these are the buffers I have had to manage these patients. I used to deem any of my patients admitted in the hospital as my personal failure. That's how I used to work.
Here, I would actually, I was surprised because one IT youngsters from Hyderabad, now Hyderabad is a very IT hub, and his parents, when they came with dementia and this problem, when I was explaining to him that how these drugs can cause these side effects and all that, we said, doctor, why can't you think about the family that is taking care of to get relief rather than the patient? Because you're saying the patient has got no treatment. So at least you do something to the patient, which will give us relief and we can do our work.
I would also treat the family, sir.
No, I think I fully agree with Ajay. The reason is that, you see, like sodium valproate and carbamazepine, they have serious side effects, like hyponatremia and sometimes hyperammonia.
Exactly, madam.
Especially when they have, other medications which they are taking. So unnecessarily you are causing, damage. And, this patient, they're going to delirium, they fall down, they break bones.
Very much.
These are the things I think one need to. Another thing, I mean, in case of I just responding to Dr. Joshi, the best drug would be maybe you can give quetiapine if they don't have any cardiac problems.
Very low dose, very low dose. I'm talking about 6.25 milligrams in drops.
Maybe throughout the day you give in small doses, divided doses. That would be better. And I think if not many questions, I think I would like to take advantage of Ajay and take a few more questions. Yeah, I'm sure you
Sure,
will
madam.
take.
Pleasure.
There is one question by Sai.
Yeah, sure.
How do you explain memory problems as a side effect of lithium? That's a fantastic presentation. That's sorry, he's complimenting you, but asking you a question.
So, memory problems with lithium, probably psychiatrists like you are more experienced in managing general adult patients. Do you see memory problems in lithium?
No, I'm surprised about that question because as a matter of
I'm not sure about that.
Yeah, some of the bipolars do well on lithium for a long period of time, even when they aged, as a matter of fact.
Exactly. Any other questions?
No, Gauri, we can actually add her.
Yeah, quickly I'll ask because of my experience and my liaison with the neurophysicians. I found that pramipexole, especially Parkinson, Lewy body syndrome, and also with small depression. I found a couple of patients doing very well. The neurophysician referred saying that it's a depression, and more than acetylopram, which can cause more damage, like hyponatremia. I just tried small doses of pramipexole. And
the only problem with pramipexole, madam. So
psychosis.
Brilliant.
Only problem is psychosis, maybe can
exactly. So that's what is the only issue. And sometimes you may end up with some impulsive disorders too with pramipexole. So, and if you're having issues with hyponatremia, the best antidepressants is valdoxone, agomelatine, which has very minimal impact. And lately, one of the antipsychotics which I have discovered, which is beneficial with limited anticholinergic side effects, is lurasidone.
Yeah.
So lurasidone, low doses, it works brilliantly, better than some of the quetiapine or other things. There is a risk of EPS with the lurasidone when compared to quetiapine, but it gives you that buffer, especially with hyponatremias and QTC prolongations. It doesn't cause QTC prolongation.
Lurasidone, again, you have got epigastric, the gastric discomfort all is a major problem there.
Exactly, sir. But if that's an issue, so give it PPI and take care of the PPIs in elderly, cause delirium.
Delirium, right. Exactly. It's very difficult in the elderly to
Please.
manage
You need to
because there are so
balance.
many parameters to be taken care of.
Okay, quickly, I just want to say something about the music therapy. You know,
sure.
What you said is very true. Like, I mean, my daughter-in-law, she's a music therapist, trained from Bristol, and she's in the, I mean, like, she's working in Malmo. She's a she's from Sweden. She has done a lot of work on this. As you are rightly saying that she's working with Indian group of people. She asked me, songs or, which are used in adolescence or for marriages or, bhajans and all those things. She picked up those things which are very, very common in different languages, Hindi, Telugu, Tamil, and she's taking them and using them, which they use. I mean, music is something which people will not forget, I suppose. You can use, you can miss words, but you'll never miss music or the things which you learn in childhood. And all the centers in the brain get stimulated when you listen to the music. She's working on it now in Scandinavian countries. Yeah.
Even if she can contact this guy in Glasgow, the playlist of her life is managed by this guy in Glasgow. Absolutely brilliant. The way he has, and he is enjoying the royalty from this, selling these things to other countries. But if someone like IT background professional with parent with dementia, if they can come up with this for India, that would be brilliant.
In India, what I have been doing with these patients is I'm trying to make those youngsters to create an old environment, not just by music, even like the bhajans and kirtans that they used to listen in those days, the memories of the old photographs and the videos of the old age, what they had spent when they were in their 40s and 50s. And many of them really do well. And their behavioral problems are controlled by just watching at that and spending time with that. So that sometimes is non-pharmacologically more beneficial, actually.
True, sir. Expanding the spiritual beliefs as much as we can.
Yeah.
Thank you, Ajay. I think I don't want to delay the other proceedings, and thank you so much. It was quite elaborate and
not just proceeding. Even the lunch, we are delaying the lunch. Probably many of them
Sorry
probably
about that,
might be
everyone.
having already. Many of them probably already having lunch while listening to us, and then we'll probably let them have a pleasurable lunch. And it was really nice to be with you, Ajay and Gauri, and really with my alumni, the first fellow to join, and the next generation, which has really improved and shown a great IMH alumni. I'm really proud of being an alumni of IMH. Thanks to Dr. Raghuram Reddy and Krishnamurthy. We are the only first qualified assistant professor was Kartikeya, and Dr. Raghuram Reddy, Chandrasekhar Reddy, and P.T. Chandramouli were the senior qualified people who were teaching us. And it is a pleasure, really. It is a pleasure that we...
Over to organizers. Thank you.
Organizers, yeah.
We thank both of us. Thank the organizers for giving us this wonderful opportunity to interact with all of you. Thank you.
The lady said it better. Lady said it better.
Thank you for the wonderful session, Dr. Ajay Verma sir, Dr. Gauri Devi ma'am, and Dr. Madhusudan Joshi sir. Now moving on to the next topic, developing emotional resilience in medical workforce. The speaker is Dr. Farooq Khan. One of the chairpersons is Dr. Ramakrishna sir, who did his MD from Banaras Hindu University. He was a retired superintendent of GHMC Vishakhapatnam, retired HOD of Department of Psychiatry of Deccan Medical College. He wrote books on Banamati and alcohol. The other chairperson is Dr. Ashok Reddy sir, who worked as a professor of psychiatry in Usmania Medical College, Hyderabad. He is the founder director of Government Medical College, Mehboob Nagar. He is currently the election officer for Indian Psychiatric Society and professor and HOD of psychiatry in SVS Medical College, Mehboob Nagar. Now I hand over the session to the speaker and chairpersons. Thank you.
Good afternoon, Dr. Ramkrishna sir. Are you available? Shall I continue or Dr. Ramkrishna is available? Hello?
Hello, sir.
Hello. Good afternoon, Dr. Farooq. I'm looking for
Hello.
to come.
Yeah, okay, yeah.
He has not yet joined, I think. He's not visible. His name is visible.
Sir, you can continue.
Yeah,
Sir will join, sir. Sir will join.
Okay.
Sir. Because already we delayed. Sir will
Right.
meanwhile.
Yeah, very good afternoon to all the delegates for the IMH Alumni Global Meet today. And we are grateful to Dr. Kishan, Dr. Umashankar, Dr. Keshav Rao, who are very instrumental to organize this global meet. And you made us to interact with all of our teachers as well as our students and young psychiatrists, budding psychiatrists, brought to the same platform. It's a very memorable experience for all of us. And thank you for giving the opportunity to chair the session of that Farooq Khan presentation, who was my student at IMH. I do recollect he was very good in academics when he was the postgraduate here. I think he continues to be to do that. And he has reached there. I think the CV was submitted to Dr. Ramkrishna. He is supposed to present. I don't have the copy now. Can the organizer project the CV so that I can just read? Meanwhile, I'll talk about the subject. And resilience, as we know, is the ability of the person to withstand the challenges and hold back and able to continue to serve again. And the resilience is more important for physicians. And the COVID period has made us more aware about this resilience. The COVID warriors, what we call physicians who are working as frontline warriors, resilience what has become more prominent because they're able to face, withstand, and able to serve the population. And that Farooq Khan is going to talk to us about the resilience in physicians, how to basics about it, as well as how to improve the resilience. I think without much CV will present at the end. I think I'll request Dr. Farooq to present, or he himself can present his CV directly because I don't have the copy now.
Okay. Thanks a lot, Dr. Ashok Reddy. Yeah. First of all, let me sort of thank the organizers for allowing me to present in front of all the alumni. I've known many of you, so there are I'm quite delighted and honored to be part of this. In the presence of my professors, Dr. Ashok Reddy, Dr. Gauri Devi, Dr. Krishnamurthy, and many more teachers in there, Dr. Umashankar, all these sort of seniors and juniors, and my friends as well here. So I'm feeling quite privileged and honored, honestly. Thanking the organizers as well, Dr. Pramod Kumar, Dr. Kishan, Dr. Shiva Kumar, Dr. Umashankar, Preeti Swarup, and all people who have put a lot of efforts in organizing this meet. As Dr. Ashok Reddy sir was saying, that I was one of his students, and I remember all the sort of days in the initial days of the ward rounds and our presentations to you, sir, in the outpatient department. So it's been an excellent teaching session. So I'm quite indebted to all my teachers where I am and for supporting me and sort of nurturing my abilities and my qualities. So following Ajay's act is quite difficult because Ajay is an excellent speaker and he has done a huge amount of work in dementia, and that happens to be my specialty as well, in West Midlands and in Birmingham. So I'll be quite. I was quite delighted to listen to Ajay. I do have listened to him before in the conferences, but it was really good to see him speaking from Australia. So it's a difficult act to follow, but I'll change the mood here. We've been talking about the clinical issues and matters. You've heard about the ECTs, very good and lively discussion there. The ECTs, we had a lot of detailed discussion with Ajay about the dementias, the management of dementias. So changing the mood, as Dr. Ashok Reddy was saying, and earlier on, Dr. Gauri Devi Madam also pointed out in some of the things, that learning some of the problem-solving skills, some of the management side of things, that is left behind in our medical school teaching, that is left behind in our postgraduate school teaching. And also, it's just not in Indian context, it is left behind in the UK as well. And here as well, we find it quite difficult sometimes to see how we approach that topic, because it's not a regular topic, it's not a routine sort of stuff. We are quite preoccupied with a clinical side of things, how to treat our patients. My patients, they're in the clinic, I want to sort of prescribe them something and then get them better. So that's our as clinicians. But I think it'll be very important to know that as leaders in the medical fraternity, and especially as psychiatrists, we have a role. And we have a role especially in the crisis situations. So there are frontline doctors who are working. So maybe the accident emergency doctors in the acute hospitals who are working day in and day out, the nurses are working. Is there a package in terms of psychological support, in terms of providing them sort of guidelines and supporting them to do their work? So frontline heroes, what are we doing for them as a psychiatric fraternity? Are we robust enough? Are we resilient enough to step up to the challenge? And that was the reason I thought it would be a good idea to talk about this. So before I sort of discuss, I just want to take a somber moment to remember some of the people in the UK, and also unfortunately in a lot of other places, including India, the frontline health workers we have lost to COVID. So just giving a moment for them to see, there are many of them who are nurses, many of them who are social workers, many of them who are doctors. And these doctors, if you look at them, they are not only older adults. So we're talking about very young people who just recently graduated. They're nurses, they're doctors who've just been sort of quite young in their 30s, in their 40s, but unfortunately lost to COVID. There's another reality that sits in with the COVID, is about the Black and Asian minority ethnic groups. So in the UK, in the US, we have seen a number of people who have unfortunately passed away as doctors and nurses. They have been from the BAME background. And this is something the researchers are putting a lot of effort to find out the causes, why that would have been the case, that a lot of Black and Asian minority ethnic groups unfortunately have succumbed to this disease. So some memories and remembrance of some of the people who were in the front line. Poonima Nair, she was a GP, 56, County Durham. She was ill for 2 weeks and unfortunately couldn't make it. The practice manager of her practice described her as very positive, encouraging and caring person. And they can't believe, unfortunately, how she has sort of succumbed to the death, and they just can't come to terms with that. She was described by her family as quite heartfelt condolences to her, and then it's very difficult for the family to deal with this grief. Another midwife, Safa Alam, she was 30 years of age at Birmingham Women's Hospital, and then unfortunately she was one of the first persons in the initial part of the pandemic to succumb to the disease.
Hello?
She had written on the Facebook.
Attention speaker and Ashok Reddy.
Yes, sir.
Ashok Reddy, sir. That
Yes,
Ramakrishna is in. Ramakrishna.
Hello? Yes, sir. We are hearing, sir.
ఇప్పుడే వచ్చినా
సార్
క్లిక్ చేయమంటారా ఇక్కడ
సార్ మీద వీడియో షేరింగ్ చేయాలి, వీడియో షేర్ చేయలేదు మీరు.
వీడియోనా
వీడియో షేర్ చేస్తే మీరు కనిపిస్తారు. మీ వాయిస్ వినబడుతుంది, వీడియో షేరింగ్ లేదు.
ఇప్పుడు
లేదు, ఇంకా రాలేదు.
ఇప్పుడు
లేదు సార్.
ఇప్పుడు
లేదు సార్, ఇంకా రాలేదు.
నౌ
నో,
you can't start your video because the host has disabled it అనుస్తుంది.
Okay, attention to
right. Organizers have to correct it. That Shiva, please take it.
అందుకే రావట్లేదు.
attention to organizers.
That Shiva, please take care of this.
చూడు ఇప్పుడు కనిపిస్తున్నారా?
లేదు సార్, లేదు, ఇంకా లేదు.
నేను కూడా కనిపించట్లేదా?
లేదు సార్, కనిపిస్తలేదు.
వినిపిస్తుందా?
వినబడుతుంది.
మరి అది పోతే ఇది పోతుంది, ఇది పోతే అది పోతుంది.
Yes sir. Even without video, you just talk, sir. Whatever you Farooq Khan is talk is going on, sir. That Ashok Reddy is chairing.
సరే.
Now almost 30% of talk is over, sir.
You continue it. At the end, I will talk to him.
Yeah, after session you can put your remarks, sir. The video will become on. Okay.
Okay.
Over to Ashok Reddy, sir, to coordinate. Sir, your video also on, sir, now. Sir, Ramkrish sir.
You are visible.
మీ వీడియో సార్, మీరు ఏమైనా చెప్తారు, రెండు మాటలు చెప్పచ్చు సార్. ఓకే.
ఇది కనిపించట్లేదు నాకు.
మీరున్నారు, మీరు అందరు కనిపిస్తున్నారు, వినిపిస్తున్నారు, మీరు మాట్లాడండి సార్. ఇక
హలో డాక్టర్ ఫరూక్.
Yes sir.
Yeah, I am Dr. Ramakrishna.
Good morning from here in the UK. Good afternoon to you. Good morning from the UK.
Yeah. Good afternoon. Okay, how are you?
Yeah, fine. Thanks.
I am retired professor of psychiatry at IMH.
Yes, sir.
You are in 91, 95?
So I'm from 2003, so batch I exited on 2003.
2003, I think. I see. Okay. How are you there?
Yeah, I'm fine. Thanks, sir.
Sudhakar and Krishnamurthy is my colleague.
Yes.
They're all. Ashok Reddy is my student. Kishan is my student. Okay, glad to see you. Yes, just kindly start. I will listen to you.
Yeah.
Okay.
Kindly
start.
Thank you, sir.
Thank you.
So thanks a lot, Dr. Ramakrishna. So I think we're just describing some of the thoughtful moments in this period of difficulties around the COVID. So I was just reading some of the sort of Facebook post of Safa Alam, who passed away. So she has made a plea in the beginning of the pandemic to all people that she's a midwife and she'll look after your baby and the health and safety of them. And everybody, please help me stay safe by staying at home as much as you can. So that was, you remember, in the beginning of the pandemic, there were a lot of problems people were having of social distancing, and lockdown was there. And unfortunately, after the father acquired the illness, he died 2 weeks after she unfortunately passed away. And she's been described as a very kind and compassionate person. Another doctor, Dr. Chaudhary, he was a consultant urologist in Homerton Hospital in Hackney in London, and unfortunately died 15 days after admission to the hospital in Romford. He wrote to Boris Johnson at the time that he outlined the need for the personal protective equipment. PPEs have been quite a challenge in the beginning of the pandemic, when the frontline staff could not get the access to the PPEs, and some of the staff members would have succumbed because of that. And he wrote to Boris Johnson suggesting that health workers are in direct contact with the patients. They've got the human rights like any others to live in a disease-free world with their families and children. And then it was taken cognizance by Philip Glanville, who is the Labour mayor in Hackney, and he hailed him as a hero. And he suggested that I hope his death wasn't as a result of continuing issues with the testing and the PPEs. So this is some of the frontline healthcare workers who have succumbed in the UK, and I'm sure in rest of the world as well, a similar sort of situation. Now, the learning objectives I have put down in here is I'll not take a lot to talk about in the it means to be in frontline, because all of you would know what it means to be in the frontline. You have been working the frontline, but some of us can do more in terms of providing that help to the more frontline people. I think I'll talk about that.
need to sort of talk about managing internal anxieties and also intolerance of uncertainty. These are the concepts we'll talk about. There is also a perceived anxiety and then actual demands. So how we feel stressed about the situation and what is the actual stress and what is the perceived stress in people. And why emotional resilience? Why should we talk about emotional resilience and how we build emotional resilience in people? And then enhancing psychological well-being to ourselves and also to our other members of staff and other colleagues in other areas. So talk about the why emotional resilience is. You are, as professionals and especially medical fraternity, you are in the front line, and being in the front line is something sometimes quite challenging. So especially in the circumstances like COVID or floods, Hyderabad is facing a lot of floods in the coming in these days. So what does it mean to be in the front line, to face people straight in the difficulties and in situations where they can't go to anybody, they can't find any help there, and you are the front line. We have been and we should be the leaders in the healthcare. So we should be appearing as, and also we should be acting as leaders in the healthcare. We should be the people who should drive the change. And we should be people whom people should approach for bringing about a change in the society, in the when the challenges appear, like COVID, like the floods. We should be people who will be driving the change that happens. And then unfortunately, if we are in the back seat and we are not in the driving seat, then we can't blame for a bumpy ride, because we don't want to be sitting in the driving seat. So we need to be sitting in the driving seat to drive the change that happens. A lot of the times, we as clinicians want to be clinicians. So you want to take up the job as a consultant psychiatrist, or take up a job as a doctor in a clinic, in a hospital, and you get a salary and you're happy with that to continue. But you don't want to be into the management and leadership and taking up the big responsibilities. And I think this is the area where I felt it's very important to talk about the emotional resilience, so that we understand and know the needs, why we should be taking these responsibilities, bigger hats on, so that we become part of those management teams, part of those leadership teams, and not to shy away from the responsibilities that comes with that. And then be the change. Now it is rhetoric, you can say, but it is what it is. If you want to be seeing the change, if you want to bring about a change, you need to be part of that. You can't be sitting in the background and then expecting change should happen. As psychiatrists, I really feel that we are in the right situation. We have a very clear and a good understanding of the psychological aspects. We have the understanding of the cognitive abilities. We have the understanding of our own cognitive abilities and the cognitive abilities of other people. We can analyze, we can sort of discuss issues and problems in a very different way than many of the frontline healthcare professionals and doctors may not be able to do. So we have got those sort of skills we acquire by training into psychiatry for 2, 3, 4 years, and then a wealth of experience of 10, 15, 20 years when we work into psychiatry, by seeing number of patients, by reading an immense amount of literature. You train yourself to be in that position that you can understand and analyze people's mind. When people meet you, they say, oh, you're a psychiatrist, you can read my mind. We may not be able to read everybody's mind, but we will be able to analyze things in a very, very different way than a lot of people can't do. So that's why I think for us to help our medical fraternity, we need to be in that sort of driving seat to inform that change. Now, talking about emotional resilience itself. So GlaxoSmithKline has described is the ability to succeed personally and professionally in the midst of a high pressured, fast moving and continuously changing environment. So this is the resilience bit. So people who are personally and professionally, they proceed, they progress in the changing environment. So there are a lot of pressures coming your way. There are a lot of resistance coming in your way, but you're continuously moving fast, moving ahead in that changing environment. And UK Health risk assessment tool has also described emotional resilience as an attitude and skill set of an individual, allowing them to cope with great efficiency and effectiveness in the periods of change and stress. So this is something that individuals have that in them, or they develop a great degree of efficacy and efficiency, and then they can adapt and act in a long period of time in stress. So to adapt to the change that happens, that is stressful environment, that crisis that is in your way, the way to adapt that, that is what emotional resilience stands for. So some more expansion of about the mental flexibility. So it's easy for me to define that and somebody to define that and say that, okay, this is what resilience is. But how cognitively, what are we talking about in the mental structures? So we talk about the mental flexibility in there. So it's a psychological ability to get go of old internal structures of thinking and behaving that over years have given a sense of stability and coherence. So we all will love to sort of be in our clinics, in the hospitals, work as same we have been doing for a long time, and we don't want change, because change is destabilizing. Change causes stress. Change causes a lot of dynamics to change in your life. And we all want that stability to happen forever, that we want to be in a peaceful environment forever. But that is not the reality in the life. Because life doesn't go smoothly without bumps throughout. And that old habits and old structures, they have been there in our mind. They're quite fixed, and it's very difficult to shake them. If you try to shake them, you feel the unease. But this is what emotional resilience teaches us, to have those sort of structures change, try to think differently, try to behave differently in difficult situations, and then don't lose the coherence around that. Also, it says that our ability to create and reintegrate new structures of thinking and behaving that provide us with a more mature sense of coherence. So this is something that when you especially tested in the crisis times. So the COVID, now did we ever believe that the global meet of alumni or this type of meeting will be happening across the world, thousands of miles apart, will be speaking to each other on the webinars? We are doing clinics. So Dr. Ashok Reddy was saying yesterday that he's doing telephonic consultations for people. Did you ever thought that you will be doing telephonic consultations? We never thought about this. So we have adapted, we have changed to the demands of the crisis. So we have adapted to the new, and we have reintegrated that in our practice. We have changed, and then we are recognizing that it may continue for a very long time. Then further sort of descriptions on the basis of the neurological, neurobiological basis of this. Resilient individuals have staunch view of the reality. So they're very clear and vivid about the reality. They're logical in their interpretations of setbacks. So setbacks when they happen, so things which we didn't go well in the past, how do you proceed with that? Do you think it's negative? Do you think it's really bad, that shouldn't have happened, and you've done a really big mistake? No, you learn from them. You take them, the positives out of those negatives, your failures, where you have not succeeded, then you may change them into a positive. How can I different to last time? So if I fail my exams, if I fail my tests, if I failed some of the patients, how can I learn from that and move on? So resilient people will take all those failures as positives and put the negatives on the downside. They develop realistic optimism, as well as the motivational processes and strategies devised for overcoming life's obstacles. So whenever there is something that has went wrong, they come up with realistic solutions that can be done. It will be challenging. It will not be easy, but they will put this up and then they develop the strategies to remove those obstacles in their way. Now, developing or forming emotional resilience or making yourself more resilient, sometimes people have used it as a negative side. So many management and leadership roles in the hospitals, they will try to implement things on people, say that you were making them more resilient and making you work more. But if you look at it, it is a combination of a number of things. It involves your self-esteem and your self-confidence. It involves how do you regulate yourself emotionally. So in the meetings and in groups, how do you discuss things? How do you agree and disagree? How do you control yourself in that sort of emotionally draining or emotionally challenging environment? How do you control and hold on to things? Having a positive outlook. So I was saying earlier that from the negatives, take the positives out of it. It's again not easy, but that is something you need to develop as part of the emotional resilience. Be not judgmental on things. So we sometimes quickly come to the criticism or criticizing of things. But then instead of doing that, instead of putting blames on people, try to be non-judgmental and look at the problem and provide with the solutions. If you are sitting in a meeting with 10 problems and you are presenting problem after problem after problem, and none of the solution comes out of it, then you become part of the problem. You won't be sort of sitting in a situation where you're having 10 problems, but you don't give a solution to it. So come up with sort of solutions and be non-judgmental, non-critical of individuals and people in that way. Establishing and maintaining relationships with people around you. So when you're working in teams, so especially in the West, and I'm sure in India as well, we all work in teams. So you've got your MDT. So AJ was talking about earlier about his sort of MDTs he has. We all work in the multidisciplinary teams. We've got nurses, we've got doctors, psychologists, physiotherapists, HCA workers, support workers, occupational therapists, so all these social workers. So we have to work with them together. So how do you establish those relationships? So that requires a lot of resilience. That requires breaking the barriers. So people will come with their own ideas and their own thoughts, and you have to sort of deal with them. You can't say that you're going to impose your thoughts and ideas on the system. The system will test you on that, and how much flexibility you demonstrate. And this is where that talked about the mental flexibility. So how much mental flexibility we are demonstrating to be resilient and adapt those changes, and then to persevere on things, not to leave them because of setbacks, not to say that I can't move on because I've been failed. I failed last time. I will definitely fail now. That is not the way with the resilient people. Resilient people will persevere on things. They will start to sort of look at the setbacks and then take the positives out of it and start to grow more. There is a close relationship of the stress and the resilience. Now, all of us, we can say for sure, we go through the traumatic events. So we read in the psychological concepts when children are born, right from the birth, there are challenges, there are trauma that people face. And from the trauma, what comes out is actual stress that is causing problems, that is causing depression to people, that is causing anxiety to people, that causes other emotionally sort of disturbing conditions to people. But there is something which is actual stress, and there is something which is perceived stress. That is all in the mind. And you need to distinguish between that actual stress that is challenging you and that perceived stress. You are thinking that there's a lot of stress, and you manage that. So how do you manage that? To remove that perceived stress out of the frame. So this happened to the COVID. Everybody is in the COVID. So it's just not me who is suffering or going through. Somebody has lost their loved one. Somebody has lost their friends, families. I've known people who have lost both parents, and all the family have suffered in the ICU through COVID, and everybody will know that. So most of you would have seen or known people who have unfortunately passed away, or their friends and family have suffered significantly due to COVID. So you manage that bit of the perceived stress and take it out, avoiding all of the time the all or none phenomena. So either it's going to be there or not. Either all is going to be doom and gloom, or all is going to be sort of quite flowery. It doesn't happen. And again, life is not like that. It's not all or none. It's also gray area. It's not black and white. It's also gray area that comes under. And by having this sort of stress, actual and perceived stress, and you manage them and remove those sort of negativity from that, and then have gray areas, can see the shades of different grays in your life, and that's how you develop emotional resilience. How does the brain react? So, I mean, all as postgraduate students and in medical school, you've all studied how the amygdala responds and what is the sort of cerebral hemisphere's response to this. So, example, how the cerebral response will be there is you might worry about what might happen. So that is something perceived, that future is uncertain. There is a threat. When there is future, can you know what is going to happen next year with the COVID? Do I know? Do you know? Does anybody know that COVID is going to go away? Is vaccine the answer? Is herd immunity the answer? There are a lot of these questions which are uncertain, you don't know. And that brings about a threat of uncertainty. And when people react, they become anxious and they become quite restless about that. You start to ruminate about this, excessive rumination about those thoughts of those uncertainty, because you're not very clear, you don't know the future. And that's why you start to ruminate on that. And towards the end, people start to catastrophize. that everything is not working. Things are going really bad and things can't improve, things can't work. And that's how you just become doom and gloom at that time. The response to the amygdala, as we have seen in the medical school right from the beginning, the fight, flight, and the freeze response. So we've known this, that people sort of become quite emotionally reactive to things and talk about sort of the positives and negatives, but concentrating more on negatives. And that will create intense anxiety. And you see in the physical appearance of anxiety, sort of tremors, shaking, sweating, palpitations, and feeling of dizziness and feelings of passing away. So all these sort of the fight, flight, and the freeze response will be caused in those stressful and anxiety-provoking situations. And that is because of that threat people perceive of the future they don't know. So why we talk about that is to regulate this. And the part of the emotional resilience, to develop emotional resilience, is to control, or to say, to develop how you regulate yourself emotionally in that. So you've seen there are 3 basic and simple concepts. And as I said in the beginning, for the psychiatrist, for the psychologist, it's a very, very easy area. It's in our area. It's our remit. We need to take control of this because we can think about these things very clearly. Nobody else can think about this. Cognitions, the way we think. This is what we've read in the Kaplan set of textbooks of psychiatry. Oxford teaches about these sort of things. A lot of psychological concepts. Cognition, the way we think. Perception, the way we analyze and evaluate things. And then we act. And this is very, very simple. 3 spheres: cognitions, perceptions, and actions. And we need to take control of each of them. Now, emotional resilience develops by sort of following aspects of this. So we'll just talk about a minute or so. Now, our thoughts influence our actions, and this is all we know. So our cognitions are the top. They will influence what we do. If we are able to acknowledge that actual stress, so early on I talked about the actual and the perceived stress. So if we acknowledge that actual stress and willing to effectively cope with it, so you understand that yes, there is a threat which is an unknown threat. I don't want to catastrophize myself on that, but I would like to know that yes, there is something which is uncertain. I accept it in myself. By cognitively, I accept it, that there is going to be an uncertainty, and I'm not going to catastrophize on that. That is your effective way of dealing. Your maladaptive way of dealing would be putting a negative slide on that. And that will be, there is no vaccine. Maybe the next vaccine will not come. Maybe the vaccine will not work. Maybe the future is going to be quite gloom. There are thousands of people are going to die. But you can't do much about it. What you can do about is to understand your actual and perceived stress and deal with it effectively. Then trying to be flexible. And that is where, as I said earlier, that is where the resilience comes about. When you are adaptable, when you are flexible to change with the new ideas. So as I said early on, I never thought that I'll be doing my clinics remotely on the telephone. And we have to see people face to face. But now we are in the situation that we are seeing our most patients on the telephones. We are not seeing them. We're talking to them on phones. Sometimes we're using a video technology. But your way of your adaptation should be, can I use more video now? What can I do about the Wi-Fi situation? What can I do to help people to develop a cheaper Wi-Fi solutions? So we should be in that position to think in that positive and progressive way, to be flexible. And then also that we need to accept the truth that by changing the way we react to stress, a lot of difference can be made. So we can say that, oh, everything is doom and gloom, nothing can happen. But if you think slightly differently, positively, if I do a small change, maybe instead of shutting down the clinic, I start telephonic consultation. So one way is that I don't want to do the clinic because it's COVID all around. I don't want to transmit COVID or get COVID. That's fine. But can I do telephonic consultations? Can I do online help? Can I develop a online program, which I can provide solutions to people? Can I do webinars or educating the GPs? So my colleagues who are actually frontline, can I give them some emotional support to them as a psychiatrist, as a psychologist? Can I provide that sort of frontline support to my coworkers, to my medical fraternity who is facing the brunt of the COVID or the floods? So thinking about those sort of things, that's how your resilience and your development will come about. And then having self-compassion and empathy. not to self-criticize or not to criticize other people, being non-judgmental. Again, that is part of developing emotional resilience. So being empathetic towards it. And this is, I think we as psychiatrists are very good at. So standing in other people's shoes to know what they're going through. So we can do best the compassion and the empathy. This slide just talks about really what the I must say the essence of the talk for all of you today, and that is we've got two circles. One is a circle of influence, and one is a circle of concern. A circle of influence is my remit as Farooq, as Dr. Ashok Reddy, as Dr. Krishan, what I can do. So I can look after myself, look after my family, look after my clinic, look after my colleagues, my friends, my immediate circle. That is in my remit. That is in the gift I can do something about. But then there is a bigger sphere of area of concern. An area of concern is the worried well. So what happens in the world? So across the world, who will win America's elections? Will Trump win or Joe Biden will? Will the vaccine come about? Will there'll be a sort of a cure next time? So if somebody getting admitted with COVID, will there be a cure for that or not? It's a bigger circle of concern. And what happens most of the time is we talk about and we discuss about the area of concern, and we forget about the area of influence. So we talk about the international issues, international problems. They are very important. They are good to talk about and raise awareness. But am I neglecting my area of influence? Because my energy is limited. My work, my time is quite limited. So can I utilize that in putting my efforts into area of influence, where I can have some impact on my clinic, have an impact on my MDT, my members of my team, I can support them, I can help them. But if I'm concerned about the bigger area of concern, then maybe I'll be neglecting the area of influence. So that is something to keep in mind. With another example on this, again, self-regulation. That area of influence, things I can control and will focus on. So there is an example here. So I've got a lot of sort of pressure put on the system in terms of what the PCNs are doing, what the sort of local authorities are doing. So, but what is in my remit, in my gift to solve? Am I going to solve the whole problem of the NHS? No, I will be looking after at my small group of patients, which I'm responsible for, and working towards that. An area of concern, example, is COVID. It's a huge thing. It's an international problem. It is a problem which we have to talk about and discuss about, but not to overtake you, that you forget about your area of influence, where you could have done a huge amount of benefit to people. About the positive and negatives, I don't have to teach you. All of you are well aware of this sort of the negative slants they put on things, but try to think about alternative thoughts on that. So this shall never pass. This is going to stay with us, COVID, forever. We have seen worse things. We have seen the Spanish flu. We have seen the influenza pandemic. We have seen the Ebola virus. We have seen the HIV and AIDS crisis. This is another crisis that will and should pass away. I'm losing hold on my life. Can you take back control? Can you try to take back control? I can never move on. Maybe I should give it a time. So just thinking about some alternate ways of thinking. I won't be able to adjust here. It's a new environment. I've moved in. I've gone to a different place, a crisis situation. Let me be friends with some people and try to see whether it will change. Better to stay quiet, because if I say something, people will start judging me. That's fine. Let me give it a try and see what happens. So these are just flexible attitudes in your mindset, in your mental structures. Some of the features of the emotionally resilient people, these people are aware of their thoughts, their emotions, and what inner potentials they've got. When they react, they're not very reactionary. They think before reacting. So you say something, I bounce you back with a very strong argument on that. No, these people are very balanced, calculated, and think a lot before they react. They're patient. They understand the matters, and they're willing to adapt. So a new proposal has been put forward in front of you. No, this is not going to happen. That's a negative attitude towards it. What is the proposal? What does it talk about? What are the pros and cons of that? So, and we're willing to adapt that if it's good for us. They're high on acceptance and forgiveness. Again, that compassion and that empathy will come into the emotionally resilient people, that they are high on accepting people with the deficits they've got. They are forgiving. They give in, and in the sense that they don't want to hold grudges against people. Focus on finding solutions rather than problems. As I said before, in a meeting, you have got 10 problems. That's fine. But have you got a single solution for that? If you don't come up with the solutions, in many meetings, I do that to people. So when I'm chairing the meetings, I'll tell them that bring problems, but bring at least one solution with you, so that it's good or bad, we can talk about it, but always bring some solutions with that. And expressing emotions. This is something which we all have to learn and adapt. How do you express a discontent, a disagreement, where your idea and your thought is very different in a socially acceptable fashion? So we all work differently. We all have different attitudes and perception of doing things. But how do we put that forward to people in a very socially acceptable manner that the conversation can go on? It's not that I'm going to say something today and there is a blocked conversation. You can't speak to the person again. And then again, always bottling up negative emotions will never help, because when you spurt out, when you talk about, all that negativity is going to come out. So try to have some mechanism where you don't bottle up things. When there are negatives, think about what can be better, can be done better, or can be done differently, rather than sort of blurting out all the negatives in one meeting. These people are able to create and sustain long-term relationships. As we see with a lot of people, I mean, we talk about the borderline personality disorders, we talk about the emotionally unstable personality disorders in which they can't maintain relationships. So emotionally resilient people, they will have that sort of way or mechanism or method to have good and sustained relationship for a long time. And they're not ashamed to ask help. And this is another thing. When initially, when I was trying to deal with situations in the UK, when I came from India, I was always would say that, okay, I shouldn't be saying no to things, because I should be knowing everything. I'm the doctor, I'm the consultant here, so I should be knowing everything when people ask me questions. That is an attitude which lead you to the pitfalls. So the best way to do it is, if you don't know, just say don't know. Learn from one of the consultants I was working with, and I asked him a question about sertraline, and that I thought a very basic, simple question, and he said, "Farooq, you know what? I don't know, and this is the book. Can you read and come back to me and tell me what it is?" So this is the way sometimes you ask for help. When you don't know, you just say you don't know. Believe in sorting out conflicts through discussions, to conversations, to communications, rather than putting a blunt presentation. Now, some of the unhelpful styles of thinking, again, I said to you, most of us are aware of this all or nothing phenomenon. When jumping to conclusions, being judgmental on people, labeling or criticizing the systems or people all the time, and disqualifying the positives. So if you hear or get something positive from people, start to sort of blame or sort of have that sort of culture. Use of should and must. I must do this. I must complete this. No, there is a bit of an area where you may have to put things down for a later date. Nothing good ever happens to me. So always generalization, overgeneralization. Every time it's negative on me, I can't learn from that. Oh, it's a complete disaster. Catastrophizing yourself, trying to sort of minimize things, and then developing and putting on mental filters, like you have seen 30 patients, but the one patient you were not able to see, oh my God, I failed the patient, or I failed the system, I couldn't do that. You are hardworking, so give some positives to you as well. Emotional reasoning. So always trying to remove something. I'm worthless, I'm helpless, I'm hopeless. And we all know the mental state examination, we've learned in our IMH, that this is where you develop this sort of thing, that depression, suicidal tendencies, when you become hopeless and worthless. And then personalization of things. This is all my fault. Or blaming or accusing someone else. This is all your fault. Putting things personally on people. And this is where you sort of destroy relationship. You destroy your own mental structure. And then you jump to conclusion on the systems or people or yourself, and to start to blame because of that. Now, before I sort of conclude, I think put down this mindfulness is something which you would have all heard, and many of you would be practicing as well. It's quite a phenomena in the UK now that people are using this and this is something described as living in the moment. So you just don't pay a lot of attention to your future and what's going to happen, the past, what has happened. You're just living in the moment. So I'm in front of you today, presenting this, looking at you, looking at my slides, seeing people interacting in this presentation. And that's where I pay a kind attention to that. So I don't criticize others, I don't criticize myself, but in the moment, I'm attentive with kind attention and live in the present. And that is easy to say and easy to put up a slide. It's very difficult to do it in the midst of your clinic, in the midst of your crisis. It's very difficult to do that, but try and practice this and teach other people. So teach your colleagues, teach your GPs who are the frontline clinicians working in the difficult times. I think this is where our skills will come in. And to sort of elaborate, just my last slide, just elaborate on how you feel to practice the mindfulness, the undistracted presence, focused presence, and the attention in that moment. So many times, simple things, small things we don't enjoy. So your baby started to walk. That's a milestone. Enjoy that. Your baby has uttered the first letter, first word. Your children, your grandchildren have graduated. They have secured marks in the examinations. Enjoy that in that moment. Be attentive and be clear and aware of things. So be very vivid in description of things in your mind. Be awake and notice things around you. So might be where you're sitting, there might be a sort of beautiful tree of flowers, how they are. I mean, in the busy nature of things, we forget all these things and don't pay attention to this. But these are the things important in being mindful. So, and kindness, again, non-judgmental, not accusing of people, and accepting how people are, accepting how and what they have gone through, accepting in the way they are, not to sort of blame and criticize them. And then relaxing among all these. So be patient, be easygoing on yourself and other people as well, and present there. And one of the things I'll say is the grudges, let go. I think letting go, it's not easy, but if you let go of things, you will really find that peace and that sort of you'll achieve the mindfulness. So I think that's where I'll end, I think, my presentation. There might be some questions. I'll be more than happy to take any questions coming this way. I'll just stop sharing the presentation now, I think. And many thanks all of you for listening.
There was a wonderful presentation from Dr. Farooq Khan. You have elaborated in detail about the topic of resilience, which is very relevant at the moment of time. You have talked about various attributes of resilience very nicely. You have talked about the characters of the resilient person, the 10 commandments. You can just say that characters of a positive person. And you also told about the importance of psychiatrists in improving the resilience of our own medical colleagues now. And even most of the administrations look forward to us to get the help in improving the resilience of our frontline workers now. It's an opportunity actually for us, for psychiatrists, to help the management and get into them. We have to look for this, we have to utilize the advantage now. So with this, I think there are no questions put in the box. I think there are no questions put now. I would request Ramakrishna to make some closing comments or.
Sir, can I come in?
Yeah, please.
Okay. Farooq, excellent presentation, very inspiring talk, especially in an unprecedented state where UK has been going through. I can understand the pain. My question here is with regards to your telephonic interviews and elderly, and with regards to sensory impairment. How did you manage? I mean, I found it very difficult doing some of these interviews within the hospital. And then how did it affect your therapeutic relationships? And has it increased the admissions lately?
Ajay, yeah, really, I think the question is very, very important. We are going through, so we've not sort of, we are into the, if you would know, that Birmingham and also I think north of the UK is sitting in the tertiary lockdown now. So it's a sort of a not a complete lockdown, but tertiary level of the restrictions are there. Birmingham can anytime enter into that phase. We are having about 27,000 cases each day, and the death rate is sort of 250, 350, and yesterday it was 310 patients. Unfortunately, in the UK, they're dying. So these are people dying every day in the UK. So it's very difficult, and we have been talking about the opening of the outpatient clinic gradually, but the problem is we don't want to risk our elderly, because this is where in the initial part of the pandemic in April, May time, we have lost quite chunks of people in the care homes and nursing homes to the pandemic who were 80, 85. We have lost sort of in one nursing homes, we've lost 10 people, we've lost 15 people in one nursing home. So it is very difficult to take a decision to start doing the face-to-face clinics at this juncture. But we are having, so this Friday, I'm having a meeting with all my directorate to just look at how things can be changed or developed. We have talked about the video consultation. Now, you will understand, as you're saying about the telephone sensory input, our patients, 80, 85, 90 years of age, telephonic consultation, video consultation. So how they'll be doing the video consultation, they need to have a family member. The family member here in the UK, they'll be sitting in somebody's Manchester, somebody's London, somebody's Birmingham. All the family is dispersed. They might be living on their own with a spouse who doesn't know the technology. They hardly use the landline phone. So it's difficult for them to have a smartphone with a video link to start. Unless there is a family member there, we are finding it very difficult. So I think you're right, Ajay. I think with the sort of their deafness, with the visual impairments, with even sort of understanding when you are there on the video, sometimes they don't know the person who is there. They've seen you last year and then they just don't remember who you are. So I think it is a challenge, and it is challenging our thoughts every day. So I think as it's talked about sort of changing and adapting, we are looking at the other ways. So one of the places in the UK, what they have done was they've given the iPads. There is an iPad available with a physician, and there is a Wi-Fi connection, Wi-Fi enabled laptop. And then we're going to the home visit, giving the one iPad to the family member, and they're going inside, and the professional is sitting in the car, and they're doing the consultation there. And then once it's finished, wipe and get the laptop, the iPad back. So there are different types of methods in which people are trying to communicate. But I'm finding the same as you've said, that after one consultation, the second consultation, if it is again by the phone, I'm finding it very difficult because I've not seen the patient for almost 8 months, 7-8 months now. So it is, I think it is challenging, and it is challenging all of us in here.
Thank you. Can I ask another controversial question? In the peak of the pandemic, when there was difficulty in getting the ventilators and ICU beds, was there a preference given to the younger adults to get into ICU when compared to the older adults? Was there any discrimination going on into your place?
Yes, so I think I have read about this in the media. So and again, I said in the media, it is I think a sensitive piece of things people have sort of forwarded. It's been on the social media as well. People have forwarded. In Birmingham, we know that in the peak of the pandemic, the majority have been older adults who passed away in the ICU. So we are seeing more lately now that because there are more younger people, 40s and 50s. What you're saying has been an issue with the healthcare workers. So initially the PPEs were not there, but the management has been telling people that, look, you can't ignore patients. You have to go and see these patients. You have to sort of get involved. So I think some of those healthcare workers who have been sort of unfortunately succumbed to this, investigations will reveal in the future that the contribution might have been there with the lack of PPEs at that time. And I think the ventilators, there was a shortage in the beginning. Birmingham and London were on the alert with this big even NEC arena they have booked in with a huge number of 4,000 bed capacity, which was never opened, never used at all because there was no need. We didn't reach that sort of peak. But I think the time will tell, Ajay, in terms of the investigations, those sort of very sensitive issues, if that was the case.
Thank you, Farooq, and good luck. And that was a fantastic presentation. Thank you.
Dr. Farooq, we have received some questions now, a bit late now. One is from Dr. Sanjay. Do you need psychiatrists need a break from work on a regular basis? This is one. And another question is from Dr. Vyasa. Many thanks for a nice presentation. Can you please comment on how the ability to work on the area of influence got used by a team, and how did it work?
Okay, so Sanjay, thanks. Yeah, Sanjay, regarding your comment, I think. Sorry, Dr. Ashok, can you just repeat Sanjay's question?
Yeah, the first one, shall I repeat?
Yeah, first one.
Yeah, do you need psychiatrists need a break from work on a regular basis?
Okay, yeah, that's fine. Yeah, that's fine. I think Sanjay, we do have, so here obviously we'll get a leave which has got quite, I think NHS in the UK has got, it's a government job, and then we get annual leave. It is a 30, 32, 34 days depending on your seniority, protected leave which is there, you'll have. So I think definitely you need, and then in the day as well, I think there are breaks that needs to be taken. Now as you go on to develop your career and you take up the responsibilities more and more, I find it is very difficult to find time in between. So there used to be lunch break before, there used to be you used to go out for tea 15 minutes or so. That doesn't happen. Everything happens in the time. So it's very important. I think we all as psychiatrists should and must take breaks in your work. So you've seen, and in India, I know that you might be seeing 15, 20 patients in a go. And that's quite a big volume. Here, I think in the morning session, I'll see 4 or 5 patients, and in the evening, I might see 2 or 3 patients. And that's my day. If it's a very busy day, it'll be 10 patients the whole day. But I know in Indian context, you might be seeing 15, 20, 30 sometimes, and even more if people are busy. So you need to take a break because you need your thinking time. And you know, the driver for us in many times in Indian context is the medication. But for the families, as Dr. Gauri Devi and Ajay was talking earlier on about the more comprehensive psychological work around them, more comprehensive psychoeducation of the families, the expressed emotions and the work on that, we are not able to do it because we don't have time. But medications are not just the answers. We need that comprehensive workup of the patients. And I think I also feel that we sometimes ignore ourselves. So we think that, okay, that's fine, this is my patient, one after the other, you see. But then for planning for that individual patient, you need a mental plan to yourself that this patient is different from the previous one, the one which is different from the next patient. So you need a different plan for that patient, even if it's got psychosis, both of them got schizophrenia, but you need that your mental space to prepare and plan yourself. So those breaks will definitely are needed, I think. And I think next question, Dr. Ashok, is from Vyasa.
Yeah,
and I can see that. Yeah. So commenting on how the ability to work on the area of influence got used by a team and how did it work. So I think the in the situations where we have been working in Birmingham, we had sort of initial days of our pandemic was significant. We have to quickly change our practices. We had been in the lockdown immediately in the first part of the pandemic, and the problem is a lot of people have their own sort of ideas and thoughts how things can be done. But most of them, if you look at them, they're talking about what will happen about the vaccine, what will happen about the future deaths and how many people are dying on a regular basis. They're very important. But then how you can do it locally. So what we thought was to start within our local teams in our own MDTs, how we can adapt. So immediately we have transferred to the MS teams, which I think I'm sure everyone has done in the same way. But then we started to have some packages for the care homes and nursing homes, what we can do. So we have developed small packages for the nursing homes about the mindfulness, about the sort of resilient activities, making sure the staff members in the nursing homes and care homes are provided some helpful material so that they can look after their patients. So it has helped the MDT in terms of looking into different areas and new areas of work, which they were never used to before. So we had an incident in which my trainee rang the care home, and they said that the staff member started to break down. She started to be in tears. She was crying. She said that we have been left. There was no support to us. So we started from our psychology team. We started to support to the care homes in terms of the telephonic consultations and providing that sort of input to support the staff members there, so that they're losing 10s, 15s of their patients in a go. So all of them they have been looking after yesterday, they've all passed away because they succumb to COVID. And these type of things, I think they've helped to build up those teams. That you'll always find challenges, I think, in the system, which we all will have to deal with that some people will say about the negativity, being judgmental, being critical about your opinions and thoughts. But then you have that focus and the direction, take account into what they have been saying, what they're feeding back, and then move on with your sort of developmental and progressive thoughts.
I think the one question from Dr. Raghuram Reddy, which is not very clear, I think sir has to again reframe and ask, how does it work for more rigid personalities and personality disorders? I'm not clear about MDT or what it is. I'm not very clear.
I think I can. But regarding the personality disorders, I think I can understand Dr. Raghuram Reddy. It's very difficult. It may be people may find it very difficult to do it because we're talking about the disorder. You mentioned about the rigid personality, so I'll take that as a personality trait. So I would say that all of us are formed by a set of personality traits. So I might have some paranoid, some obsessive, some antisocial, some dependent, anxious, a combination of that, and one of them will be slightly predominant in my my personality. So it is same with everyone. We are a culmination of number of different personalities, and that's how we are formed. Now the issue, how you change them, is that sort of training and teaching of this mental flexibility to people, talking about that what to look this in a different perspective. So if some proposal is there, you've put forward and somebody has shot it down to say that, okay, is there a different way of looking at it? So how would we just have a discussion? Ajay's question was there, that is finding it very difficult to do telephonic consultation because he's not seen the patient, and same with me. But what is the other alternatives? Can we up it to make it video consultation? Can we talk about providing more sort of Wi-Fi type of cheaper Wi-Fi options to the patients? Is it possible to discuss with sort of the telephone companies who provide these sort of services? Is that an option? So looking at different ways of addressing something, and it is very difficult. People hold their views very strongly because of the personality traits. Some people are very obsessive and sarcastic, and they don't want to. Their mental structure is quite rigid, and that's where you need that sort of discussions and that sort of facilitation of those discussions to have that different. So, and also putting forward the options. So telephonic options, video consultation options, this iPad options. So all these are options. So discussing with them about these proposals. These are proposals we're discussing. This is not, you're not putting your own mind there. And again, we can come across as different to different people. So I might come across as very forceful sometimes, but that is my way of putting things forward. But I'll be flexible to adapt the ideas other people are suggesting me. So I think this will not be an easy answer to say that the rigid personalities will change quickly or immediately, but it is with the way of discussions and with the way of sort of facilitated discussions and providing number of options to them, you can break into those.
There's one more question from Dr. Jagdish. My question is, what is the neurobiology of selection of positive thoughts, which is highly selective in various ways? This is a question from Dr. Jagdish from Warangal.
Yeah, Dr. Jagdish, yeah, I think the main areas you're talking about the cerebral hemisphere and the amygdala. So I think your reward centers, your limbic system, where you get that sort of positive vibe and your drive, that's come from there, and always thinking about the positive side of things. So as I said to you, the failures and setbacks, for example. So it did happen to me when I came to the UK. It was with a lot of my other friends as well who have been in the UK and other places. There is a big change in the practice and the culture of practice. So the way we have worked in India is a consultant-led practice. So so if you're doing a private practice, you are on your own. There is nobody else who is there to support. So everything, all the calls will come to you. You are responsible. And then adapting that in the UK concept, where there is multidisciplinary team. You've got a psychologist, you've got an OT, you've got a physio, you've got an HCA, the social worker, and they will all challenge you. So when initially I started to do the meetings in these sort of big MDTs, for me, it took some time to adapt that system. But if I didn't adapt myself in there, I wouldn't fit in the UK. I wouldn't be able to work because it's a more of a comprehensive type of work. My patient is not my patient. It is our patient. It's all of our patients. So that patient, if I say that my patient, a psychologist may challenge you. No, it's not your patient, it's our patient. So, yeah, that's fine. It's our patient. Yes, you're right. I'm doing my bit. You're doing your bit. I respect and you respect each other. So I think in doing that sort of when you talk about the sort of the positives, I think I would say that even the negative side of things, even if you've failed, and this will be very important for all of us, I think, even if you failed miserably, just think about, and I've got an example in front of me, but it's quite a bit. It'll take time, so I don't want to share that now. But I've got a recent example in which I've learned still today and will continue to learn from the things which I think were setback for me. But I've picked that up, and how we do it is. There was a situation. I mean, I'll just briefly tell Dr. Ashok Reddy, if you allow me, just 2 minutes. There was a situation in which we were in, where one of our wards, part of it was converted into a COVID ward, in which the new patients who were coming, we don't know whether they've got the COVID or not for the investigations. They were kept there briefly in there, and then that decision was made by the management, and some of the consultants were not part of the decision. And it was a very sort of tough time for us to accept that decision without we being part of it. And then I just really felt that I've been sort of neglected, or I've been sort of sidetracked. My consultant team has not been consulted. And it felt a lot of distaste in the medical fraternity. But then immediately, we got around that and we said that, okay, we need to have a big meeting. We need to get back together with sort of this plan, because we are an MDT. So you have to bite the bullet. When we say you bite the bullet and then say that, no, I will come back on this. And then now 5 months down the line, we are working again back as an MDT. So if I leave if I just continue to have that sort of disgruntled approach to say that, oh, I have not been consulted. No, we need to move on. This is a crisis situation. Decisions have been made in difficult circumstances. And then I accept and I forgive and I move on. And that's the way I think you work on.
I think there's a comment that Raghuram Reddy wants to make the question live, I think. Sir, would you like to ask the question personally? That Raghuram Reddy, sir? I think he's not audible. Okay. There's a...
Am I audible?
Yes, sir. Yes, sir. Please continue.
Yes, sir.
What I meant is it was an excellent presentation by Dr. Farooq, very extensive. All the factors have been taken, and it's a very meticulous study. They are all concepts. How they can be reduced into practice will depend upon how will we meet people and conduct it. Something like CBT has an excellent way of patient study and things like that. It is excellent. Ideas are very good. They may even look moralistic. They are not. They are psychological, I agree. But each one of them will have to be worked out, a kind of a workshop for quite a number of factors to come out how to deal with they're all end things. They're all very good end products, but how to navigate them through the workforce, individuals, will be quite a tough job, but it is worthwhile taking up, and at least taking up a few aspects which are particularly rational to that individual, that workforce, etc. I congratulate Dr. Farooq for the extensive presentation. Thank you.
Two of the delegates have raised their hands. I think that Sairam wants to raise a question. That Sairam, probably you can ask the question. And Sri Naveen. You can ask the question. You are able to unmute your mics or not? If not, organizers have to unmute the mics of the delegates. Hello? Dr. Sairam, are you able to unmute and ask the question? Okay, I think probably organizers have muted the mics and they're not able to ask the questions. I think even we are overshooting the time, we are going to enter other times also.
Yeah.
I think we'll request Dr. Ramakrishna Garu to make the final concluding words and then we'll close it.
Yeah, thank you. Thank you. At the outset, sorry for the delay in attending, Farooq. I may be excused because I joined a little late. Sorry, Dr. Farooq. And I must thank the organizers for inviting me for this chairing the session. And the topic which Dr. Farooq has delivered is very relevant for the today this situation in the entire world where we are all facing so many problems, and this is very relevant. And as if when you are delivering the speech, I went into little in so many stage, hypnotic stage. Probably your talk, your voice, everything is just like that. I think one of the callers commented that you are a guru. so I think that, and my question is, there are so many problems, to COVID, either physical or psychological and all these things. When you want to intervene as a psychiatrist, there will be resistance in the community because they don't like psychiatrists to be examined in the community level. So you have to do some sort of psycho education or some sort of informal meetings with the public and taking the help of other people like elders or religious leaders and other things, so that fear goes off, and that depressive spell which is going to occur like that may also disappear after talking to the, because by this hospitalization or all these things may again produce depression. So number one is whether directly psychiatrist can intervene or only the mental health specialist or non-psychiatrist specialist or nurses or like that. Will they take over instead of psychiatrist to intervene, because there is a stigma that they may not like to get examined by psychiatrists. That is one thing. And another thing is, do you think that you can give advancedly, because we know that this month we are getting the floods. This month we are getting, already the government has got that. So do you suggest to take some precautionary measures, the preventive aspects? Okay. So these things, I think with these things, I want to conclude. Thank you very much. And I think Farooq can tell a few words about it and then close it. Thank you.
Yeah, no, thanks. I think thanks, Dr. Ramakrishna. I think the last point you mentioned about the flood situation, that was COVID situation before, and now there's flood situation we're in. I would say that I think our influence in terms of the informing the governments. So what is our role as psychiatrists and the leaders in the mental health, I must say. So how the government is looking at the policies of the controlling the cyclone, people who are affected with the cyclone. Everything has been lost with some people. Some people have completely, all the day-to-day activities have been lost. Charities are providing that input. Are we looking on the trauma side of things now? Yeah. The mental health trauma, whether they will be having sort of in the future PTSD. So are we informing? So we need to have that sort of through the IMH or through our resources we've got into the government, we need to approach that, whether there is a strategic view on this, so that people have got COVID pandemic and immediately has been hit really badly by the cyclones. So what is the package government wants to give? So in their policies, whether there'll be some sort of help and some sort of a strategy about the mental health side of things. And then we can influence the government by proposing ideas. Might not be taken, everything might not be taken, they might not be able to do it, but are we doing that through the health ministry? Are we trying to sort of push the sort of the mental health on the driving seat, that to say that in 6 months, 1 year down the line, we will see a lot of PTSDs maybe, we will see a lot of depression growing out of it. The financial and economic crisis that will impact people's livelihood will be coming in forms of suicide, unfortunately. So are we having some sort of strategy through the government? Are we proposing that? So I think maybe as an alumni or maybe as an independent body or through the sort of Indian Psychiatric Society, something needs to be proposed, I think, locally within sort of the Telangana government through the health ministry, that can these sort of things will be taken into account, that mental health is not neglected and put on the forefront.
Yeah, thank you. Thank you very much. Ashok Reddy, can we close?
Yes, sir. We'll close the session.
Yeah. We'll close. I
Thank
think
you.
our thanks to organizers.
Thank you, sir. Thank you for the wonderful presentation. So there is a small announcement now, like we have to now change our Zoom ID, sir. Basically, after this academic session, we are going to have a get-together networking program. As it is interactive program, so we are going to change the Zoom ID, sir. Zoom ID is already been sent to mails and WhatsApp group, and then even that is there in the chat box, sir. All panelists and attendees can check it in the chat box. The link is there. You can directly connect to that link, sir. So I request everyone to switch over their Zoom ID, Zoom link, and switch over to the other part. 10 minutes will take and start the next program, that is Get Together and Networking, sir, which is an interactive program. Everyone will be interacting.
So we'll have online tea now.
That's true.
Online tea and biscuits.
Only online.
Okay. So are we joining back in 10 minutes now?
Yes, sir. Thank you, sir. Join back in 10 minutes, sir. Yes, sir. Thank you so much. Any other queries, sir, you can all contact us, any of us, organizers.
Shiva, okay.
WhatsApp చేస్తాను సార్, ఒకసారి వాట్సాప్ లో లింక్ జాయిన్ అవ్వండి సార్.
వాట్సాప్
వాట్సాప్ లో ఉంది సార్, కొత్త లింక్ జాయిన్ అవ్వండి సార్.
ఓకే ఓకే.
థ్యాంక్ యూ సార్. 245 సార్ లింక్. ఆల్ని అట్లా దాంట్లో గెట్ టుగెదర్ నెట్వర్కింగ్ అని ఉంటుంది సార్ లింక్, అందులో జాయిన్.
చూస్తాం.
థ్యాంక్ యూ సార్.
Shiva, can we change the all audience by technical people? Is it not possible?
They told, even I spoke with Satish also, sir, from Sun. Not possible, sir. We need to switch over. I send everyone the link, sir, in WhatsApp and then in the groups also, sir.
రాలేదయ్యా
సార్ పంపించాను సార్, రామకృష్ణ సార్. మళ్ళీ పంపిస్తాను సార్, మళ్ళీ ఒకసారి. ఓకే
మరి ఇక్కడ నా దాంట్లో వాట్సాప్ లో లేదు, నీ పేరు ఇంతకుముందు ఉండే.
ఇప్పుడే పంపిస్తాం సార్, మళ్ళీ
పంపించండి.
థ్యాంక్ యూ సార్. అందరికి వచ్చాయి సార్, కొంతమంది మిస్ అయితే మళ్ళీ పంపిస్తాం సార్.
పంపించు. ఇక్కడ మార్నింగ్ ఉందంటే 8:50
పంపిస్తున్నాం సార్. 1 minute.
ఓకే.
థ్యాంక్ యూ సార్.
థ్యాంక్ యూ.